sector position, a lot of times that company pays for those supervisory hours, which can be about $5,000 to $10,000 a year for a couple of years. But for individuals that go to work in the local mental health authorities or at HHSC or in other places, they're having to pay for that out of pocket. And so there's ways that if we had some dollars available to pay for that for them, basically develop a network using our health-related institutions to provide that supervisory support for them for free, that would be a way to be able to bring individuals along quicker so they can get into the jobs that we need them to be in. A second component of that is that they have to have the training under a supervisor, and right now there's a wait list to get people in under one of those supervisors so they can complete their training. We think we can use our HRIs or other entities, local mental health authorities, other individuals, and be able to train up those supervisors so that they can address that pipeline issue and bring more individuals into the service. Senator Nichols, I think one strategy may be to look at the licensing boards and ask them to see if there's ways that we can streamline the pipeline to get folks here, including the ability to bring people in quicker from out of state, and what we need to do related to honoring their license in another state to bring them in so they can serve in the state of Texas. We are looking at some of our academic institutions related to a couple of different varieties of their residency programs, so you can become triple boarded quicker, and so you can get online as a physician, psychiatrist, child psychiatrist quicker, and what it's going to take for us to stand up those programs at a couple of our institutions. And then I think a recurring theme is that the programs that you've asked us to do are going to be, is only going to be successful if the other pieces of the mental health system in Texas are functioning where they need to be. And we have a major challenge, I think, with our local mental health authorities that are doing God's work and doing the best job they can, but are really struggling to retain and hire the people that they need to do their day in and day out work. And so I think we need to work with them, and how do we secure that workforce base that really is essential for the state of Texas.
Okay, let me open it up for questions.
Yes, sir.
Now. Before I do the questions, I know Senator Zaffary, who was first, Senator Colcourse was second, but I'd like to get the clerk to call a row so we can establish a quorum.
Nichols.
Here.
Creighton. Colcourse.
Here.
Betancourt. Birdwell.
Present.
Campbell.
Present.
Hinojosa. Hughes. Perry. West. Zaffarini.
Present.
Okay, quorum's present. So, Senator Zaffarini, I'd like you to ask first.
Thank you, Mr. Chairman. Thank you for your testimony. It was excellent, and this handout certainly was excellent. But I could see you making this presentation not only to this group, but specifically to the Finance Committee and to the Health and Human Services Committees of the Senate. But going back to your page, your last page, specifically your last page of your handout, if we were to adopt or recommend or fund these strategies as a legislature, what impact would it have on the task we have at hand, which is to protect all Texans and most specifically the students and teachers and staff in our school?
Well, thank you, Senator Zaffarini. I think it would have a significant impact on your ability to provide the services to protect all children in the state of Texas. I think if we don't have the workforce there to provide the counseling services to our kids in the schools, we're not going to be able to identify issues early, provide them the counseling they need, the services that they need to get them on the path that they need. And so this may be a little bit of a longer-term strategy related to the mental health system, but I think it's essential if we want to be able to meet the needs that kids have in the state of Texas. There's some families that have the resources and can get into services in the state of Texas. A lot of kids don't, and a lot of kids don't have the ability to, or the parents don't have ability to go to Baylor or one of the other HRIs, travel 2 hours to get mental health services in the state. And that's what these programs do, is try to, because of the shortages we have, equip the providers that we have across the state of Texas so they can provide those services, and then use technology to bring those kids in, so that if there's a child in need of of services quickly, and that teachers are saying something's not going on right here with this child, and we need to get some professionals to help provide those services, that you can get those services no matter where you are in the state of Texas.
And long-term solutions to our problems and challenges certainly are important, but does your consortium have any strategies or suggestions that would have immediate impact if we were to adopt them?
I think the main thing that we're going to be working on this summer, Senator Zaffarini, is how do we expand these services to make sure that TCHAT services are available throughout the state of Texas. We're at 40%. We are going through, we have a list of schools across the state of Texas that we are in conversations with right now that need to complete the memorandums of understanding so that we can move forward in that. But our goal will be within the next year to make it available to any school that wants that service. And again, and it's making sure the school that wants the service has that available, and then the parents, if they want that service, that this service is available in their school. And so that's what we'll be working on right now. But workforce still comes in, because you can't expand unless we can hire the people and bring the people in to do this work.
Thank you. On your slide 18, I believe it's 18, I'm not sure, but it's the one with a headline, race and ethnicity, the two circles.
Yes.
And of course, you have the race and ethnicity breakdowns for the total population and the students covered in TCHAT. If you were to look at the shooters in Texas and place them in a third circle, what would that circle look like?
I don't have that chart in front of me. I think we've seen the pictures of individuals that that have committed these heinous crimes. That there have the pictures that I've seen have been more Caucasian individuals, but not exclusively. And so, but I don't have that slide here ready to give to you.
And all male?
What's that?
Male?
And male.
All male?
That's my understanding.
Thank you. And it might be slide 28, the one with the headline, Challenges for Further TCHAT Expansion. And you have challenges in two areas, implementation and timing. Looking specifically at the implementation challenges, how do we overcome them?
How do we overcome the implementation challenges?
Yes.
With TCHAT, I think we just keep at it. You know, we keep working in the communities. We keep making our psychiatrists, our teams available to the schools, making sure that they feel comfortable with the programs that we're setting up, making sure that they understand that we respect them and their input as we do this. But it's a continual process, Senator, that we work with the communities in order to let them know the services that are available and what we can do to help them if they request that help.
Thank you. Now, we all know that a mental illness diagnosis does not predict violent behavior. How do we avoid causing a stigma while providing mental health support and services to students with behavioral problems?
Okay. You want to?
I think that's an excellent question. Thank you. The way that I approach that idea is that we really want to help a child with the problems that they're having, and to do that, you need to understand what they are. The more that we can make this be a safe thing to talk about and it's not stigmatized, then that's where we're really going to make the most change there. Walking down the hall and going to the mental health provider should not be seen as something that means you're a bad person or doing something bad. It really means that you're recognizing that there's strength in telling somebody you need help. It's okay to ask, it's okay to say, is really that idea. So I think it's really a public, universal sort of conversation about how we make it okay to talk about mental health.
Thank you.
And Senator, if I may add just a couple of points. I think these programs help address that in a couple of ways. One, so the child doesn't have to take the day off to go see a psychiatrist 2 hours away, and mom and dad have to explain why they had to take their kid out of school. The ability to do these services through telehealth and in the comfort of their home if they want. And so, again, allows them to incorporate that into their daily life schedule. And we're also working, again, with HHSC and others related to some educational programs. There's a youth access mental health program, and there's mental health first aid, which I know you're very aware of, that is trying to address those issues and make sure kids understand the connection with the mind and the body, and that sometimes you need to ask for help, and that's all right.
Assuming that telemedicine was certainly one strategy for improving and expanding mental health services in rural areas, what are our other strategies, specifically for rural health areas, for rural areas?
So, Senator, I think telehealth is important, but I think also growing your own workforce in the communities in which you reside is important. And Tyler, Senator Nichols, we talked about the new residency program that's been established, that there's also a component of that that's in a rural part of East Texas. And so you have physicians training in a rural area and figure out that it's nice to live in those areas and that you can have a complete life and satisfaction and job satisfaction with the support you need. I think also providing, Senator Zaffarini, the support to those primary care providers that have decided to live in those rural areas. A lot of times a physician doesn't want to leave the big medical center because he doesn't want to be put in a situation where they don't have that team around them that makes them comfortable in caring for those individuals. And so I think that's where CPAN comes in. One of those items that I put there related to workforce is to develop that kind of a statewide, the supervisory capacity for licensed social workers, et cetera, so that we can make sure that those type of training, if there's somebody in a rural area that wants to be able to increase their professional credentials, that we can do that without them moving to an urban area to do that. And so I think those are some of those strategies that we're thinking through to try to make it easier to practice and recruit in these services wherever you live in the state of Texas.
Thank you. Now, Uvalde is not involved in the consortium, correct?
Uvalde has not been a school part of the consortium. We have been involved in the response behind the scenes supporting the local mental health authority, but after the event. But Uvalde had not been, it's not in that 40% of the schools that were part of the consortium.
And 40% of Texas counties are enrolled?
40% of the student body in Texas is currently covered in a school that has TCHAT available.
So if a consortium were in a school where there were a number of students who had been reported to have problems related to animal cruelty and bullying and truancy, what services would persons, professionals associated with a consortium offer for those people?
So the services from the consortium are in these items that I've listed. And so if the counselor thought that, or a teacher thought that the child needed to be seen, they could, after getting consent of the parent, make the referral for us to see the child. And then with parental consent, that child could be enrolled in in one of the TCHAT services that are available. And again, then if they referred to their pediatrician and they had a comfort level with the pediatrician and the pediatrician wanted advice, then they would call us and we would give that pediatrician the support they needed to do this. And the other host that Dr. William talked about, the other host of services that comes with the CPAN of linking individuals to a variety of services in the community. And Dr. Williams, I don't know if you want to expand upon that.
Is it correct? So again, what TCHAT can offer is that a sort of initial assessment and initial care. And if there's definitely felt to be a problem that needs ongoing care, then both CPAN and TCHAT teams, part of our job is to help locate services that could help connect them. Usually when you have a young person dealing with some of the things you talked about, it's a multi-team approach. It's not only seeing a therapist is going to address the issue at hand. So it's really sort of pulling in a team at that point.
If students have been identified with these characteristics, should they be prioritized for mental health services?
I think if there's a child that had shown very aggressive behavior, the bullying behavior, other types, that teachers should recognize that something's not right here. Maybe they don't know exactly what's not right, but then refer for additional support.
And finally, have you addressed the social media and threatening messages posted in social media?
That hasn't been part of our work thus far. I understand how important that is. We do provide some information related to our services and have done some social media there, but kind of blanket social media, we're still kind of developing that. those type of services.
Well, thank you both, and thank you for your succinct answers. I appreciate them.
Thank you.
Mr. Chairman.
All right, Senator Kokorsz and then Senator Hinojosa.
Thank you, Mr. Chairman. Thank you both for the presentation today. I spent the last 2 weeks talking to superintendents in Senate District 18, and it was great to hear so many of them utilizing TChat. And I know that you mentioned that you get 5 consults. One of my superintendents said that y'all have been very willing to go beyond that, and that's great. I had another superintendent who said that in April, seemingly, y'all were overwhelmed, and so you shut the program down. Does that go to the workforce issue?
I'm not sure of that exact situation, but it is part of that workforce issue of needing to, especially if we are tasked
referrals.
If we were tasked to go to the other areas of Texas. One of the things that we are, and Dr. Williams may expand upon this, is figuring out how do we cross-cover a little bit better. And so if there was a issue related to in one part of the state where they needed additional help, figure out how do we share that responsibility with other HRIs that may not have that demand.
So that's a great segue into what I want to talk about in workforce. You spoke a lot about psychiatry, and you spoke very eloquently to the long investment in time that it takes to become a child psychiatrist. Talk to me about other workforce availabilities. I often find in dealing with these superintendents, sometimes they just need a life coach. Mm-hmm. And I was very curious about the licensed social workers, counselors. Do y'all utilize that through TChat? And my question is going to be, because with dealing with all of our superintendents, and we heard it yesterday, and I'm sure you've heard it, members, as you talk to your superintendents, is the need to, not the counselor that helps make your schedule, but the counselor that truly becomes kind of a life coach in those moments where you just need a little help. So the question is, define the different workforce. I see a slide here, but I want to understand that better, because I don't think that we can produce enough psychiatrists quickly enough.
Correct. But there's also workforce shortages for social workers, for licensed professional counselors, for psychologists. They each have a slightly different pathway in order to get their licensure to start providing services. TChat actually does employ both LPCs, those licensed professional counselors, LCSWs, which are LMSWs who've done the additional clinical training to become a therapist, and as well as psychologists. Most of the psychologists that we have in TChat oversee the quality and the service delivery of the LPCs and LCSWs, but they also can provide direct services and assessments.
So I'd like to y'all, not today, but I'd like to dig deeper into that because we're really looking at the workforce issue. I hear that resoundingly.
And Senator, if I may add to that, if you look at that slide that was presented related to the type of services that are provided through TChat, only about 15% end up being seen by the psychiatrist. The other 85% is by these other individuals, part of the workforce that you mentioned.
Great, because I don't want to leap to somebody needing psychotropic drugs, right? No. I mean, like, we don't need to prescribe. I mean, obviously, that's something that it may be at last resort, right? Mm-hmm. Coping skills are a wonderful thing.
Correct.
Okay, so with that, looking at how someone enters in, and then how long does that record? Obviously, there's a lot of discussion in Washington, D.C. I think there was a bill passed by the U.S. Senate last night about certain restrictions on how someone would purchase a gun. How long does this record stay? Is it a part of their permanent record? How do y'all keep that private? Who's accessible to it?
So we have a data management system where this is where you're getting this data from. It's a secure data management system, but the care, because it's health care, not directed at the school, it's health care, they're actually being seen through our hospital affiliates. So they're having a patient record in a hospital system, which is also extremely secure.
Okay, and so it becomes a part of their medical record.
Correct.
Yeah.
Probably electronic health records.
Correct.
And then with that, y'all said it was free services. The question is, and Dr. Lakey, I appreciate your honesty when you say, we probably have some money we can't spend because we can't find the workforce. Talk to me about that spending model. Do y'all pay the people at the HRIs? And then if a child is on Medicaid or CHIP, do you also bill it? How does that work? And how does the program become sustainable, or is it always going to be an expenditure of the legislature? The funding model.
Yeah, right now the funding model is it's GR funds and ARPA funds paying for these individuals. They go out to the health-related institutions, and so they've hired these individuals to be available to provide these services, or a staffing model. They are not, we have not been given the direction to bill. It's made available to anyone regardless of their payer status. And so it doesn't matter if they have Blue Cross Blue Shield or are uninsured.
Y'all don't charge the health insurance. It's literally free, net free.
It's net free. Mm-hmm.
That's interesting and something good to know.
And if I may add also, Senator, these aren't matched dollars right now through Medicaid, and at some point
they are not matched.
They are not matched at this point.
I remember it was really originally Senate Bill 10, Mr. Chairman, and I'll say that for Senator Nelson and her hard work following Santa Fe because of some, the last-minute issues during session. It got folded into Senate Bill 11, but thank goodness, it got passed. So I want to move to, I think Senator Zaffirini mentioned this, the different children, ethnic backgrounds, gender, et cetera. We had a discussion yesterday about some of our IDD population and some behavioral issues there. With all my interviews with superintendents, there was a great discussion of needing more special education funding, the difficulty sometimes with those behavioral issues. Does TCHAT help with special education, or does that move into a different area?
So from the perspective of TCHAT, regardless of maybe a disorder that a child already has, if somebody knows they have an intellectual disability, a neuroatypical or autism spectrum disorder, if they make a referral to our team will generally see that young person, do an assessment, and potentially give recommendations for crafting potentially a long-term plan that would be beyond TCHAT's abilities.
And if I may, Senator, I would add that these programs are not there to replace what you have in the schools. They're there to supplement them and support them. And so the school-based counselors that you have there, you still need those, and especially with IDD. IDD is very complicated. What our role there is to come behind them and support them to give them from our academic health science centers across the state, the support they need and hopefully to be successful.
And so I think a part of the consortium is research. Senate Bill 10 was originally research. How much of your funding goes toward research, and how do you define research? So
right now, right about $10 million of that whole pie goes to research. And basically the research it's not clinical research. It's not bench research. It is two different programs, one looking at depression and one looking at trauma for that kids have had. And before I go through this, there is a firm wall between the clinical programs and this work. We never use the access to the schools or through CPAN or those lists to recruit individuals into these programs. But they work with ERs and hospitals and others when there's been a child that has undergone significant trauma or severe depression. And then through surveys and others means with parental consent, gather information and figure out what happened. Did something happen wrong in the system of care in Texas that led to this event where this child is in the emergency room? And so it's that type of health policy, systems of care research that is taking place right now. We have two, again, at UT Southwestern. They're the lead related to the depression network, and at UT Austin, the lead related to the trauma. Again, when the trauma being a variety of types of trauma that kids have gone through, and again, looking at what has worked and what hasn't with those kids.
We'll discuss that more at a later date. And then, so You mentioned parental involvement, and I'll just describe what one of my superintendents, rural, a superintendent, she said she had 22 students accesses. This is a pretty small school. And they had set up a room where it was very private and that they could go in. It was through Telehealth. And so I found it, really great. But the question is, are those conducted with or without the parents? I wasn't clear on her answer or y'all's.
So a parental consent to start the service. The vast majority of the first appointments include the parent at the appointment itself. If the parent is not at the subsequent appointments, the therapist is talking to the parent outside of the session to say, this is what's going on, this is how I'm helping your child. So the session itself may not always include the parent, but the information about what's going on in the care always says. That's just a standard of care within healthcare.
Okay, excellent. And my final question, my calculation was a third of the districts. You said 40%. Were y'all involved in Uvalde?
So before this, the Uvalde was not a school system that had been part of the TCHAT. It was part of the plans coming out with the ARPA dollars that you provided to expand. Our Health Science Center in San Antonio was in the process of reaching out to Uvalde to include them, but they had not received these services yet. Subsequent to this, there are conversations taking place right now with their leadership at multiple levels on how this could be made available. In addition, the other work in Uvalde that's behind the scenes is that our HRIs have been providing support to the local mental health authority, which had significant vacancies. And it was in that situation where they had significant vacancies and were trying to respond, and were also victims themselves. The local mental health authority is only a block away from the school, and so a very traumatic event for them personally. And so what we are doing here is they needed additional counselors, and we're rotating that responsibility to provide additional counselors between health-related institutions.
Yeah, so you mentioned 17 of the 39 LMHAs were involved, so they would be one that had not.
The local mental health authority had some support, but the school district had not been part.
Okay, excellent. And then I guess this is a question to y'all about what we have learned about the perpetrator is that he was truant off and on since the 5th grade. That was the testimony yesterday. Obviously very truant in the last year and a half, maybe 2 years. That's not clear yet. So TCHAT really could not reach a child as it's set up today if they're truant at school.
I would hope that with what we're looking with TCHAT and going out into the future, that when that child was in 3rd grade and started having initial problems, that somebody would have referred him at that point and got him the counseling and support that he needed earlier in his life. I think at the time that he's truant and no longer in school and there's no access from the school, that'd be hard for us to reach. But it is possible to reach the next person earlier before they progress to that stage.
And I think that's a great statement because I looked on one of your charts here, which the public can't see, but it looks like your services grades 1 through 5 is 26.8% of the services rendered, grades 6 through 8, 35.6%, and grades 9 through 12, 34.6%. Believe it or not, in pre-K, 3%. That makes up your 100%. So well said that y'all are catching children that are having issues. As we hear more testimony, Mr. Chairman and members, truancy is an indicator of a child starting to have trouble. And again, I like what you said. You'd like to think if we could turn back the clock that this child would not have ended up with where he was in a mental status to create such and to act in such a violent and evil way.
If they're not there, we can't help them.
Thank you.
Senator Hinojosa, followed by Senator West.
Thank you, Mr. Chairman. The Child Care Mental Consortium is relatively new, and you still have a lot of challenges to work out and procedures. But one of the purposes was to help identify students who were suicidal, were a danger to themselves, or a danger to others. And I'm looking at one of your charts, and they're not numbered, so I don't know which one it is, but it says reasons for referral, October 2021 to May 2022. But in that chart on the referrals, when you talk about harm to others, you have 0.
I think, Senator Hinojosa, you also look, the third one over is anger, and there's a variety of other ones that I think could help precede that.
The other thing I would say is that this is what the school has identified as the problem. So if they've not identified that, they're not putting that down as the reason for referral.
Okay. Well, and one of the issues, and just to follow up on Senator Colquist, on parental consent, what happens in those situations where the parent refuses to provide consent?
We don't see the child.
Well, that is part of the problem many times in situations that I've seen and I'm familiar with and experience, where the child needs help and counseling, but the parent is the problem. So in those type of situations, you just walk away.
So I wouldn't say we walk away. But I make sure that we run this program per the full direction that the legislature gave us to run this program, which says that we do not see a child unless we get parental consent. And so we can continue to build these programs. We can continue to destigmatize because people get very familiar with these programs and feel more comfortable with that. But the school would need to work through that program. Our legislative direction is very clear that our role is only after parental consent is provided that we can provide these services.
I think at some point we probably need to revisit this issue, only because you have students who are truant, students who are bullies, students that have real serious behavior problems. They beat up on other students, but the parent are disengaged. They're checked out completely. And that is part of the problem many times with a student where the parents are not engaged in their child's education. So we need to find a way to help those students, because I look at that as being one of the key problems. When parents are involved, it's a big plus, and it helps the students because they're trying to help and resolve issues that student may have. But when parents are not involved, this will cause us the problem in the first place, and then we cannot help the student because they don't give consent. So we need to figure out a way how to deal with that issue, because I think it's a very challenging issue.
Yeah, there are quite a few kids that get referred, but we don't get parental consent, and therefore we cannot see those kids.
Yeah, and I see this as a big challenge. The other is, we have always had issues with a health workforce people, from doctors to nurses to psychiatrists. There's always been a shortage. And we have tried different ways and different programs to try to provide incentives to nurses, for example, by helping them pay for their student loans, with doctors by helping them pay for their medical school loans, increasing general medical education funding. And it's really a big challenge for such a large state, so we'll continue facing those challenges. And as I see you working through the process, you still have a lot of challenges and systems and procedures to work out. And one of the biggest ones that I see is just trying to make sure that we identify those students that are or need help and are really a danger to themselves or other students that we have seen again and again that happening. and get feedback from you all, whatever changes may need to be done in the statute to make sure that you're able to accomplish your mission. But thank you very much.
Thank you, sir.
Senator West?
Thank you very much, Mr. Chairman. Thank you very much for the presentation also. There is really no profile, so to speak, of a shooter. Is that correct? School shooter?
I had trouble hearing you, sir.
I'm sorry. There's really no profile that we have of a school shooter. Is that correct? According to the, I think, according to the
As far as my understanding is.
psychologist.
Correct.
Right. Are there commonalities? I mean, given the numerous shootings that we've had across the country and specifically here in Texas, are there some commonalities of these shooters that we should be looking at, like anger, depression, things of that nature?
This is sort of a little bit outside of my expertise, so I...
Okay, that's fine. And there'll probably be other.
I think there'll be others testifying today related to the profile of the individuals, and so I think that'll be discussing that in more detail.
Okay, and so listening to what you're saying, the notes that I've taken, is that we need to look at developing the workforce. In looking at the workforce, is compensation a big issue?
It is an especially big issue for the local mental health authorities related to recruit and retain the people they need to provide these services. And again, look at Uvalde or a variety of other local mental health authorities, they had significant vacancies at the time that this occurred. And if you can't have that basic structure to provide mental health services in Texas,
Right.
it's hard for these other supplemental services to be as effective as they need to be.
And so there's a lot of that tied to starting wages, starting salaries, and things of that nature?
I think that's part of it, sir.
Okay. Is there any way that you can give us an idea of the unmet need out here for services?
Unmet need?
Yes. You may or may not be able to quantify it.
I have some information. If there's unmet need related to workforce, the HRSA, federal agencies, and others, and Department of State Health Services puts together maps across the state of Texas, county by county, for a variety of these critical professions. I actually have some of that information here that I can give you following the testimony related to what those resources are needed. But, and again, I think the Texas Council will be testifying later, but what I hear is sometimes up to 30% or more vacancy rates in those facilities. And so that's an example of the need that's out there.
Okay. I want to go back to a question that was asked by Senator Colcourse as it relates to how the persons that provide assistance to the providers under that system and also through the T-chat, all right? Explain the compensation model for those persons that are providing those services again.
So they're employees of the health-related institutions. So their salaries are set by, in order to be equitable across each HRI. LCSW's salary is set at whatever they say that HRI's salary is, usually the midpoint of the salary.
Okay, so through the HRIs. So the HRIs, as part of the monies that they're receiving through the consortium, are putting in place the compensation model. Now, help me with this, David. I know that under Senator Nelson's leadership, I think we put in, what was about $100 million or $200 million?
In the first legislative session, you put in $99 million. This last legislative session, you put in $118 million for the biennium, and then during the special session, you put in $113 million.
So totally, that's over $300 million.
That's over that full, over 2 biennium time period.
Right. And so are those are the dollars that you're using and are responsible for from a fiduciary standpoint? And so from that vantage point, all of the health-related institutions that you've identified in your presentation are getting a part of that money.
Yes, sir. Those dollars go to the health-related institutions in the state of Texas.
Okay, now, does each health-related, so the people can understand this, frankly, so I can understand, each health-related institution has a specific area that they're responsible, region that they're responsible?
Correct.
State of Texas? All right, who's responsible for the region down by Uvalde?
Uvalde is, that area, catchment area is UT Health Science Center, San Antonio.
Okay, and so UT San Antonio has been helping in that particular area. What services, they have been providing these services that are in this presentation, correct?
They had been providing the CPAN services in the community. They had been working with the local mental health authority, and on their plan for outreach in this, with the ARPA funds that are being released right now, the plan was to bring TCHAT to that area. And so that now they are in those conversations to bring TCHAT to that community.
Okay, was there a discussion about TCHAT prior to the shooting incident?
I believe there had been outreach to the community, but it's just the challenge of standing up a statewide program a year and a half into it, and we've been able to get to 40%, but we haven't been able to get 100%. But there had been, I think, some preliminary outreach to them.
What does that mean, preliminary?
Emails, we have this program, can we talk? Can we set up a meeting? And I want to be careful here. I don't have the list of meetings and all those, and so I don't want to say something that I don't have all the details on, but the information I had is that they had some preliminary reach out to that community.
And in terms of the local mental health agency, do you know what the shortage was in terms of persons working there?
I have heard, people tell me what they think it is. It's probably best for you to get that number directly from them, but it was substantial vacancies. And again, what I've heard, statewide is about 30% in the local mental health authorities, and that they were above that.
Okay.
And not because they weren't trying. They were trying to recruit people as best they could. It's just hard to recruit in some of these communities.
Right. And not only in that profession, too.
Yeah.
Other professions. Thank you, Mr. Chairman.
Okay. I'd also like the record to show that Senator Eckhart, Senator Menendez, and Bob Hall are all here. I would appreciate y'all's attendance. Well, she was here. He's still here. If you have any questions related to this panel, at some point, let me know. Okay, so you will in a second? Okay. Yeah, she's got you down. I checked on that. I know you're constantly reaching out to schools and expanding the program. That's kind of the direction we're headed. But do we wait until y'all reach out to a school to add them? Or if a school wants to be added, how do they approach y'all?
So we do a number of presentations on a fairly regular basis in the community. We also, again, talk with educational support centers, and with them we will also do presentations to superintendents. And so we'll hear from them. We have on our website, we could direct schools to a number where they could reach out and find out which HRI is maybe in their coverage area, and then that HRI would specifically reach out.
Okay, so you're open to that. If they're interested and they want to reach out, then it's a matter of just contacting y'all. I've got that number out there. On the different types, you had the different percentages like anxiety and depression were like 75%. But on the suicidal, is there any particular pattern of the age or grade on the suicidal? Or is it spread across all the ages, or is it certain age groups?
I haven't looked at our specific data to say that. In general, just suicidal ideations and behaviors are more common in the middle school and high school children. It's considered rare to have an elementary school child, but they still can sometimes say they feel suicidal.
On this issue, and I know Senator, I guess Senator Hossa was talking about it, how often a parent say, what happens if a parent say no? Well, obviously you can't do any treatment, which is the way I think it should be. But how often does that actually happen? Is it 1 out of 10, 1 out of 20, or is it 1 out of 5?
As far as once we reach a parent, it's pretty rare that the family says no to the service, because by that point they've been aware. The school has told them about the service. They're interested. It's more that we have problems with families not returning our phone call. So that's where things can stop, is if we can't get that family so we can finally do the actual consent to care. And I don't have those numbers in front of me, but we can look and get back to you.
Okay, for my last question, and I think there's going to be a few others. Something that always concerns me is, how do we know we're using the best practices out there?
Correct.
There's a lot of different people that are trained a lot of different ways, and some are better than others.
Mm-hmm.
As part of your research, or maybe this is going to come up when we talk to Health and Human Services, are y'all comparing all these notes of the best practices? And
Absolutely, Senator. And so we meet on a monthly basis with the full consortium. Those are open meetings, and we go program by program related to the implementation of the program. And the overall thought of why the consortium was conceived is to get all of us talking together to do these programs. And so in those meetings, we have every chair of psychiatry at a state-funded entity in the state of Texas, your Health and Human Services Commission, the representatives of the local mental health authorities, and we talk together related to the problems we're seeing and solutions. And if there's a good idea at one institution, we always say, we need to share seamlessly and still shamelessly related to these ideas, and have that kind of conversation so that we're all upping our game related to services.
Thank you. Were there any other members who had questions? Senator Campbell and then Senator Bettencourt.
Thank you, Mr. Chairman. So you don't have your own providers. Y'all are the liaison, the middleman to connect a student to a healthcare provider, mental health care provider, like at a facility? Or do you have your own providers?
We have our own providers. So TCHAT services are run through the health-related institutions, and we hire the therapists and psychologists and physicians to be in the service.
We don't have a person based in that school.
Right.
And so the counselors, whatever, the teachers that make the referral, then they hand it off with the parental consent. And then we have
A set of providers that you've already procured that work at a facility.
that work at our medical schools, health-related institutions across Texas.
Okay. And there's only a limit of 5 visits, is that right? Did I hear something like that? There's a limited number of visits.
We will never drop a patient that isn't need. We have a set of 5.
Where do they go after when they reach their limit?
Yeah,
Do you pass them off to someone?
I'll start, and then Dr. Laurel does this, or Dr. Williams does this on a regular basis, but we try to hand off to a psychiatrist in the community and get them in. And so sometimes you can, sometimes you can't.
What do you do? I mean, what do you do with the child if you can't do follow through? I mean, you've pulled them in to try to help them. They've met their visits. If you can't find somebody, you just drop the child?
No. We
What do you
continue
do?
to see them. We continue
Okay.
to see them.
The other strategy that we're developing, and this is part of that partnership with the local mental health authority, is that if we're seeing a child through TCHAT and we can't get another physician to take over the care, then you can refer to that local mental health authority
Some of them
where you
don't.
have your residents and staff there.
Okay.
But we have made it clear to our folks, we're not going to just drop kids. We'll do our best effort to try to find the continuity of care.
Do you prescribe any medications?
If it's clinically indicated and the parent agrees to it, yes.
And then it's the local mental health that continues that, and do they have an inpatient visit before prescriptions, or is it all via telemedicine?
So TCHAT services are telehealth, and if we feel that the assessment cannot happen without it being in person, then one of our jobs in TCHAT is to help that family get that in-person visit
But you do prescribe some medication.
via telehealth. Yes,
We just need to be careful with that, obviously. We don't want to dumb our kids down, dope them up and dumb them down. So.
Correct.
And I think the experience, and we're trying to gather this data, is different. And that sometimes kids are on medicines they don't need.
Correct.
And then once you talk to our academic psychiatrists, they can say, you can titrate off some of those medicines.
Right, and I'm happy about that, so they're transferred. How does T-Chat interface with emergency rooms? You said something that they're also available for emergency rooms. How does that happen?
So we are not available for emergency rooms. If the child is actually in the immediacy of a crisis, a telehealth visit's not appropriate, and the school needs to send them directly to the emergency room.
I just thought I heard something about,
Sorry.
piqued my attention because I'm an emergency room physician.
Yeah.
So you're really not available for ERs?
No.
Yeah, that's too bad. Do you tell parents about outcomes? So you're engaged with the student. Do you have consultation with parents
Yes.
after?
Yes. The parent is involved every step of the way.
Okay. Just a couple of questions through the handout. On the CPAN, is that what you call it?
Yeah.
CPAN.
CPAN. You said you direct message or have text add-on. That's to PCPs?
Correct.
Primary care providers? When does that happen? How does that happen?
So we're currently doing a pilot of it to sort of work through how it's going to work. But what we got some feedback from primary care physicians who were using CPAN that they wanted to maybe even faster way to reach us. And they wanted to see if we could include being able to text and say, hey, can somebody call me back? I need a consult.
Are those PCPs, do they engage with the child first and then contact you all? Or you all are contacting the PCPs, the child's PCP?
So
We're just trying to figure out what that looks like.
And I can start then what you do it on a regular basis, but what it looks like is a pediatrician is in his office, mom comes in with a child, there's an issue there, and the pediatrician doesn't feel comfortable with providing that care by themselves, and there's not a psychiatrist or a mental health specialist down the hall, and so they call our line, and within 30 minutes, one of our mental health professionals is on the phone with that individual, with that primary care provider, listening to the clinical presentation, the history, and
So
providing them advice.
It's a phone consult.
It's a phone consult.
Okay. Speaking of phone consults, is there video
for CPAN, no.
or any of your T-Chat?
T-Chat is a video, it's a telehealth visit, so it's video conference, yes.
Okay. And one of the challenges was trying to broadband, having access.
Yes.
So you have a picture here on one of the pages that time to get a consult, 2 weeks, who provides the consult. You've got a picture like they're in an inpatient setting. They're on a sofa, high-fiving the doctor. But it's all just video.
Yeah, it's a video conference telehealth appointment. So the equipment is at the school, or if the child is at home, at the parent's home.
Okay, on their phone or something.
On their phone or their computer or their laptop.
So I would just say that the picture, to me, is a little deceiving. I just probably have a picture of your machinery.
Okay.
So that it's video, because it makes it look like they've gone
Okay.
to an inpatient. You know what I'm saying?
Yeah.
And then I think, what do the supervision clinical hours look like, or when do those come in for those doing a residency or in their fellowship? You said, and then not just physicians, right? Social workers or licensed behavioral or behavioral.
So some of those ideas on the last slide, there's a set number of hours that the social workers need to receive after their internship, before they're allowed to practice on their own. It usually takes about 2 years in order to complete those hours of supervision, and they have to pay that out of their own pocket unless they're working for a large healthcare system.
So it applies to social workers.
Social workers, psychologists, a variety of other professions, non-physician mental health providers.
Okay. Well, you know, while we all want to provide support to children that most certainly have mental health needs, and there's a lot out there, I would hope it doesn't ever get to a point where a child seems to be isolated because he or she doesn't have a therapist. You know what I mean? It's a trendy, popular, well, everybody else has a therapist, why don't you have a therapist? See where I'm going with that? I think that's kind of not a balancing thing, but when you're talking about reaching out, we don't want to leave children behind, most certainly. We want to try to provide care for those who have mental health problems. But I wouldn't want it to be turned into something that's a trendy thing to have. Oh, I'm going to see my counselor. More like and I don't even know how to really describe that, except it was just a gestalt that, could we get to that in the future where we now have 90% of the children enrolled in some type of mental health? I mean, I don't know. I would never want to deny mental health care to our children or anybody who needs it. Yeah. But I would want to make sure that it's being measured tight enough that we know who needs a therapist and who doesn't. Thank you.
Well, thank you.
Thank you, Mr. Chairman.
Senator Bedcourt.
Thank you, Mr. Chairman. I think everybody can see why we have a talented ER doctor. At least more than one panel member here has used her services in need. And speaking of services in need, if somebody's outside the service area and they call, do you all just have a referral like a VA, or what do you do at this point? Say, sorry, we can't help?
For TCHAT?
Yeah.
Currently, yes, because we need to have an MOU in order to serve.
All right,
child.
now, when we look at the economics of this, we've talked about $300 million. You all have had about 10,000.
Lean into your mic.
When we look at the economics of this, you have about $300 million spent, or at least appropriated. We've had about 10,000 completed consults, or nearly that same number of patients. That's about 30,000 per patient.
Senator, if I may, with your math, I think you're looking at not just the TCHAT budget, but the overall budget of the consortium, and then using in the numerator the TCHAT number. And so there's the other parts of that would be the CPAN numbers, the work with the child and adolescent fellowship training, the other components of the consortium.
Okay, so instead of the CPAN metrics, what is the total number of patients? So I can do the math in my head. We're spending $300 million. How many people have you seen?
Yeah. So we provided about 10,000 consults under CPAN. You have about 38,000 total encounters under TCHAT. You have...
What's an encounter? I need to understand. I understand what a consult is. What's an encounter?
An appointment with a healthcare provider.
An appointment?
Yep.
Okay. And as Senator Campbell already identified, that's tele, not in person, right?
Correct.
Okay, what's the breakdown of this? Did you do an ABC costing between the CPAN metrics and the encounters? What's the overhead that applies to the encounters, and what's the overhead that applies to the consults?
Yeah. So I can give you the numbers, but I think the challenge right now is the challenge of standing up a new program because of fixed costs with the people that our institutions have had to hire as these programs are built.
Okay.
And so accurate numbers of what it's going to take in the long term will be another year before I can give you accurate numbers.
Okay, well, but you can do an ABC costing now, Dr. David. I think it's important because we're talking about scaling up a program. We just have to have some idea what the cost metrics are here, because if $300 million gets us 10,000 patients and 48,000 encounters, I want to know what the cost structure that supports that. So now, because here's a point, and it goes back with some really intelligent questioning from the, Senator Hinojosa, Senator Colcourt, Senator West, Senator Campbell, Senator Nichols. We're looking at this as a solution because we're talking about what's happened at Uvalde. We also know that at Santa Fe, that shooter has been declared mentally incompetent. And for obvious, logical reasons. Now, we do know the manifestation, that the last thing that people knew was that he was wearing a trench coat for over 3 or 4 weeks, which was against Santa Fe ISD policy, but no one called him out and nothing was done. Now, that may have been the last stop sign before, before disaster. I need to go back to use what we learned yesterday about the shooter and see how does this program interface, or how could we possibly have helped? Because this is a very important point, because we're looking at literally sands on the beach, grains of sand, individual. This one shooter in Santa Fe, the one shooter in Uvalde. We know that in 4th grade, he went back to the classroom. Obviously, there's some point of origin story here that we may never know. His truancy started up in 5th grade, accelerated through middle school, became endemic in the senior, what was his high school years. We know the father had disappeared for at least 2 years, or maybe 3 in COVID. We heard about him dragging a bag of dead cats. We know that Senator Colcourse talked a severe truancy issue here. Now, we have a small town, 16,000, 17,000 people, but we know from Director McGraw yesterday that there were 500 to 700 interviews that he's done. At least a half a dozen of them pointed to this shooter as somebody they thought was going to be a problem and actually do a shooting up a school or have violence. So how does this program help? Where do we start? Because we've got 8 years of this shooter's life that we know. So could we have intervened in 4th grade? Could we have intervened in 6th grade? By the time I submit he's dragging a bag of cats, dead cats, it's probably too late. Where can we expect that this could identify these grains of sands on the beach? Because that's really what we're talking about, if it's the solution to mass shooting.
So I think this is part of the solution and what you think through related to an overall response for Texas. And I think where we want to go is that when an individual in the future like this is in 4th grade and the teacher says, this isn't right, I'm seeing these worrisome signals, that they make that referral. If the school has the services, they provide it. If the school doesn't feel comfortable, they refer in. And then at that point, you try to link them to ongoing services in the community. I think where this fits in with CPAN is when that child is seeing his primary care doctor, and hopefully a parent is there with him, and the mom says or dad says, I want to talk to you about these worrisome things that are occurring, that the physician has the ability to call a trained, board-certified psychiatrist to say, this is something to be very worried about, and this is what we need to do. And here are services in the area or in the state that can be brought in to help provide for this individual. And so it sounds, I haven't been in the middle of this case, but multiple times during that individual's life where there could have been intervention.
This is why it's very important with Dr. Campbell's question. If you have a limit, this is a person that if they were engaged, given what we've known, this 5 limit would not have been effective. Because bringing somebody in with severe, whatever the issues are, I don't care how trained a psychologist, it's not going to happen like that. It's not going to be fixed.
Correct. I definitely would absolutely agree, and that's why we are very clear that we don't stop seeing the child. And we do think that most children are not going to need extended services, but for those instances where it's clearly necessary for ongoing care and we've been not able to make a connection, we will continue to see that young person until those connections are made.
Now, both of you all have testified here many times, okay, and we appreciate your service in that. But life is not all straightforward. We don't all have primary doctors with referring, physicians that have parental involvement that will make decisions on a rational basis. In fact, this family is a very dysfunctional one by any measurement that I understand. So how do we get around not having a parent involvement, because that's a big political, quite frankly, and family question, okay, because we want people to have parental involvement, but when you look at this, they may not have consented, and so I use this one grain of sand in this ocean because we've had a tragedy of really 22 deaths because the man that died of a broken heart is a direct, a casualty of this. So how, when we look at this, how does this consortium we're putting together, how does it interface in the messy nature of life?
Mm-hmm.
So I think that's a tough question. And I can't tell you the full answer. I'm just going to be very honest with you. The work that we do is not to replace the family. It doesn't replace the role of the parents. There are kids that struggle in the state of Texas because parents can be abusive, or the parent isn't there, or a variety of issues. What we're trying to do through the guidance of the legislature is to have this safety net to help support the schools, the primary care providers, the people that are on the front lines, develop the workforce so that we can help. But Senator, I totally understand that what you're funding here does not replace that parents that are daily involved in the life of that child, making sure that he is attending school, making sure that he's in productive activities after school, checking the grades, all those type of things. I, in this role, can't fix that. What I can do, per the direction of the legislature, is try to make sure we build an efficient program, and I'm working on efficiency to make sure that these type of services are available, regardless of the ability of any individual to pay.
Well, I appreciate the conversation and the directness, but because this is why this is an intractable problem. And so if you have an ABC cost estimate, activity-based cost estimate, I'd love to see it, but that's really when we're looking at this, because one of the issues of this is that when there is a success, you'll never know it. You only generally know when there's a failure.
Yeah.
Thank you.
Thank you. Senator Hall, I think you had a question. Let the record also show that Senator Hughes is here. Welcome.
Thank you, Mr. Chairman. And Senator Ben Corton, I couldn't agree more with you if that's the direction that we need to be moving in and the emphasis. And I recognize that you do what the legislature says, but we're in a situation I don't think any of us have the training to get into what really needs to be done. So I think, at least from my standpoint, I'm looking for the solutions. I don't want to see them dictated from a bureaucracy, but I really appreciate what you said, what you've talked about, what you're doing out there in reaction to what we have in this growing, and I'll put in quotes, mental problem out there. And would you agree, and I think it was what you're saying, that your services are increasing? It has been, the need, the demand for it. Matter of fact, we're about where we've outstretched our ability to service what we're identifying as mental problems out there. Would you say, and if it continues to increase at this rate, is it going to get beyond what we can really service throughout the entire state?
I think we're seeing the challenges for a variety of reasons related to mental health. If you look at the last couple years with COVID and the shutdowns and isolation and a variety of things, you see increased emergency room visits because of mental health needs, and you see increased attempts to take one's life because of everything that's gone on. And so you do see increases in demand. I think that's based on also underserved areas of the state of Texas that were already there. And so we're trying to help you leverage what you have the best you can as we also look at the workforce issues in Texas, Senator.
Okay. So with it growing that way, what are we doing to try to determine what should be the standard of care in the area of prevention, looking way back, the step beyond what Senator Bencourt was talking about in the early stages of recognition, move beyond that. What is causing this? Why is this happening? What is the root cause of it? You know, in medicine, I said yesterday in another case, an ounce of prevention is worth a pound of cure. And this is a case where it's amplified. This is where a lot of problems get solved if we could prevent this. So what is actually being done to developing an understanding of what is causing this growth in, quote, mental problems?
Well, I would say that it is unanswered at the point so it's not something I can sort of say, this is the root cause. It's generally multifactorial, and there's lots of debate about what is the root cause. I do think that some of the work that's being done in those research networks that are separate from the clinical services, that's part of what they're designed to do, is try to understand maybe some of the reasons for why these families and kids are having these problems, and then what to do to help them. So I don't think we have an easy answer to that question. It's definitely something that many people across the world actually are looking in and trying to understand.
Well, I think that somehow we're going to have to move there, because just treatment on this is like buying extra Band-Aids just because people get cut with broken glass instead of getting rid of the broken glass. Now, let me ask you just one other question here on within the standard of care. Would it be within the standard of care in discussion with someone to ask them or suggest that they develop a closer relationship with God to help solve their problems?
Certainly it's families, and we're family-centered, so as families tell us what their values are, we try to work with them.
No, I'm talking about coming from the discussion to the people.
I think as a physician, it's my role to understand what families are where they're coming from.
All right, thank you. That's all. Mr. Chairman, thank you.
Thank you, Senator Hall. Senator Menendez.
Thank you, Mr. Chairman. First of all, let me thank you for the work that you've done and you've been doing in the last 2 hours, very straightforward and frank testimony. We've all heard about the fact that many times parents won't agree to even a visit because of the feeling that somehow their child will be labeled and that somehow something is wrong with them. And so, have you tried to make a parallel between someone's mental and social health and their physical health? Because one of the things that drives me crazy, no pun intended, is that no one here would blink. I mean, we'd actually be concerned if parents didn't take their children to an annual dental visit or an annual checkup, physical checkup. Is it not true that mental health should be just viewed the same way as your physical health?
Absolutely. Your brain is most people I know, their brains are connected to the rest of their body. So your mental health resides in your brain. And we really work as a universal prevention, speaking of prevention strategies, is really this idea that how your mind is working is equally important to how your heart is working, how your lungs are working. And so yes, if you have a broken arm, maybe you can just go to an outpatient visit, get services. We want to have people feel just as comfortable if they're having distressing feelings or thoughts and they don't know what to do next, to go speak to somebody and get help.
So, as I listen to the testimony, and I think that it's somewhat sad that we only react to this issue sometimes when there is a time of tragedy. If we were to address children's social, emotional, mental health at a younger age, in terms of not trying to psychoanalyze them, but just trying to give them healthy habits. For example, we know that if you eat well and you exercise, you're going to be healthier physically.
Correct.
So I'm sure that there are good habits to get into that will help you have a better mental and emotional health state. Would that not be correct?
That would be correct.
And the sooner and earlier we start, the sooner and earlier maybe we can help children not be isolated, work well with others, and give them an impulse and a desire to stay in school. Would that be correct?
That'd be correct.
So as I was listening to you, it's tragic to hear about the mental health deserts that we have around the state, because it's very true. And Uvalde has been one of those. As you learn, as I heard you testify that you work with, primary care providers, you work with the school districts, as you identify these best practices, would it be possible for you to help our incoming teachers or our educational system to come up with a sort of a best practices not an identification process, but really this is the best way to have a healthy day for all students, that they could start, that would be age appropriate? Yeah. And so is that something that you're working on?
So we work with TEA, and again, part of the role of the consortium is to talk across our silos, whether they're state government, academic centers, et cetera. And so TEA has been in part of those conversations. Again, we don't want to duplicate what other entities that are funded by the state are asked to do, but we're there to complement. And so we have ongoing conversations with TEA, and where they decide that there's an appropriate role, think through how we can do that together. But we're open to that direction.
Well, I guess my thought is, especially if you don't have the personnel, the workforce available, wouldn't it be helpful to sort of expand that by helping educate the professionals who are with the students in the classroom every day, to help identify? And then would it be helpful if the state had more counselors in the schools each and every day, counselors that were going to be doing more than just asking them what college they're going to or if they prepared for their next standardized test, but really more social emotional counselors? Would that be helpful?
I think so. I think what we're also about is choice, and some families may feel uncomfortable having a school and their health care kind of be too layered. So I think the idea that we work with TEA, we work with the local school districts, and so we do provide education. And right now, to schools as they sort of indicate, hey, this is an area that we feel like our students or our counselors or our teachers want to kind of understand and learn better. And so that's part of our role every day.
I guess the thing I'd add, Senator, is our role is to help support those individuals that are in the school. But I don't think telemedicine takes the place of that person standing in the hall saying, David, how was your day today? Or I saw you really struggle earlier today. You doing okay? And so that kind of adult-student interaction, I believe, is really important. And what we do, again, is when that counselor identifies that David's not doing so great today, they can link us up to somebody that can help him provide services in the school.
Sadly, I don't believe that mass shooters and a lot of other criminals are an anomaly or something that you can't study patterns of past behavior. And so one of the things that I would ask you is, if you do get an opportunity to review data where there's a common denominator or there's a lot of similar patterns, that we can get down to the earliest place possible where we can interact, so we can sort of try to offset some of those things before they start. And so as you do your work, if we can start in terms of healthier behaviors, I mean, I'm old enough to remember the president's challenge on physical fitness.
Right.
Which
you did better than I did.
How many times did he touch your toes?
Lois was number one.
Of course she was. Of course she was.
Okay.
But the reality is that it made us think about our physical health. We need to be thinking about our mental, social, emotional health in order to remove the stigma. If we're going to really remove the stigma about mental health and talk about it, so we don't have to be talking about it as if it's a bad thing or it's scary to have something's wrong with your kid because they need to go see a counselor. We should all get a checkup. all of us would benefit from talking to a professional that could help us work through things.
Over 20% of the American population has a diagnosable mental health disorder, and so there's a lot of things that the consortium is sort of not doing ourselves, but in the area of prevention. So the American Academy of Pediatrics recommends screening of young people when they come into the office. So does the practices for adults as well, and also with peripartum. So our goal is to really help upskill those primary care physicians as well. So that the idea with why the academic centers, I think, are so essential here is that this is the place where evidence-informed, evidence-based treatments are developed, studied, and then we can sort of go out and disseminate them to other people.
Last question. People's physical health is on a spectrum. Some days it's very good, some days it's not as good, and no one looks askance at someone if they say, I've got high blood pressure, I need to get a medicine. People's mental and emotional health is also on a spectrum.
Absolutely.
And so we've got to do something better. Thank you very much. Thank you.
Thank you. We very much appreciate the work that y'all do and what the consortium does, and thank you for being here, answering the questions. We'll now go to the next panel, Texas Health and Human Services, Sonia Gaines, Deputy Executive Commissioner, and Chance Freeman, Director, Disaster Behavioral Health Services. And that panel will be followed up next by Texas Council of Community Centers and the Texas Medical Association.
Mr. Chairman?
Yes.
I have a question as we go through today, and I just feel like I have to bring it up on the heels of great questions. I've had some superintendents who indicated to me that they will have a child that is troubled. They will even have a child that threatens to kill staff or other students. And at that point, we've talked about, I think, Senator Perry, you brought up yesterday, DAEP and alternative education is being very limited. We know that the juvenile justice system is very, we don't refer as many. And their question was, as we go through the panel today, when someone makes a threat, they might be gone for 3 days to a residential treatment center, maybe a mental health hospital, but they end up right back in that school system, and they're still dealing with the same behavioral problems. And so I think, and we've got a lot of experts that sit on this panel that deal with criminal justice issues, educational issues. I spend a lot of time in mental health issues. Listening to our superintendents that we had yesterday and then my interviews with them, there is a real need that some children are a threat to society, and what are we going to do about that, rather than just putting them back in that system of school and then the school district being very nervous. And I say that from the largest to the smallest. That is an issue.
We spent some time
I don't know if
yesterday.
it's this panel, but somehow today somebody needs to answer that.
We spent some time yesterday discussing that, of course, and the more you start, if you're a school, the more you show disciplinary issues like that, the more you get dinged by the feds on your score and retention.
And TEA.
And TEA.
And I think this is something that we, you know, as we go through the mental health issue, we were looking
It's
at
kind of interesting
T-Chat.
because your private schools don't have to put up with them. They just send them out. Your charter schools don't have to put up with them either, so they send them out. So they all get stuck at public schools. Public schools, we really don't have a system for dealing with it. So I appreciate you being very vocal on the issue. It's something I hope we can address. I don't know the solution to that thing, but it is a real problem because you've got a certain number of those kids. I was looking particularly on this chart from the consortium that talked about all the different categories. One of them was harm to others, and there were 0 incidences, which that's the ones they treated. There were 0 incidences where a child was going to do harm to others. Yet we know from practical experience talking to our superintendents and principals and teachers that that happens.
Yes, and I do think that we have to discuss that as a body as we come out with reports that someone who has made a real credible threat, do they have a place, and I mean a violent threat, not somebody that's just dealing with mental issues, but someone that has made a threat, do they deserve to come back to that school? I don't know the answer.
And since you said that out loud, I think everybody here and watching heard you. And as we go through our different panels, maybe somebody will come up with something.
Well,
Senator?
And it's not just a federal issue, it's a state issue. I mean, if the school district is, that data entry is code of conduct rather than an imminent threat or a threat assessment category, then at some point, you know, the public's going to find out about those entries. And if 30 kids are pulled out of school because that school has a stigma related to that, that's a $300,000 bill based on how we fund schools. Because they're paid based on attendance, not enrollment.
I'm just listening and gathering.
Federal and state.
Senator West, did you have your hand up?
Yeah, let me get involved in this too. When we start talking about a threat, I'm going to beat you up. Is that a threat?
No, this was I'm going to kill a staffer.
Okay, so again, and I understand that. That level is something that we have to deal with. But we've got to be real careful because, frankly, profiling goes on. When you begin to look at the DAEP programs, and I don't want to get all into this because we're dealing with something else, those DAEP programs look like Senator Hinojosa and myself, African Americans and Hispanics. When you begin to look at expulsions or suspensions, those suspensions looks like Senator Hinojosa and myself, okay? So we got to be real careful going down this slippery slope. Does something need to be done?
That's
Yes.
why I asked the question.
And I'm glad you did. Yes, something needs to be done, but we got to be real careful about this and the ethnic impact or the racial impact it's going to have. And so,
But if somebody gives a credible threat, I'm going to kill a staffer.
And
I mean,
right
like,
now.
this was
If you're saying that, I agree with you.
And they're back in the school in 3
And
days.
they end up, is it something that they're able to carry out? Who have they communicated it to? Is it true? How do you make a determination that it's true? If I'm saying that to a teacher, that's one thing. If a student is communicating it, how do you determine the veracity of what the student said? There's a whole process we have to look at.
We had a
I'm glad you brought it
long
up.
conversation about
As
that.
we go through the panel,
It goes through
I'm
mental
hoping
health.
somebody will contribute that. And our next panel is Texas Health and Human Services. So Sonia Gaines, please state your, I didn't know which order y'all want to go in, but whichever one. Okay, Sonia, please state your name for the record and go through your presentation, and then we'll open it up for questions. And you heard the comment that Senator Kokorsz had.
Yes. Good morning. Sonia Gaines. I'm the Deputy Executive Commissioner for IDD and Behavioral Health Services at the Health and Human Services Commission.
Good morning. My name is Chance Freeman. I'm the Director of Disaster Behavioral Health Services for HHSC under the direction of Det Gaines.
And it is our distinct pleasure this morning to have the opportunity to give you an overview of our behavioral health services that we have available through the Health and Human Services Commission that we contract primarily with our local mental health authorities as well as other nonprofit organizations. And then Chance is going to talk about some of the work that his disaster behavioral health team does, particularly in response to the Uvalde incident, so you can have a good overview of some of those services. Before I get started, I really want to take the opportunity to thank this committee for their unyielding support over the years. I've been with HHSC now for 8 years, and I've seen tremendous support and investment in mental health services during that time that has really created a well-established network and infrastructure in terms of those services. So I'll be talking about some of the services that we have available. The first slide outlines the Statewide Behavioral Health Coordinating Council. I think by now many of you are well aware. Senator Nelson actually authored some legislation that created that council back in 2015. That council is made up of 23 state agencies, including TEA, juvenile justice, criminal justice. We also have the consortia that Dr. Lakey spoke about, and that group meets on a fairly regular basis. They have been very productive in producing a number of quality outcomes, some of which Dr. Lakey spoke about, and several other initiatives that we can go down the list and talk about. But again, that group has, over the years, has really formed very close working relationships, have done a lot of partnering on several different initiatives, and have really been instrumental in building up and reducing some of the duplication that we may have had. We now have a better understanding even of the finances. We know that there's about $8 billion that we spend across all of those state agencies in terms of behavioral health services. The next slide, on slide number 3, basically talks about some of the services that the service array that we have available through the Health and Human Services Commission. As I mentioned, we work with our 39 local mental health authorities and local behavioral health authorities that are geographically located across all 254 counties. Those LMHAs, you can see on the map on slide number 4, again, they're all throughout the state and geographically located. They each provide a standard array of services, and those services, as you can see on slide number 3, include services both to children's outpatient as well as adult outpatient services. We have crisis services. Chance is going to talk about the disaster behavioral health, as well as some well-established now grant programs that many of you were instrumental in getting started. And I would say that the peer services is a service that is a real intricate part of our service delivery system that we have. The other thing I want to mention about our local mental health authorities is that over the past 3 to 4 years, there's been a lot of work. I call them now the new and improved local mental health authorities because they are all now certified as community behavioral health clinics. And that's a national certification. And it requires that they each have certain types of pieces that are part of their infrastructure, as well as how they deliver services. And some of that includes they have to have the crisis array, as well as the peer services. One piece that we're very, very excited about is the focus on integrated health. When we talk about integrated health, both mental health, substance use services, and also looking at physical health care as well. The other thing that the LMHAs also work with us to provide, or work through their local hospitals, providing community-based inpatient beds. You know, and you all have invested in our state hospitals, so we have the inpatient beds there, but also through our local authorities, we have hundreds of beds that are available within the communities that have really been instrumental in helping to serve people here in their own community versus having to go away if they don't need state hospital level care. The other level of care that I want to mention is the crisis service array. If you look on slide number 5, you can see some of the prevention and early intervention services, and the crisis services that are outlined here include 24-hour, 7-day-a-week services that are available through a call line. Every last one of our local authorities are required to have a call center where they can take those calls, and it's actually a live person that answers that phone. They also have are required to have mobile crisis outreach teams that are available as well. If triaging the call that comes in requires a mobile response, then they have certified staff that are able to go out and respond. In addition to that, in terms of intervention type services, you can also see on slide number 6, mental health first aid. And I heard a lot of discussion about what type of training and early intervention supports are we involved in. And you can see with the mental health first aid, it's an 8-hour evidence-based training that's available to our school districts as well as other individuals that may be interested. If you look on the slide, you can see back in 2014, on an annual basis, there were a little less than 3,000 of those trainings that were provided. And because of the focus on providing more of this training within the school system, based on a bill that Senator Schwartner actually authored, you can see now, if you fast forward to 2022, over 100,000 individuals have been trained. And a large number of those were from the school district, over 76,000 from the various school districts. On slide number 7, it outlines the behavioral health matching grant programs that have been really greatly successful. We have about $140,000 that are currently invested in that program, serving a little over 140,000 individuals. You can see some of those programs that are listed here. We have the mental health grant program for justice-involved individuals, serving over 47,000 individuals. The Healthy Community Collaborative Program, which served over 33,000 individuals. The Community Mental Health Grant Program, serving over 40,000. And the Texas Veteran and Family Alliance, serving over 18,000 individuals. I can tell you from the feedback that we have gathered on the effectiveness of these programs, we're finding from a performance measure standpoint, we're seeing return on investment in the 90th percentile in terms of reduction in use of hospitals or people becoming incarcerated in jails. In terms of the mental health program, there were over 6,000 residents in rural counties that actually received services. 640 who were incarcerated received community reentry services, and 98% of the individuals at risk of rearrest were not rearrested while enrolled in these programs. The unique and wonderful thing about the grant programs is a couple of things. One, these are matching grant programs, so depending on the size of the county, the county is, or the LMHA is required to provide matching dollars. And so that could be anywhere from 25% for the counties that serve less than 100,000 individuals on up to 100% for those larger urban counties. The other unique thing about this program is that it allows the various communities to identify some of the unique challenges that they are dealing with and to be able to fund those things. And so we find things like jail diversion programs that have been funded, and then some unique programs on the veteran side like equestrian therapy, we have found that to be effective as well. So those programs continue to thrive and have done a tremendous job in terms of the infrastructure that we have available throughout Texas. One of the things that Dr. Lakey brought up, when I think about challenges that we're dealing with, is the workforce. And I thought Dr. Lakey did a great job of outlining some of those challenges. But just to put some of that in perspective for you, for example, when it comes to our behavioral health services delivered through our local authorities, they're serving close to 300,000 individuals, both adults and children. If you can imagine having a 50% vacancy rate, and let's say you have a caseload of 30 individuals, and I do want to mention when it comes to the delivery of those services through our local authorities. They are delivering evidence-based services that are based on the level of need of the person that presents. There's an assessment that takes place to determine what level of need a person needs to go into. So you have some individuals that are getting office-based services, and they may just see a psychiatrist and they have a caseworker. That caseworker may have a caseload of maybe 250 individuals. Then you have another level of care where maybe people need more support than what they're going to get from a traditional outpatient setting. So in that case, on the adult side, you may have a case manager that has a caseload of about 30, but they're not just seeing that individual in the office, they're actually going out to their home and providing rehabilitation services and other supports to link them even to, just community living resources that all of us need and just to live. So if you can imagine 50% vacancy rate, so that person that has that caseload of 30 now has a caseload of 60. The person that has a caseload of 250 now has a caseload of 500. And as you can imagine, you get diminished returns in terms of the effectiveness and also the burnout. I actually worked in a local mental health authority for the lion's share of my career prior to coming to the state, and so I understand the complexity associated with that. The other thing is that they're not just seeing individuals, they're also having to document. In a case of our LMHAs, they bill for their services as well as, have some individuals that are indigent that they can't bill for. So there's the heavy load of the documentation. If you're having to go out to see an individual, you're going into their home. And so if you double a person's caseload, it makes it very difficult to reach everybody at the time that they need to be reached. So I would say that the workforce is a huge challenge. The other thing that has become a challenge, particularly during the pandemic, is the availability of inpatient beds. And as I mentioned earlier, the legislature has been very generous in supporting and understanding some of the needs in terms of inpatient services. And we've been able to build on that. But with the pandemic, there's been some adjustments that had to be made in terms of not having as many people in the same room, social distancing to make sure. So what that's done is cut down on the availability or the capacity of what would normally be available. And the other challenge are the forensic cases that we have. And so more community beds are needed, particularly for youth. And I'm sure you're going to hear more about that from some of the other presenters. So those are just a few of the things that I'd like to mention in regard to just an overview of our behavioral health system. I want to turn it over to Chance, and he's going to talk about our disaster behavioral health system, and that he actually is the director of and has done a yeoman's job. We're very, very fortunate in Texas to have this disaster behavioral health program. They've been instrumental in responding to dozens of disasters, and both natural disasters and criminal events. And I will tell you, during the Uvalde, in the aftermath of Uvalde, they have played a critical role in terms of coordinating services among the community partners. Thus far, we have seen through the local mental health authority in partnership with the Texas Children's Consortia, over 1,600 individuals that have been seen through the local mental health authority. And in addition to that, there is a crisis, there is a CISM team that we call, and they are a group of volunteers that have been assembled, and Chance has been working with them for many, many years, and we have about 70 of those individuals that are peers, and some of them have worked as police officers, first responders. They have also been instrumental in providing services to more than 1,000 first responders, during the Uvalde event. Also, at the direction of Governor Abbott, we were able to stand up a support line that was made available very soon after the event occurred. That line has been available to anybody across Texas. It's answered 24 hours a day, 7 days a week. That call center has taken 335 calls as of yesterday. There's also a website that has been stood up to help people understand where they can go for resources. And we also are actively involved in the Resiliency Center that is available, and Chance will talk more about that. The other partner I want to mention is the federally qualified health clinic within the Uvalde community. They have done an incredible job. I talked to their leader yesterday, and they have served, from a behavioral health standpoint, over 700 citizens in Uvalde. I've been very, very impressed at the coming together of that community and the community partners, and some of the unconventional approaches to providing aftermath support. People, I was thinking about the staff at the Hill Country LMHA that actually went and did home visits. They were posted at the library. So there's been quite a bit of support that has occurred. And I'll ask Chance if you have any other comments.
Sonia, you kind of stole my thunder, but thank you.
Chance, please state your name for the record.
My name is Chance Freeman. I'm the Director of Disaster Behavioral Health Services for HHSC, and it's my pleasure to be here today and to kind of share a little bit about what we've been doing in support of long-term recovery, the immediate response to Uvalde, and kind of what our program does for the state in general. And so we have a small team of 7 staff that, we work with all of our 39 local mental health and local behavioral health authorities, as Sonia mentioned earlier. We also have a network of volunteers through our Critical Incident Stress Management Network, and through that program, we're able to also serve first responders, police, fire, EMS, and even medical staff. We really take a notion of all hazards, so no matter what it is, weather, pandemic, public health emergency, natural disasters, mass shootings, our team responds. And for example, following Uvalde, we were on the road in Uvalde at 8 o'clock Wednesday morning, helping to establish what would become the immediate response network, as well as helping the community pull together about 13 local resources that are there for the longer term recovery. And that's unique for our program in that we're responsible for the planning piece of how do you respond to disasters. We also are on the ground responding to the incidents in person, coordinating with local leaders, local mental health authorities. We're not coming in and taking over any of those operations. We're just simply asking the questions around what are the resources that are here? How do we maximize the availability of resources? What is your local capacity? And then how do we transition all of the good work that's being done during the response piece to then look at long-term recovery? And for us, as a state mental health authority, we really qualify, if it's a federally declared disaster by the president, we can request funding through the Federal Emergency Management Agency for what's called Crisis Counseling Program grants. Those grants last in duration anywhere from 15 to 18 months. COVID was a little different in that was about a 2-year project. With regards to criminal incidents such as all that we've encountered since 2017, those federal dollars do not become available. However, we do work closely with the Office of the Governor and their Victims of Crime Act dollars to make sure that those resources are coordinated and that, we're helping to inform the strategic planning and just asking the questions, who's here to help, what are the gaps, and what can we do to provide expert, as y'all mentioned earlier, the best practices, evidence-based informed interventions, so that we're working directly in the community, being culturally aware, culturally competent, and doing what the community leaders want and what the community and the survivors themselves say that they need. And that's important because all disasters are local. We come in and help, but at the end of the day, we are trying to help that community build a network for long-term recovery and then therefore establish that resiliency that we all know that Texans have. We're a very resilient state, and that's the process that we're in right now with Uvalde, is trying to help.
So how many people do you have in Uvalde?
That can vary any point in time of the day. So like HHSC, on average, we average three people a day from my team that was there. As Sonia mentioned earlier, with regards to peer support for first responders, we had a total of 77 different individuals there that rotated out from Thursday following the incident until Sunday of last week, so the 19th. Through Dr. Lakey's team, they've deployed a team of around anywhere from 4 to 7, depending on what the need is and what's been requested by either Hill Country or through the FQHC. In addition to that, with regards to support to the local hospitals, there was a team of 5 that deployed there, that were there for 11 days straight.
That's pretty substantial. Members, what kind of questions do you have? Senator Kokorst, followed by Senator Perry.
First, let me thank you for what y'all are doing in Uvalde and caring for a hurting and grieving community. Commissioner Gaines, did I hear you had the LMHA there had served over 1,600 individuals?
That's correct.
Since the tragedy of
Yes,
24.
just related to support to individuals that needed mental health support related to the tragedy.
Well, I want to thank y'all for that and for Governor Abbott and what he instructed Health and Human Services to do. And there's not enough care and love that we can give to that community as they grieve, and we wrestle with the answers of what happened. And I think the rest of the state and the nation are looking for how do we never let that happen again. So thank y'all for that.
Thank you.
I want to talk about just a little bit. I want to go to page, well, it's your mental health first aid numbers trained. I noticed, it ramped up. I think that bill passed in 2013. So it ramped up slowly, went from 14 to 15, fiscal year 15, pretty large. And then, the height was 16,125 there with school district employees trained. And then I know in fiscal year 20, that's COVID, but it looks like in fiscal year 22, is that just because we're young in that year? Are we keeping pace? Do you think the program's still growing?
Yeah, some of that has to do with the pandemic, and we are still young in the years. We get the numbers in the rears. One of the things that we did during the pandemic is we had to switch to a virtual. That training is normally done in person. As you can imagine, it's, doing it in person is not a very good option right now. But the numbers are in the rear, so we haven't caught up yet. But I did talk to my staff that you're going to see a big jump in the numbers. The other thing is during the summer, that's when a lot of the training occurs.
Okay, that makes sense. I'd like to ask, when we look at LMHAs and Dr. Lakey gave a pretty good, a real good presentation measuring outcomes. And I think, Commissioner Gaines, that we have really increased mental health funding pretty large over the last 2 or 3 sessions in different programs. How do y'all measure outcomes? Like, are we keeping children out of the criminal justice system or adults out of the criminal justice system? Are we helping keep children out of the foster care system with giving parents coping tools? What is something tangible that we can point to in the metrics?
So, what we know, and thank you for asking that question, we have performance measures for all of our contractors, whether they're a local authority or a nonprofit in, providing services through the grant programs or our substance use providers. And there's many performance measures that they have to meet. One of which is to, look at and measure our ability to keep people in the community. And that is a good gauge for us to know whether or not we're being successful. The other one is for someone to be engaged in their treatment and their medications, to not become homeless. So there are many measures, but one of the things that we have done in our division is really focus on what you're talking about, Senator Colcourse, and that's whether or not the services are making a difference. So for example, we know that when individuals are engaged in services through our local mental health authority, less than 2% of them are ending up in jail or the hospitals. That's a pretty phenomenal outcome when you think about the investment that you make. And on average for the adults, it's a little over $4,000 for a person that's in normal level of care. I'm not talking about the most intensive level of care. So we know that it's a good value. We know that these evidence-based approaches that are used when someone is engaged in treatment actually make a difference. I mentioned some of the basic services, but we can get into some of the other services, for example, that we have available for children. There's something called coordinated specialty care. That's a service available for individuals that are 13 to 30 that may have early onset psychosis, and helping them to understand about their illness. Well, we know that program is having success in the 80 to 90 percentile in terms of those kids that are involved in that program are more engaged in their education. They are staying in the community and they're thriving in their families. So we do keep outcomes on every one of those programs.
And great. And you can tell us, is that available on the website, or how do we get that kind of information on metrics?
I'll be glad to provide some of that to you. On the grant programs, we have report cards that I can give you. On an annual basis, we do a report card on each and every one of the grant programs. And then we also publish an annual report that highlights some of the outcomes that I just mentioned on some of the key program areas that we have. I'll be glad to share that.
So let's go to Uvalde and the perpetrator. And we look at all the different programs. We talked about it in TCHAT. TCHAT had not yet rolled out to Uvalde, or Uvalde had not enrolled in TCHAT. But even if TCHAT had been there, because of its truancy, probably would not avail himself or the school district of that service, even if it had been there. Local mental health authority, we heard in testimony, it was understaffed. We know that mental health workers are needed. We'll work as a body to address that next session. But where in our system would that person have gotten referred to services? And I think that's important for us to understand, because I don't think that he was going to refer himself. So how does someone get the help needed if they're truant or have fallen out of school, or they're 19 and not in school? Where is it that our system says this person is troubled and needs help?
Yeah, it's a challenge, right, in a major way. One of the things I will say is that the Uvalde school districts were heavily involved in mental health first aid, and that's a good thing. Meaning
Which
that
is
they're
great if the kid is in school, but not
Right.
in school.
Right.
And so I think that this is interesting. One of the police chiefs from your district, Jacksonville, testified yesterday and said, we know the troubled youth. We know 90% of them. We know where they are, who they are, and we can pinpoint that. Again, being careful about stigma and things. But, as we work through mental health, sometimes people just need help. It might be a life coach. There were indicators here, animal cruelty. And so I think one of the things we have to understand, Senator Zaffarini, you and I have had a conversation just today. Truancy and animal cruelty, that is a moment that you go, there might be trouble here. We have laws on animal cruelty, and yet this person never seemingly ended up either seeking help, being referred to help, or law enforcement stepping in and saying, this is a person who has already committed these crimes or in the act of crime. And so I think that that's what we're trying to wrestle with. And what role, I mean, how does someone get referred to an LMHA if they're not themselves going to say, I'm in trouble?
They can't.
They're not in school. There's no teacher that.
Yeah, this is where I say, mental health is everyone's business, that we all play a role. It's kind of, and I've used the example that if we walked outside and we saw a young child in a car with the doors closed, we would do something about it. We would respond to it. I think the more knowledge, I heard Dr. Lakey and the psychiatrist talk about it's okay to talk about these things. And so I think the more that we do, to educate the community that this is no different than if someone had a broken arm, we would respond to that. If a kid was in a car and the windows were all rolled up, we would immediately respond. And so it's not just anyone's.
And I think that that's a fair assessment, as it was discussed, of someone walking around with a bag of dead cats might be a warning signal for us,
Exactly.
Right? And so this is my final question. You talked about challenge with mental health beds, inpatient mental health beds. You mentioned forensic beds, particularly for youth. It goes to the question that I think I posed to future panels of, again, school districts, large and small, dealing with children maybe in a psychotic manner. Maybe they didn't mean to say they were going to shoot a staffer, but maybe this is a warning signal. So we increased forensic beds last session. Obviously not enough. You and I have been working on a model that there should be not just ASH and SASH, which we're spending billions of dollars to rebuild our mental health beds across our state, a wise investment. But there's also a need for those regional beds that maybe Senator Perry way out west. My goodness, somebody shouldn't have to travel 8 hours to find a mental health bed. Our deputies, you hear those stories. So how are we doing on that? And what do we need to do, as Senator Zaffirini, my colleague, my senior colleague, always asks, what can we do to improve this? What are your recommendations?
Yes, and on that note, again, thank you for the investment last session. We were able to get an additional, $15 million to
both in rural and that was a partnership with my friend Senator West, my colleague, where we put in extra beds for both urban and rural. How are we doing on that?
We're doing great, and it is really a great value because what the LMHAs do is that they're working with their community hospitals that have beds available. What has been really wonderful about it is that we're able to stand those beds up very quickly because you're not having to build another building, right? So, and we're also finding that those beds are used at 100% utilization. Senator Perry, I want to thank you for your focus in the Lubbock area. With some ARPA dollars, we were able to look at some construction to expand the beds in the Lubbock area. That's going to be, a huge benefit to that community as well. And so, to answer your question, I just can't say enough about the value and the benefit, both clinically and otherwise, for the families and for the individuals that have access to those beds on a community level. And what I would say is it's been great. It's been greatly appreciated. We need more. We need more community beds.
And so, members, when we say that, we're a growing state. People are moving here. They're fleeing other states. They're coming to Texas for an opportunity. I'd like to say the business opportunities and the different things that we offer as a state, affordable, housing that's maybe not as expensive as in California, and restrictions that we see in California. So you're right. We're a growing state. We need to meet that need, and I think that's an investment we have to make. And both my colleagues from urban and rural, Democrat, Republican, we agree on that, and that is a wise investment moving forward. But we're going to need from you some recommendations, and for those listening, for our the forensic beds. I was just getting some statistics from my staff on the number of folks in some of our prisons on psychotropic meds, and the need for that, in forensic beds to get mental health is very large. So I look forward to working with y'all.
Senator Perry.
Thank you, Mr. Chair. Very quick follow-up. It's about $85 million for rural beds. I know Lubbock's, I think, got construction permits issued. I know that Midland was 40 of those, I think. They were going to build another facility, or are they using existing? Do you know?
Where is that?
Midland, Odessa range. They had about 40 of those going to a particular center, I'm told.
I don't know that specifically off the top of my head, but I can get that information.
Okay, so I appreciate you working through. I appreciate you. You always come with a follow-up, and usually you're implementing, and that's not always the case with our laws. Specifically, and this is from a personal perspective as well as just general, what I hear, we really don't have bed space for minors that are very accessible in a geographical region specifically. But we have a lot of LMHAs and we have a lot of facilities, and we're always talking about all these great things, but we never really drill down to what is our minor capacity. Kids that are threatening suicide or other things that are maybe 8 to 17. We don't have that facility, do we, really, of substance?
That you're exactly right. I mean, there's the beds for children that we had diminished through the state hospital. Things have changed over time. You think about before the pandemic, after the pandemic. But one of the things I will say is that, historically, the children that we serve through the local authorities, about 80% of them have some type of benefit, Medicaid or some other type of benefit, Medicaid or CHIP. And what we had saw a trend where the need for state hospital beds had started to diminish. This was several years ago. And so there was a movement to reduce some of those beds, I will tell you, from a state hospital standpoint. And then fast forward, now we've gone through the pandemic and, social distancing and some other things. And what we're finding is that those beds just simply are not readily available as they were previously, both on a community level, and also at a state hospital level.
Do you have how many beds we would need to meet the minor inpatient need, not outpatient, not any of that, but inpatient minors under 18? What does that look like?
I do not have that number. There may be other people on the panel that have that information.
Is it available?
Is it available?
Is it available?
Yes.
Is most of our minors that are requiring inpatient treatment probably getting outpatient as a substitute until something comes up?
Yes. I mean, it's always preferable, right, to have a robust outpatient intervention that could keep kids from having to go into the hospital. I think all of us would agree the hospital is no place for any of our kids to be in. And I will tell you, again, some of the programs that we have, I mentioned that coordinated specialty care program, but we also have another outpatient program called the Yes Waiver. Those two programs have been very, very successful in keeping children in the community when we get them, when we can engage them. But sometimes there are kids that need more support than what they're going to get through those.
So we're struggling from a bed capacity, but specifically we're struggling more in the area of 18-year-old or 17-year-old and under. I'm going to flip over to something that's been a conversation yesterday. It continues to be a conversation today. I want your opinion. I'm going to go back to the kid that's non-responsive, that doesn't want our help. As much as we've tried to extend or we've identified, we don't get a response. Specifically in the schoolhouse environment, There's internal disciplinary programs that we try to handle that kid. There's externals that we go to JAJEP. And then there's what I call the non-responsive. Where we have made our mistake in this analogy is that kid needs to stay in an institutional learning environment when really they need to be fixed before they can learn. In other words, we're trying to keep a kid in a classroom that really, by all metrics, isn't ready and won't learn, and we haven't dealt with fixing it. Today, we don't have that middle, what I call no man's land place to send these kids. Do you have a perspective on when a kid needs to come out of the classroom, and back to a conversation previously? In today's world, any verified threat against anybody in a school, regardless of where the capacity to carry it out, has to be taken seriously, and the kid needs to be removed, period. Zero tolerance. That's the only discussion I need. And then we can determine if it was serious or not. But once a kid makes it in today's world, we can't ignore it. Do we have a go-between of the JJAP system, which is similar to a criminal? I mean, honestly, you probably run the risk of a kid getting to become a better criminal if that's what they're bent to. Do we have a place to put those kids to get them fixed outside of the education system to put them back in? Because all we do now is just move them back and forth.
So you mentioned the juvenile justice system, and of course they play a role. I can't speak to them, but as I mentioned earlier, we do have a continuum of care that is available to serve at-risk youth. That program I mentioned, the Youth Empowerment Program, it's a very, very intensive wraparound program. It works with children while they're in school. It works with the school system as well as the family, teaching the family some skill set. And it's a very, very effective program when families are interested in being a part of it.
I think that we're all talking through, there are kids that do not care, that have checked out, that because of compulsory requirement, they are in an education system. They're not safe for them or their peer groups or authority figures in that classroom activity. Do we have an alternative holding cell, if you will, for lack of a better conversation, to get them right, to be able to go back to the empowerment person? But there are kids that are checked out of society.
And you mentioned an holding cell? Is that
well, a place to put them besides current JJAP or DAP process, because that's not working.
So
they need mental help before they really need education.
Systemically, I would say I'm not aware of a program.
So that's what we're trying to get to. What do we do? There's got to be a middle ground in here somewhere that we don't have. Just state-supported living centers. I've argued for repurposing numerous empty bed space on all of these campuses across Texas. Is that a viable alternative if we get the right personnel in place to hold those kids, to get them healthy mentally before we put them back into an education environment? Can we do that?
I think that would be great.
Thank you.
All right. Thank you, Senator West.
And obviously, that's going to be a long, long debate on those issues, because those kids look like you and look like Senator Hinojosa for the most part. Am I correct? The demographics of those kids, the demographics of those kids that he's talking about that may have those problems, that may have allegations made against them, in some instances confirmed allegations, will probably look like you, African American, and Senator Hinojosa, Hispanic. Is that correct?
So that is something that we certainly would have to be aware of.
Based on the demographics of kids in those types of programs, if you are aware of them, would those kids be Hispanic and African American for the most part?
I'm not the expert on that, so.
Mm-hmm. I'll leave it alone right now, okay? Let me ask some questions. Our charge has been to look at the mental health system in Texas to determine how do we stop mass shootings, school mass shootings. My question to you is, what can be done differently, and we've already done, to reassure parents that the council, the behavioral health council, is doing everything possible to do its part to to provide solutions to mass shootings?
And that's a question for me?
Well, it doesn't matter, but one of the two of you.
That was definitely a question to either one of you.
So, as I mentioned earlier, and I think, Dr. Lakey touched on this, it is a multifaceted approach. It's not, any one solution. The work that we do is around the mental health piece in terms of having a continuum of care available that people can have access. And as I mentioned, we have call centers, we have mobile teams. We also have programs that work closely with the schools. I will say with some of those programs that are school-based, and I know there's some people that you're going to have on the panel that come after me, those programs have been very effective. Well, we have LMHA staff that are co-located, even in the school system. Dr. Lakey talked about some of the services that they have available in the schools as well.
And not to cut you off, but to cut you off, okay? So you're saying we already have a structure in place in the state of Texas?
I'm sorry, I didn't hear.
We already have a structure in place in the state of Texas?
So here's what I would say. Some of the services that I mentioned early on, we have a basic structure of services, but in addition to that, there are some places that it is not uniform across all counties, for example, that we have school-based services.
So one recommendation is to make certain we have uniformity across the state as it relates to school-based services. Is that a recommendation?
I believe from, my experience and when we look at the data and the outcomes, those school-based programs are having a huge positive impact. When you have, a person.
No, hold on. How many wings on an airplane?
I'm sorry?
How many wings on an airplane?
What type of plane?
Okay. So what I'm asking you is a recommendation to make certain that we have school-based services and it's uniform throughout the state of Texas. Is that a recommendation?
I definitely believe that would be a benefit.
Okay. Are there any other recommendations that Health and Human Services would make in order for us to address the charge that we currently have?
The other one that, I had mentioned briefly, Dr. Lakey mentioned, I think, we have to strengthen the workforce, and we just simply have to do that. More money to do more, to fund more services without strengthening that workforce simply will not happen. And so that, to me, that's the number one thing that has to happen.
Strengthen the workforce, right?
Strengthen the workforce.
Now, let me ask this question. Let's stay with workforce for 1 second. I noted in your testimony that you were talking about caseload. What is the average caseload in the country for similar persons in these positions that we have in the state of Texas? What's the caseload?
So, as I mentioned earlier, the caseloads vary. We adopted a evidence-based approach where we assess individuals and determine the level of care that they need. So there are several levels of care. Just to keep things in general terms, you can have a person that
Out of due respect.
Okay.
I'm not interested in all of that. I'm interested in the caseload. There has to be a national standard for caseloads, is there not?
So there are standards in terms of if someone only needs medication, what type of caseload there. It could be, a couple of hundred individuals. But if someone needs more support than what they're going to get, just going into a clinic on a regular basis, you're going to need a smaller caseload. And for children, for adults, it could be 30. For children, it would be more in the teens.
Okay, so in Texas, what is the average caseload? Do you know that?
So the average case, depending on the level of care, it could be around 250 for office-based services. And then for community-based services, it's about 30 to 35 individuals on a caseload. And then if it's a child that's being served in an intensive program, it could be as small as 1 to 10 ratio.
And because of the workforce shortage, it increases the number of persons on the caseload, correct?
That's correct.
Which frankly kind of reduces or dilutes
correct.
services. Is that correct?
That's correct.
And so would one of the recommendations also be to make certain that we have a standard caseload and a workforce that would be able to maintain that caseload in the state of Texas?
That would be correct.
Okay. Are there any other recommendations? And you may not be able to get all the recommendations at one time, but off the top of your head, are there any other recommendations that you can think of while testifying today?
No, sir.
Okay, let me go to another one then. We know that Texas is not the first state to have experienced mass shootings at schools, correct? We've had them in Florida, we've had them in Connecticut. Have y'all done an analysis, and there hadn't been, and thank God, we hadn't had another one in Connecticut nor in Florida, but we've had several in the state of Texas. And so the question is, as it relates to mental health, if y'all looked at or compared Texas's mental health structure to the other states to see what, if anything, they have done in order to prevent this type of behavior on a going forward basis.
Chance, have you done any with other states? So I would not say with other states. I would say like with some of the other communities like Sandy Hook. I know that there's been a lot of collaboration with some of the other communities that have experienced shootings and some of the things that they have done. One of the things I would say, Senator West, is that we actually are kind of unique in Texas in terms of the infrastructure that we have, particularly around some of the service delivery, like, for example, the crisis service array. When I talk to some of my peers in other states, many of them do not even have that infrastructure in terms of a 24-hour call center, a mobile crisis outreach team, those sorts of things. What about in Connecticut and
Florida? I mean, those are kind of some. What about in Connecticut and Florida? Do they have similar services? Is there anything that we can learn from those states as a result of the mass shootings that have occurred there? And what, if anything, they've put in place to prevent them in the future?
There's not anything that comes to mind right away.
Have you looked? Have you talked with them?
We have had some, not related to mass shootings. We have done some comparison in regard to service arrays.
Do you think it'd be wise to talk with them about mass shootings?
Absolutely.
And what, if anything, they've done?
Absolutely.
Would you do that and let us know whether or not there's anything that we should consider based on your conversation?
Yes.
Okay.
That it?
One more.
It's somebody's watch.
It's a phone.
Are there any other funds, revenue sources that we should be taking advantage of in order to make certain that there's adequate funding of our mental health programs in the state of Texas?
If I understood your question, are there other funds that we should be taking advantage of?
Yes.
And so one of the things I will mention is that we have been the recipient of some COVID relief dollars to the tune of $250 million. And so we're in the process of implementing those dollars that can.
Are there any other funds that we need to be looking at that you know of?
There
I
may
understand
be
the COVID funds, but are there any other funding sources that you?
None that have materialized yet. We do know that there may be some funds coming down the pike in terms of the development or the implementation of 988, which is going to be a one number that everyone can call, kind of like 211, to the tune of $8 million. And so we're working with the federal government on acquiring those funds as well.
Keep your eyes open for the money. Keep your eyes open for additional funding, okay?
Say that again?
Keep your eyes open for additional funding.
Absolutely. Absolutely.
Thank you, Mr. Chairman.
Thank you, Senator West. Senator Campbell.
Thank you, Mr. Chairman. Mine is more a description of what, when kind of to the tail of Senator West's question regarding funds, but regarding ARPA funds. Comal County is looking to partner with their local mental health authority, Hill Country, and their Development Disability Center to increase their capacity for crisis beds, inpatient beds. Then they're going to build a 15,000 square foot building with 16 inpatient beds. Any more than 16 would be referred to as a psych unit. But right now for crisis intervention, Comal County has to send their folks to either San Antonio, Kerrville, or even further. So they're going to use dollars to build a facility, 16 beds, operated by the local mental health authority, and just need some dollars support from the state, about $3 million or so for 2 years. Yet that increases some capacity. And I'm just wondering if that could be replicated in some other, not urban cities, but counties about the size of Comal. I think that's very unique, and it is a way to use some dollars and increase capacity, some crisis beds that are needed. So have you heard anything about that? Or if not, I think talking with some of the other counties, our DA and our county government has been looking at that because of the cost to send folks out. Mm-hmm. And it's a cost savings. And yes, it does cost the state a little bit, but it's really utilizing one-time ARPA funds to build a facility that definitely is affected, to support mental illness, mental health crisis that would be needed. Have you heard of that with others?
So absolutely. We have heard a number of situations where the local authority and the local county are working together because there are some COVID relief dollars that went directly to counties. Mm-hmm. And so they were able to capitalize on those dollars. And because of the great partnerships between the local authorities and those county government entities, there are a number of different proposals that I've heard about or have seen that will result, the one that we talked about in Lubbock is going to result in an expansion of an existing facility. So they're going to actually build on an infrastructure that they already have. So I'm a big believer in those local partnerships. As a matter of fact, some of the local communities are also finding that maybe it's advantageous for them to put more skin in the game, even in terms of the operational costs. Right. I've seen that happen as well. So it's really a great idea and partnership. The challenge will be if the state, if there's a reliance on the state to cover the operational costs. That's beyond me. I'm at the will.
The county puts in some. I'm not sure specifically of the numbers, but $3 million over a 2-year budget is a lot less than some of the other dollars we're having to spend at our state beds that we're trying to provide. And if that model could be replicated, building the facilities, it at least increases our capacity for crisis beds. Mm-hmm.
Yeah, we already have a model like that. The Star Care out in Lubbock, they've had their hospital for quite some time. I've had the pleasure of visiting their hospital. It's
more, and I didn't mean to cut you off, but it's more just not making it a hospital, just less than 16 beds, 16 beds or less.
Right.
Okay, thank you.
You're welcome.
Thank you, Mr. Chairman.
All right, thank you very much. Sonia, I think you have been heading up that coordinating council since Jane Nelson first used the term.
So I actually, when I came to state government back in 2014, I came in the job as the first statewide behavioral health coordinator and did that. And then after that, the next session, Senator Jane Nelson developed the statewide coordinating council. That's when we brought together all the state agencies. And so, yes, I was on the front end of the development of that. And now that's one of my program areas. Dr. Harvey is the actual coordinator now for across the state.
Okay. All right, but you've had involvement with it since the beginning. I remember when, I still call her Chair Nelson, asked the question in finance, how much do we as a state spend on mental health? And nobody could answer the question. Even LBB could not. And it took about a year or two to really figure it out. And the coordinating council kind of came out as a product of that. I didn't really have any questions related to this subject matter, but you did bring up federally qualified health centers kind of in your early comments.
Yes.
So I just want to say the legislature approved $25 million last October for, I call it seed corn, startups for federally qualified health centers. This has been 8 months, and I know some of your other people have been working on this thing, but we can't even get applications out to these centers who are having cake bake sales and stuff like that, trying to pay people to provide a medical service, waiting on some of the startup money. So anything you can do to encourage the other people that you talk to at Health and Human Services to hurry and expedite that would be greatly appreciated. And if you would remind them that every morning when I wake up, that's the first thing I think about.
Wow.
And I'll be waking up in the morning hoping I don't have the same problem. But it's a great program. And anyway, I'm glad the members came together on all sides to fund it. But thank both of y'all for being here today. We very much appreciate your testimony and the work you do for the people of Texas.
Thank you.
And so with that, I'll call up Wayne Young, Texas Council of Community Centers, and also Dr. Celeste Caballero, Texas Medical Association. You can both come up and we'll take one and then we'll take the other. Okay, I think that must be her. And then coming after that will be Dr. Roshni Kohli, Texas psychiatrist, and then the Children's Hospital Association of Texas. So, Wayne, please state your name for the record, and then give us your testimony.
Yes, sir. I'm Wayne Young. I'm the CEO of the Harris Center for Mental Health and IDD. And I believe you have a few slides in front of you that I will reference. First, I want to thank you for the opportunity to share a few thoughts today about this important topic and to be here with you. For reference, the Harris Center for Mental Health and IDD is the largest local mental health authority. You've heard us reference several times, or us and our sister centers, and I know that some of my colleagues are watching and I think perhaps even here. The Harris Center serves Harris County. We're one of the few LMHAs that only serve one county. It is probably all I could say grace over, to be honest, so I'm grateful for that part. We have about 88 care locations, and last year served a little over 90,000 people. As has been referenced before, we are proud to be one of the local mental health authorities that's been designated as a CCBHC, and we are CARF accredited. Last year, we provided about 1.5 million services to those 90,000 people. Across all of our programs and program areas, which includes both mental health and intellectual developmental disabilities, we served about 18,000 youth. So of those 90,000, that's the proportion of them. Obviously, operating a community mental health center in Harris County is considerably different than operating one in rural Texas or out in West Texas, where some of my friends are. However, I would certainly venture a guess that some of the same things that keep them up at night are the things that keep me up at night, right? Trying to make sure that we have access to people when they need it emergently, that we can intervene early enough when someone's illness, that we can perhaps change the trajectory of where their situation is headed. Those are things that I think we all have in common. As we start off, I want to thank you for the investments. Much has been said about the investments that's been made in mental health services. And a couple of the ones that I want to highlight, I'm doing so because I think it's important that we continue that investment or perhaps escalate it. And so thank you from the very beginning in acknowledgement of that. The new state hospital facility that's in Houston, we partner with HCPC. Most of the original beds in the original hospital that HCPC operates, those funds funnel through us to them. So we fund about 170 beds locally in HCPC, and then we purchase additional local ones in local private psychiatric hospitals. And those local beds are particularly important because I think we've all seen there are growing pressures from the forensic side on the state hospital beds. And so often it is those local beds that are most available to us and where we can most readily get individuals in there. I heard the conversation about the number of beds. Technology is a wonderful thing. As I was listening to my friends and colleagues present earlier, I happened to approve 2 payments to those private psychiatric hospitals for about $300,000 for providing that local bed kind of on demand, and as Sonia mentioned, often at full capacity. So those are going to be critically important to continue and to expand availability. We also have coordinated specialty care. That's been mentioned earlier. It's an early onset program, very evidence-based, very evidence-driven. We are one of the first programs that was funded in the state for coordinated specialty care. In fact, just this last year, there were 2 research studies that were published by UT Health where we identified that readmission, rehospitalization following engagement in coordinated specialty care and specialty long-term treatment were significantly reduced, as well as the likelihood of convictions and arrests and convictions. And if there were arrests, they still tended to be fewer for those individuals who participated in coordinated specialty care or early onset programs. I also want to mention, and some of these I know have already been kind of probably discussed as potential reactions and responses to this, MST, or multisystemic therapy teams, another very strong evidence-based program that's out there. We have the good fortune of operating 2 MST teams. They're very intensive. They're pretty costly. You tend to target them at engaging the youth that are at high risk and that have criminal justice involvement. In fact, our teams, one of them is funded through our local juvenile probation department. The other was funded through HHSC, through dollars allocated for that purpose, but still trying to intervene with those youth that are kind of at the door of the juvenile justice system, trying to stop that engagement and furthering, because sometimes when youth go into those systems, some less desirable things begin to become more likely to occur in their lives. And so of those 185 families we've served in the last 2 years in those programs, 84% of the youth that we've engaged have completed the treatment process. 96% remained in their home, meaning they didn't get placed outside their home during that time, and 88% of them had no new arrests during that time while they were engaged in the program. I will say from a success story, we had one youth, he came into the program as a result of a weapons charge. The courts were very concerned about his involvement. There was, I think, a little bit of hesitation. It was a bumpy start as we began to engage him and his family and his support system. But I'm proud to say that our therapist got an invitation to his graduation that occurred a couple of months ago, and a really, really good outcome for him and his family. So there's a really powerful opportunity within the MST teams to make a difference. Already been mentioned is the 988 launch. That's coming up relatively soon. We're one of the 4 community mental health centers in Texas that will answer those 988 calls. Currently, we do run I think Ms. Gaines mentioned every community mental health center has to ensure there's a crisis line available within the communities that they operate. We do answer a crisis line currently. We do also take calls for the National Suicide Lifeline already. I think there's a really nice opportunity. We've got to make sure it's resourced well and adequately, but I think there's really a nice opportunity to begin to create a funnel through that 988 system, similar to what we did with 911 many years ago. I think we take for granted the evolution that's happened. I'm from a really small town, and I remember my family were really concerned that they were going to have to start using the first 3 digits. Back when I was a kid, you could just dial the last 4 numbers of the number in that small town and get to anybody's phone number. They changed it because you had to have the full phone number when you were calling 911. So I think there's an opportunity to continue to invest the infrastructure and leverage that 988 investment that's happening for the benefit of everyone. We are a certified community behavioral health center. Where that becomes important is it does create a pathway to do unique and opportune interventions and programs in collaboration and coordination with law enforcement, other crisis delivery services that I think really are important. I think even though we weren't initially selected to be one of the CCBHC expansion states in the pilot program, I think HHSC's vision to keep us moving forward along that path has been really helpful, and I think it has us on the cusp of being able to do some really meaningful things with that. In terms of maximized funding streams through DSRIP, I think we all know that DSRIP is going away through your direction and HHSC's implementation of that. I think we're at least at a place where the charity care pool and the directed payment pool are at least going to offset. It's not new money into the system, but will offset some of those funds that are being lost to the district piece, so we won't have any kind of big cliffs in services, and I think that's critical to maintain that and to keep the gains that we've had there. If you move to the next slide where it talks about local collaborative partnerships, this is not an answer for the state. It does begin to answer at least some of our discussion and visioning in Harris County in terms of that response, in terms of how do we react to this. One of the things that we've had conversations with just in the last couple of weeks are those youth that often get referred for making terroristic threats. How do we engage those youth? How do we do something different with those youth? It is not a simple discussion. There's a lot of challenging dynamics and complicating factors. But what our proposed solution is, and we're not there, I don't want to create the perception that we've got this and it's in place. But what our visioning is that we're going to create a multi-agency, multidisciplinary response team to be built around those identified youth. We know that every school has a threat assessment team, but our intention is to create a threat assessment management team so that we can engage with those youth on a longer-term basis. Our system today, I think we would say, and I think we did say as we met as a group, and this group includes the district attorney's juvenile bureau chief and the juvenile probation executive director for Harris County, that what we have today is a process that does a pretty good job of kind of controlling for imminent danger, kind of this immediate right now, what do we need to do, how do we get a kid in a hospital, what can we do? But I don't think it really has the long-term focus we need on how do we do long-term engagement, how do we screen and identify the serious threats, how do we distinguish between a kid who's made a threat and a kid who is a threat in a community, how do we provide regular follow-up and services for prevention, and how do we do some teaching and education components to that. So we don't know the number of teams we're going to need, and they're not inexpensive. As you can imagine, when you start adding a probation officer, juvenile probation officer, and a psychologist, a care coordinator, and a lead and a district attorney's representative, you get into some challenging costs associated with that. But there are other communities who've used that model. We would expect that it would tie in. Each school district has to have a threat assessment team, and we would envision that they would tie into those school assessment teams, almost like a level 1 and level 2, so that it could be escalated to a team that might have a little more resources and focus in there.
Okay, I think Senator Perry, I can't.
Yes, sir.
I can't see when you push the button. Just nodding at me helps. But
I was just going to ask while you're on that topic. We've obviously been having the conversation for a couple of days. So a terrorist threat assessment's made. We don't believe the kid should be left around his peers or his authority groups. Does your model envision that child still staying at the home environment, or do you think that's an inpatient?
So I think that's a part of what the assessment will be done by that team, right, to make that distinction. Because in some cases, you don't want to do more harm, right?
So the team's not been assembled. It
is not. No, as I said, this is a visioning process for us. We don't have it in place today.
So my interest in that is if you determine, and I'm reminded that under our existing programs, the kid goes home at 4. And goes home at 4 o'clock. And so the fact that he doesn't have to go home, but he's released because he's still in education. So my comment earlier was, we can't really educate a kid that's in trouble, especially at that level, until we fix the issues if we're fixable. And so we've made this, I think the mistake we've made is we've got to leave them in the education environment while we're trying to deal with these issues. So you would be an intense mental health assessment, rehab, all the things that go with it, and then maybe put them back into an education environment, or would you see that? I guess it yet to be determined, but my concern is we've overlooked the obvious. If a kid's reached the level where he's willing to do harm to himself or others in peer groups or threat thereof, whether he has the capacity to fill it or not, that's an issue. And we put them into an education environment with this oversight role that you're going to learn these ABCs, Johnny, when Johnny doesn't care. He's checked out. So we've got to have that middle level, if you will, the middle where we put them till we can deal with them before they're back in the education. I would love to have your input as you go through this and your expert advice on what that looks like and where we can be better. Because today we put them back in an education environment. We just take them out of one environment, put them in the other, and say, we're going to educate you even though we haven't dealt with you. And that's not a success formula. And actually, it makes them better criminals, I think.
Yeah, and so, to follow up, and, I kind of brought it up from my transcript with all of my superintendents, that concern of I'm trying to educate a child who has made threats or is troubled, and the example, was made over and over by different superintendents of, I'm not sure we're equipped to handle the complexity. Sure, we deal with a lot of complexities, but when it reaches another level, but they're back in our schools and maybe with the same threats. So you think an interdisciplinary team to assess the level of threat, and then what would you do? I mean, where does that child end up?
Yeah, I'm sorry, please.
Where's the child end up?
Yeah, so I think that's part of what the vision is to try and create a team who has that ability to kind of do an enhanced threat assessment if need be, right? I think the schools do them and probably do a really good job, but there is that next level that becomes concerning. But I think the focus is not just on that assessment, but how do we do that long-term engagement? How do we screen and identify serious threats? How do we connect those youth to constructive interventions, whatever that might be, and it might be different.
And where does, one of my superintendents said we need more residential treatment centers, of which, we know on the CPS side, I'm handling a lot of that, but we need a place for this child to be able to go heal with expertise, not necessarily be in a regular classroom on a day-to-day basis with all of the pressures around he or she. And so what are those tools? What does it look like to you?
So I think putting a child in a different placement is a different conversation, but there are crisis respite units. I know as I was listening to the conversation earlier, there are different kinds of beds that you can create. There are residential beds, there's hospital beds, there's crisis respite beds where you can create a short-term gap. We don't do most of the crisis respite beds that I know of in our communities are for adults, but there are some for youth. We're contemplating creating a bit of a crisis respite kind of diversion program in Harris County right now for youth. So there are some options that you could create kind of that space. Now, they're not voluntary hold, lockdown, that kind of thing. They're open and
and I mean, maybe DEA or the acronym, I sometimes invert that, shouldn't be like a punishment, but a help place. Like, I mean, you look at, he got referred to alternative education program for punishment. Maybe that's a place that you go to seek, extra help. And it's not put in a classroom where they just sit there all day and get to sleep or whatever it is. I mean, we're looking for solutions here.
And I think all of those should be on the table. I think it is important to balance that with the stigma issue. I think we don't want to stigmatize those youth, but I think engaging them, and that's one of the things I like about our vision is that it does have DA involvement or ADA involvement. And so if a referral has been made for a criminal charge and it meets the threshold for that, that's a part of that discussion and decision. Do they file that charge? Is there an opportunity for diversion after the filing of that charge? But the court might be able to influence the youth and families engaging in care a little bit where we might not be able to compel it.
Senator Perry?
Thank you. So I'm going to kind of pitch it from a little bit different angle. You have the expertise and the wherewithal to do mental assessments. And in that vein, I think you could make some statement, if you're willing to, on a deterrent effect to those kids that flippantly make a comment that in today's world we can't just walk away from. You do an assessment. But is it fair to say that if you got that started to where kids that were watching, there's a watching effect, right? I'm not going to go there because I don't really mean it, and I'm being stupid at the time. We don't want them in your facility, obviously. But somewhere in that interaction with kids, they pay attention to what's going on around them. When you start having this pretty quick response that we're not going to tolerate that, and if you do that, we're going to check you out. And stigma or no stigma, we're missing what we used to have as deterrent to bad behavior. I'm not using you as a mechanism to get there, but in today's world, we don't get the luxury of ignoring it. We had people ignored all of the signs from the individual in Uvalde. Yeah. And so there's got to be some honest assessment from a mental health level that it's not really a mental health issue, but there is mental value from a perspective of kids paying attention that this person got that treatment for being stupid and saying things that they shouldn't have or threatening things that they shouldn't have, yet they're normal, they're just being stupid kids, and we got to be careful with how we filter that. But we have lost a deterrent in the classroom. So is there not a benefit associated with disengagement?
So I probably couldn't speak to a benefit perhaps for the person who's making flippant comments. I don't think there would be that benefit on someone who goes through with a school shooting. I don't think the present consequence would change that dynamic at all.
But that goes back to my point. There are some kids that are non-responsive, checked out. They're either paranoia, they're either so consumed with a fear or narcissistic belief that, you know, I'm better than everybody, I'm going to show them that I am. I mean, all of those psychiatric processes. But I want to be cognizant of the fact that when we're having conversations, you can't stigmatize, you can't do X. We have lost the ability to have any semblance of consequences for bad actions in what I'd call, this is not the correct term, but in the normal population that don't have mental health stigma or issues. So there is some benefit to that. I knew in your profession you probably wouldn't want to go there, but it's real. If kids see Johnny get in trouble for being stupid today at a very significant level, most kids that are normal in their thought processes, that don't have these trauma issues or whatever induced environmental issues, will give a second thought to being stupid.
Just a couple of quick questions. As it relates to a threat assessment, would you agree with me that we have a juvenile justice system and that if there are threats that rise to the level of criminal behavior, then those kids, whoever makes those threats, and there's probable cause, then they go through the juvenile justice system, or reasonable cause. Go through.
So that's what we're trying to parse.
Is that, would you agree with me that there is a system in place?
Yes, there is a system in place.
Okay. And the fact is that they have people in the juvenile justice system that do additional assessments to make a determination as to what the proper disposition of a case would be. Is that correct?
Yes, we in the Harris County Juvenile Probation, it happens to be our physicians that are doing those assessments.
Okay, speaking to the microphone.
I'm so sorry, sir. Yeah, I said in the Harris County Juvenile Probation Department, it happens to be our physicians that are making those assessments.
Okay, so there's a system already in place, and there's no sense coming up with a quote, quote, another system to, frankly, be repetitive of the juvenile justice system. And in addition, the juvenile justice system already have beds available. Is that correct?
Can I provide one clarification?
Please.
I think the distinction is that we're trying to find a path where we can do that assessment without those youth having to go into detention.
Okay, but I mean, what I'm hearing is that we're talking about, and don't get me wrong, I've seen some of this stuff about profanity towards teachers and making threats towards teachers and things like that, which no one says is the right thing to do. But what I've also seen is funding of systems. We'll start off with the necessary funding for a system, then all of a sudden, budget woes, and then that funding goes down because they're not a high priority anymore. But the juvenile justice system, there's a formula for funding of the juvenile justice system. And so if we want to look at some of these issues, I think we should look at it through the lens of the juvenile justice system.
Next, and I think Senator Perry wants another shot at it.
Thank you, Mr. Chairman. Just a couple of quick questions, Mr. Young. What you described about how threats are made, process for the things that you do in the mental health arena, are those processes any different for the child that is in guardianship or foster care or CPS? Are there any differences?
So the one difference, and every community is probably a little different. In my community,
say again?
I said every community is probably a little different. At least in the community that I'm in, what I know is that we have a program specifically designed for multi-system youth that are in juvenile probation and in the foster or CPS system. And so often they would come to us in a slightly different way, and we would provide services in a more coordinated way than what might be traditional.
Okay. Is there a concern, because I've seen this with constituents in the district, that we talked about in earlier panels, parental consent for examination, but there is a very healthy fear, in my view, on parents' parts, that there is a concern that in bringing a concern to a psychiatric professional, that's going to get me placed in the CPS, DFPS attention span, and in some way, shape, or form, I'm going to be adjudicated as an unfit parent. Because we have also created in our care for children, we've created a perverse disincentive to get your child care, because it might mean taking your child from you.
Mm-hmm. So I'm not familiar with a situation where...
Hold on.
I apologize. Yes, sir.
No apology necessary. I just want to... So I want to know, what are the things that are in the psychiatric care arena that we're making sure that we're not breaching that trust of the parent and creating a perverse disincentive to getting somebody the help they might need now?
Okay, thank you for the opportunity. So all of our care is delivered in partnership with families, and most of the time our families come to us with frustration. It's probably more common where I've had families say, look, if we can't figure this out, I don't know how I can keep providing care for my child, more so than someone is going to take my child. I've been doing mental health and behavioral health for a long time and don't know of any situation where someone's child has been removed because they sought mental health help. That's just not something I've ever come across. And it's not a common fear that's expressed by the families that I deal with. Now, I will say that everything we do, and you've heard people talk about parental consent, that's a critical component of everything we do, but also the confidentiality laws that exist. Like, for me to reach out to CPS is a very, very specific set of circumstances that don't just involve someone having a mental health condition that needs to be treated or cared for. And so there's not a whole lot of leeway for an outreach or an engagement of those other systems that sometimes appear to be adversarial or perhaps create that conflict or anxiety.
Okay, all right. Thank you.
Thank you for your question.
Yeah, real quick. So back to the terroristic threat. So do you rely on the school to make that determination, or do y'all have your own processes that would determine that? And the reason I ask that is there's a TEA definition of what a terroristic threat looks like. And what I'm told from my superintendents and folks alike, that is so narrow that a kid can actually make a threat, but that kid would not be considered a terroristic threat unless it considered some other factors. So is your definition what the districts have decided and you take it and run with it, or do you do a different assessment to determine if it meets the criteria?
So most of the people that would come in contact with our team and that are entering into this conversation today are people who've been referred by the district to the DA's office for consideration of charges for a terroristic threat. So I'm guessing it meets that legal criteria.
Okay, so you don't try to reinvent what a terroristic threat looks like. You just take...
We're responding to the youth that are already there.
I got you. I appreciate that. Thank you.
Thank you very much, sir.
Thank you.
So Dr. Caballero, would you please state your name for the record?
I'm Dr. Celeste Caballero, and I'm from Lubbock, Texas. Thank you for giving me the opportunity to speak today. I've practiced general pediatrics in Lubbock, Texas for 2 years at an urgent care facility. And prior to that, I practiced for 8 years in San Angelo at an FQHC, La Esperanza Clinic. And I'm here today representing Texas Medical Association, and I'm also representing several specialty societies that were listed in our written testimony that was submitted by our president, Gary Floyd. I would ask the committee today, have you ever wondered what it's like to be on the medical front lines with us doctors? Have you ever wondered what it's like to see patients with mental health struggles? I'm going to give you a little bit of a sense of that, and I'm also going to give you maybe some possible solutions to gun violence. As we've heard today, preventing gun violence is a really complex issue, but I'd like to speak specifically about a two-pronged approach to preventing gun violence. So number one, we ask that y'all support and bolster the medical mental health care system within our state, the psychiatrists and primary care doctors like me that are taking care of these sick patients. Number two, we're asking that you enhance family, child interventions, as well as augment investments in social services to build strong, resilient Texas families. So first, as we talk about building the mental health care system, we've been talking about that all morning, and I wanted to highlight one of the programs that was spoken about extensively by Dr. Lakey, and that's CPAN. So that's the Child Psychiatry Access Network, and I've actually used that program within the last year. I will tell you, we know, as was spoken about earlier, we know there's a large shortage of psychiatrists in our state. One estimate is that we have a shortage of about 1,000 psychiatrists. That's one estimate there. And we know that many of these families are seeking mental health care from people like me, the primary care provider, the general pediatrician, the family medicine doctor, the OBGYN. Those are generally the doctors that families are seeing first for mental health care. But I want to tell you about a story that I had within the last year in my urgent care setting. I was in the urgent care seeing just the regular cough and colds throughout the day, and all of a sudden, a very distraught father came in with his adolescent son. And when I sat down with this father and heard his concerns, it was very clear that this adolescent had a serious mental health illness and had a serious crisis as far as mental health goes. And I felt that this adolescent needed help immediately, and I also felt that I needed the help of a psychiatrist. And so thank goodness I had remembered the emails sent to me by the consortium and by Texas Pediatric Society, and I remembered about CPAN. I called CPAN, and within 5 minutes, I was connected to a psychiatrist. I was able to give the details of the case, and the psychiatrist gave me his opinions, his recommendations, and that moment, that day, that adolescent received the mental health care that he needed. I was very grateful for the CPAN help as well, and just of note, it was interesting because that father had actually gone to about 6 pediatric offices that day asking for an appointment, and all of them turned him down because his adolescent had a mental health complaint. So that was also interesting. Second, as we talk about building strong, resilient families throughout the state, it's important that we talk about something called adverse childhood experiences. Maybe you've heard of this before. It's also been talked about, abbreviated as ACEs. So physicians are aware that when children experience trauma or significant stress, this actually affects how children behave and how they feel. Some of these traumatic events are much more common than you think. So some of these traumas can be something as like child abuse, child neglect, parental mental illness, parent drug use, parent alcoholism, witnessing domestic violence, parent divorce or separation, or even a death in the family. So we know as physicians that as children are exposed repeatedly to these ACEs or adverse childhood experiences, we know that later on in life, they're much more at risk of things like depression, suicidal ideation. They're much more likely to use drugs and alcohol. They're much more likely to be involved in intimate partner violence and teen pregnancy. But there's good news here. There's good news. And we know as physicians that positive experiences in childhood, specifically safe, secure, nurturing relationships with trusted adults such as teachers, extended family members, parents, counselors, we actually know that those types of relationships can negate the toxic effect of ACEs, and that's a powerful thing. We feel that as we address ACEs and we address these effects, we know that children can thrive and be more resilient. And through this, it's our hope that we can start preventing gun violence in our communities. Let me give you an example. So several years ago in my practice in San Angelo, I had a child in my practice who his parents began using methamphetamines. CPS got involved, and he was removed from the family not just once, but twice over a period of about 6 years. I continued to care for him in my clinic, and we were treating his poorly controlled asthma. The good news was he had wonderful foster parents, a wonderful foster mother. He had wonderful teachers at school who were extremely supportive. When he came to our clinic for visits, we gave him new children's books, and we encouraged his family to read together. And over time, his parents worked really hard at their substance use disorder, and eventually they were all reunited. And what was amazing about this child is, again, it was about 6 years from the time he was first removed from his family to the time when he had final reuniting period with his family. And you know what? He was happy, and he was a resilient child. He was in school and excelling. He was making A's. He was reading above grade level, and he was invited to participate in the Gifted and Talented program. In addition, his asthma was even better controlled. And so this is a wonderful example of a child that's now on a trajectory of success, and he's healthy physically and emotionally. And so I've given you a little bit of a sense of what it's like to be in our shoes on the medical front lines. And just in summary, we ask that, again, you bolster the medical healthcare system in our state and provide those community interventions, social services needed to provide strong, resilient children and Texas families. So thank you.
All right, thank you. Questions, members? First of all, I'd like to say, you said you had that child that had a problem that came into the office with his father.
Mm-hmm.
You knew there was a problem, and you called the consortium within 5 minutes. They responded, and
yes,
yeah,
that's
and
correct.
They did not ask you to come here today. You came on your own. That's very good advertisement for the consortium. So I'm very tickled to hear that, because it's a new program, and we always wondered just how well they're able to reach out. I know getting a program started and expanding it and improving it's a whole different thing. But that's a good report. So, members?
Doctor, it's good to meet you today. I had not met you.
Thank you.
In being in my district on only San Angelo and Lubbock. It's good to know you're in Lubbock, and thank you for your time. Thank you for your testimony. Thank you for participating. And we need to hear encouragement from actually things that have worked the way we hoped they would, because a lot of times all we hear is when it doesn't work.
Right.
But that was important, and I thank you for being here and taking the time to do that.
Thanks.
Campbell?
Thank you, Mr. Chairman. Thank you both for your testimony. It's just really a comment. I appreciate your focus on, because we're looking, we're having the aftermath of the Uvalde shooting. So thank you for your focus on and encouragement on it's the mental health that we need to bolster and show support for, rather than just addressing an inanimate object. So thank you.
Yes, sure.
Thank you. I thank both of y'all very much for coming here, for what you do, and taking the time to be here with us today.
Thanks. Thank you.
Okay, I call up from the Children's Hospital Association, Dr. Stephanie Chapman, and from the Meadows Found Mental Health Policy Institute, Dr. Andy Keller.
You missed it. You're psychiatrist.
What? Oh, I'm sorry. I skipped one. So let me back up. I was correct on the Children's Hospital Association, Stephanie Chapman, but also for the Texas Psychiatrist, Dr. Rosny Coley. Is that correct? All right, my mistake. So Dr. Coley? All right, we'll start off with you. That's where we had it on the list. So please state your name for the record and make your presentation. Thank you.
My name is Roshni Kohli. Honorable Chair Nichols and Senate committee members, thank you for convening this special committee and hearing testimony about two critically important public health crises, firearm injury and mental health, and for the opportunity to testify today. I am a board-certified child and adolescent psychiatrist and medical director for pediatric mental health at Dell Children's Medical Center, a part of Ascension, Texas. In my role, I oversee clinical operations for an entire continuum of pediatric mental health care, from inpatient services for children who need the most acute treatment, to outpatient services, to pediatric subspecialty clinics, to a partial hospitalization program and intensive outpatient services, and our continued growth through the Texas Mental Health Care Consortium. In addition to my clinical roles, I lead Ascension's Firearm Injury Prevention Task Force at Dell Children's. In 2019, following the tragedy in El Paso, Ascension's president and CEO stated, "We view gun violence as a public health issue that must be addressed," and reiterated that Ascension stands with its spiritual brothers and sisters in the Catholic community, including the Leadership Conference of Women Religious, the United States Conference of Catholic Bishops, and the Catholic Health Association, to ask our elected officials to address the issue of gun violence. As of 2019, firearm injuries surpassed motor vehicle collisions as the leading cause of death for children and youth in the United States. Preliminary institutional data shows a 26% increase of firearm-related injuries in ages 0 to 16 years of age from 2019 to 2020. Our multidisciplinary team is implementing consistent counseling about the importance of secure firearm storage for families and education initiatives for the next generation of pediatricians. Firearm safety will require comprehensive policy solutions. This includes obtaining epidemiological data to inform implementation of evidence-based firearm injury prevention tactics. According to the Society for Research in Child Development, the risk of death by suicide is 4 times higher for adolescents living in a home with a firearm. There are millions of children who witness or are wounded by firearms each year. And as a practicing clinician, I see firsthand the psychological effects, including post-traumatic stress disorder, anxiety, and depression. Also and importantly, according to research, diagnosed mental illness is not a specific predictor of violence of any type. Individuals with mental health conditions are more likely to be victims, not perpetrators of gun violence. Addressing our pediatric mental health crisis also demands multi-pronged public health solutions. Texas children need access to mental health services across the continuum of care now more than ever. As part of our Texas Child Mental Health Care Consortium partnership with the University of Texas at Austin Dell Medical School, our team has increased pediatric health access in our community. Our UT Dell Med Hub has engaged 79% of all pediatric primary care physicians within our 13-county catchment area. And we have partnered with 21 school districts and 299 campuses. Unique to our program, we offer consultation to school staff, providing education and guidance for any mental health concerns for their students. We provide urgent assessments, often same day, and psychiatric consultation, intervention, and coordination with primary care providers. Despite the growth and success of our programs, gaps exist due to a shortage of qualified providers, need for increased state resources for pediatric inpatient mental health beds, and health coverage that is often inadequate to meet these services. Lack of critical behavioral health resources in the community continues to bring increased number of children to our emergency rooms in acute mental health crises. community resource for children with co-occurring intellectual and developmental disabilities, now autism, and mental health conditions are relatively sparse. In our efforts to continue to work specifically with this vulnerable population, we've partnered with the Meadows Mental Health Policy Institute to look at ways in which to identify best practices and solutions. As you and your colleagues work on a multifaceted response to keep our children safe, we encourage provision and access to mental health resources across the continuum of care. While support and expansion of the programs through the Texas Child Mental Health Care Consortium contributes infrastructure for pediatric mental health, additional resources to provide pediatric crisis stabilization and respite will be vital. We support critical investments in pediatric mental health infrastructure, including increased mental health bed capacity and workforce. Mental health parity is needed to bring comparable coverage of physical and mental health services. We thank you for your continued work to make access to telehealth services permanent. Increased access to mental health through these tools, including audio-only or telephone services, is critical to serving all children in our state, complementing in-person services. Thank you again for the invitation to testify and for the committee's work to keep our children safe.
And thank you for being here today in your presentation. Members, do we have any questions? No? Nope. Dr. Campbell, nobody? We appreciate your presentation. We have the written and I'm also glad to hear, and I've kind of glanced through it because I got it just by the time you started talking. You also were a strong supporter of the consortium.
Yes.
I believe it is a successful program that should be expanded. I appreciate that. So thank you very much for being here. And we'll go to Dr. Stephanie Chapman.
Hello. Thank you, everyone, for the time to speak today. My name is Dr. Stephanie Chapman. I'm a psychologist and director of primary care at Texas Children's Psychology Service. I want to thank you for the opportunity to speak and for all of the investment that this Senate has already brought to Texas children's mental health. The trauma following the devastating event in Uvalde must be addressed, and as this committee studies a pathway to provide more opportunities for Texas children and families to access behavioral health, I hope to talk about a roadmap for our children's hospital systems. In the wake of COVID-19, we've seen a staggering increase in the number of children seeking mental health services at our hospital ERs. As an example, Texas Children's has had at least 350 mental health crisis patients per month since August 2021, over 400 per month every month since February 2022. The demand is only increasing as the pandemic has progressed. For the first 2 quarters of fiscal 2022, referrals for outpatient behavioral health services has ranked #1 at Texas Children's, surpassing ear tubes, tonsillectomies, and setting of broken bones. Similarly, other children's hospitals across the state are seeing the same staggering increase. In Dallas, Children's Health System of Texas reported a 270% increase over the last 5 years in ER visits for mental health concerns. At Driscoll, we've seen a doubling of children and adolescents in their emergency department who had suicidal or homicidal ideation or attempts. And at Cook County's hospital in Fort Worth, they've seen an increase in behavioral health consults of almost 350% from 2015 to 2021. And suicide attempts among children and adolescents rose by over 200% over that same period. Prior to COVID-19, there were gaps in our mental health care, and this continuum of care is only showing more gaps as we move past the pandemic. Comprehensive children's hospitals are committed to serving the needs of their communities, and we are grateful to legislature for the funding of the Texas Child Mental Health Care Consortium. While the consortium does amazing work, its focus is on lower acuity care, and the children whom we're seeing are needing higher levels of care. The mental health crisis that children are facing is large enough for all of us to play a role. Some of the major issues that we're seeing from the children's hospital perspective, as has already been stated, is lack of acute pediatric inpatient behavioral health beds. Those needing beds are waiting hours to days in ERs and having to travel hundreds of miles to get a bed. Many children with acute issues are not being granted admission to beds because there aren't enough beds. We're also seeing the next step down of care as having a large gap in terms of lack of partial hospitalization programs. This care is really important because generally psychiatric hospitalization is not going to make a child fully well and able to return to outpatient care and school. And a partial hospitalization program will allow children to go to daily intervention services while continuing their schooling with the tutelage of a licensed teacher. And we need to see that development. We're also seeing a lack of residential treatment facility beds, even though I know that the state is investing in this. Many adolescents need long-term care for significant mental health issues. Children and adolescents can improve significantly with good residential treatment programs, but there are not enough of them, and they are not adequately reimbursed. And as everyone has already stated, lack of workforce. The state continues to face shortages of mental health professionals. The one thing I might add are shortages of mental health professionals who speak Spanish, as well as mental health professionals who reflect the communities that they serve. All comprehensive children's hospitals' goal is to keep children out of crisis, living safely at home with their families, and not returning to our emergency centers. I'm happy to share next how Texas Children's Hospital does this, as well as some strategies that may be strengthened and expanded across the state. First off, investment in reconnecting youth back to their communities of care after acute psychiatric hospitalization. After a child in crisis is stabilized, we need to reconnect to the communities. When young people leave their psychiatric hospital, they need immediate medication titration and immediate plug-in into behavioral services. And there are gaps in the system for that. At Texas Children's, we're investing heavily in this in many ways, with behavioral health providers in ERs, intensive IOP treatment services where children can step down for care, as well as increasing behavioral health provider staffing so that children can engage in 7-day outpatient care services where that behavioral health provider will help to plug into pediatric care and alert schools to the need as children return back to school. Another area where we want to see more behavioral health support is schools and school-based mental health care. One thing that would be very helpful is universal screening with parental consent at the school level for screening for emotional distress and behavioral disturbances. Just as schools complete vision screenings and verify immunization status for all students, they can use brief, validated tools to assess how students are feeling and coping, while also asking about adverse childhood experiences that increase risk for mental health concerns. Schools can also provide universal mental health curriculum in their classrooms that include education about coping skills, recognizing symptoms of emotional distress, and coping with stressors. These universal interventions are very low cost to implement, can be provided by school guidance counselors or nurses, and do not require mental health specialists. Others that have presented today have talked about a third level of intervention that is helpful to see in the schools, and that is increasing behavioral health clinicians on site at schools to provide targeted, evidence-based interventions for commonly occurring mental health concerns such as anxiety, depression, and disruptive behaviors earlier in the continuity of psychiatric illness so that children can engage in those services more quickly and easily, and we can prevent acuity of care. And fourth, if schools are screening and engaging in early intervention, then that is going to help them better identify the youth that need more systematic and intensive care. And that will better help the schools to be able to address behavioral disruptions and aggressive behavior issues with behavior intervention plans and referrals to specialized community partners. Another area that we haven't talked a lot about today, where I would recommend to the committee that we improve in terms of mental health services, is integration in pediatric primary care, as you noted as well. And this is a wonderful place, pediatric primary care, to meet families where they are and provide mental health services in an unstigmatized way, especially serving historically underserved communities. Most children and adolescents see their PCPs at least annually, often many more times than that. And pediatric primary care providers are often the most trusted health authority that families engage with. Embedding behavioral health clinicians in the primary care environment provides several benefits. First off, primary care providers are already doing health screening annually, and so adding in behavioral health screening can help, again, identify children who are at risk of mental health disturbances and get them plugged into care much earlier than we see currently in our communities. The PCP can get immediate assistance from the behavioral health provider in the same office, including having that clinician come into the PCP exam room to assist with assessment and care planning. And often bringing that behavioral health provider into the same room with the trusted PCP breaks down a lot of the stigma that keeps families from engaging in behavioral health care in the first place.
I'm starting to get some questions. So, Senator Kokhorst?
Yeah, thank you so much, Dr. Chapman, for your presentation. I want to go to the first page of your presentation. I think it bears repeating. In the wake of the COVID-19 pandemic, a staggering increase in the number of children seeking mental care entered the Texas Children's Hospital system. Texas Children has had at least 350 mental health crisis patients per month since August of 2021 and have had more than 400 per month every month since February 22. The first 2 quarters of FY 2022, referrals for outpatient behavioral health have ranked number 1. I want to say that, number 1, surpassing ear tubes, tonsillitis, and setting of broken bones. So with that statement, why do you think the mental health crisis has been so large since COVID-19? It's not the disease itself. What has caused this?
First off, Senator, thank you for emphasizing that because it is such a key point.
It's a staggering statistic.
It is, and it's overwhelming our workforce and causing burnout with our clinicians. There's many reasons, but the social isolation that children experienced during the pandemic, the closure of schools, the isolation of families, increased risk of acute stressors, economic stressors, and then loss of caregivers to death to COVID and family members are all contributing towards this mental health crisis.
So I think it's really important that we understand that the very policies of COVID-19, of shutting down schools, isolating children, have caused another crisis. I think that we will be dealing with this for years, if not decades. The bad policies of COVID-19 have led to a tremendous crisis in our children. I mean, wearing masks for forever and ever and ever. I mean, I will just tell you that, you know, I had children in the public school system and children in the college. It's amazing what those children lost during that time. So, Mr. Chairman, if I have to, under legislative privilege, I asked the question yesterday and didn't get the answer, but we're here today because of a tragedy in Uvalde. We know that that perpetrator was truant. And I could not, we know that he was truant off and on since 5th grade. But it's unclear, I'm not sure he ever went back to school after the school closure, which we talk about all the mental health services that could have been wrapped around him to maybe the warning signs. And so, Mr. Chairman, if TEA cannot provide that to us and we have to do it under legislative privilege, I do think that with this staggering statistic that mental health referrals have outpaced ear tubes, something that's fairly common in children, tonsillectomies, and setting of broken bones, potentially, again, a very violent act created from, we know, mental health, his issues, and maybe he never went back to school post-COVID shutdowns, I think is extremely important. The lack of residential treatment facility beds, how do you define those? I mean, like, what do they look like to you? I mean, like, I hear this from superintendents. You know, I'm from the CPS, you know, I oversee DFPS, and we talk about residential treatment centers, but that's usually when a child has been removed from the family. So when you talk about residential treatment facility beds, what does that look like in our communities?
For sure. From a clinician's stance, these are facilities where children who cannot get better with outpatient mental health care or 1 or 2 or 3 psychiatric hospitalization stabilization programs, these children need to be able to go to a longer-term setting where they can receive occupational therapy, schooling, individual therapy, family therapy, close psychiatric monitoring over a series of weeks to months, so that they can then step back down to outpatient care and school and work in our communities.
And I would probably ask HHSC, or I'm not sure who would have the data on how many beds are there in our communities across the state. I'm sure you don't have access to that.
I don't have the data. I have the anecdotal evidence that children I will send to psychiatric hospitals again and again and again. We have to call their health insurance and call their care managers and beg and plead to eventually, months later, get them in bed in a residential facility.
So, Mr. Chairman, in conclusion, I just want to, again, underscore the importance of the policies of COVID-19 have led us to a mental health crisis. And as the practitioners have said, we will be dealing with them for years to come. And it's growing. It's not going down. It's growing because of isolation and because of those things. And I'm so frustrated, but we're going to work through this. We're going to keep at it. And we're going to figure out how to make these children better and a way forward and to socialize them again. I talked to so many of my superintendents and teachers, and the behavioral problems, the anger, the acting out that they're seeing in classroom. And I often ask them, and these are just teachers, you talk about a burnout profession, and they say they lost so much structure by not being in the classroom that so many of the younger children don't even know how to act. They're relearning that again. And so the social and emotional stressors, and we're not even on the academic progress that they need to be making. And so it's going to take us all as a team to overcome this. And then I hope that we write the lessons learned from, just like we were trying to do at Uvalde, that we do from COVID-19 to prevent this crisis in the future. Thank you so much.
Senator Campbell.
Senator Kolkers, I'm sorry, could I ask Chad just one more comment? You know, the crisis, the mental health crisis was rising even pre-pandemic. And you're absolutely right. I agree, it was certainly exacerbated. But suicide became the second leading cause of death for ages 10 to 19 or 10 to 34, really, pre-pandemic as well.
I couldn't agree more. I mean, we were putting money into the mental health crisis, but again, you cannot refute the numbers. In Dallas Children's Health System reported a 270% increase. Having behavioral health become the number one referral over ear tubes, tonsillectomies, and setting of broken bones is a staggering statistic, and one that we must accept. We can't go back and change the past, but we can certainly set a path forward. And I'm looking in the windshield with the lessons of the rearview mirror. Thank you.
Senator Campbell, I think you had a question.
Thank you. Well, a little bit of my thunder was just stolen, because I was going to say the need for mental health support is real, and it's been there. But the problems we see were present before COVID, well before COVID. And what I haven't heard all day today is the effects of social media, hate music, gaming, violent movies on television or out in the theaters. No one's mentioned that and the effects it has on the brain. You want to comment on that? Because that's ignored. We have laws against hate speech, yet we've got music that couldn't be more hateful. We've got children that isolate themselves and they're on their cell phones. They're texting. They're doing games where they get points for killing someone. but I haven't heard comments on that. And that is a true problem. Go ahead, both of you, if you would.
Would you like to? The first thing I would say is there is, of course, some research that shows that violent media and video games has some detrimental impact on young brains. What we know, though, and what I would say as a clinician, is the social isolation of children who are in their homes 24/7 and not engaging in other activities because of doing electronics.
Okay, and
might be an issue.
exactly, because that was occurring even before COVID. So measures, whether we like the measures we did, isolating folks in the home or not, the problems that we're seeing are pre-COVID, exacerbated by COVID. And yet I don't hear anything even much at the federal level or here as to what to do, interventions directed at that. We're not asking our schools to take out all electronics, to have children start having some social, normal interaction with folks rather than talking to their neighbor on a cell phone. Go ahead, you were going to comment too.
Sure. Thank you, Senator Campbell. No, I absolutely agree that social media does play a role in everything we are seeing today.
And so with that, and you're both very gentle, and it's no wonder you're working with children, and I'm in an emergency room, but with knowing that, there needs to be interventions that we can do as state government to try to impede the effects this has. However it is, no matter how bad somebody doesn't want to listen to it. We need to do something. And so I challenge who you represent to come up with interventions to work on the platform that isolates these children and adds to violence. That's all they're looking at. And for a male whose frontal lobe isn't fully myelinated till age 25 or 26, that's a long time to have their brains looking at social media that promotes violence. Thank you so much. Thank you, Mr. Chairman.
Senator Hinojosa.
Thank you, Mr. Chairman. Thank you both of you for your excellent presentation. Mental health underfunding has been a problem way before COVID. We have used our jail system to take care of people who are mentally ill, incarcerate them, and we are trying to address that issue, but it's a very serious issue. Beds are available. The problem is you don't have the healthcare staff available. Lack of doctors, psychiatrists, nurses. And the pandemic only made it worse. And what we have now is more child abuse because the kids are not in school. The schools have been shut down. So teachers don't see if the child or the student is being abused or not, as they would normally when schools are open. And that's a real serious problem. You talk about isolation, with the parents also suffering mental health issues. And you stated very well, concerned about their jobs, concerned about their budget, concerned about their child not learning. So those are all challenges that we face. But we have increased funding. We were increasing funding on a regular basis, but we have accelerated the funding for mental health. I think we have over $8 billion for mental health across various state agencies. The problem is that the system is not set up yet, and it's catching up. And it's a real challenge because as we try to focus on mental health issues, I heard testimony about some of our children that we're trying to protect all Texans, not just people who are mentally health challenges. But I think Dr. Coley said that on the average, 8 U.S. children ages 0 to 12 are killed by firearms every week, every 2.5 days. A child or a teen is killed by an unintentional gun injury. That's an amazing statistic. I just wonder how that compares to children committing suicide in schools. And we have tried to address this issue about gun safety, and we passed legislation trying to make sure the parents are educated, trigger locks and everything else. What would you suggest in terms of trying to focus more on gun safety?
I'm sorry, could you repeat that last part of the question?
What would you suggest we could do to focus more on gun safety, to keep guns away from children by having parents lock them up or not have bullets in the chamber or have a trigger safety?
Thank you for that question. You know, as a clinician, when I see an individual that is suicidal, one of the things that I do is a comprehensive risk assessment. And if I determine that they're at acute risk or increased risk of harm to self, one of the first things that we do is work with the family to make sure the home is as safe as possible. So I think one of the first steps is education, ensuring that if firearms are present in the home, that they are securely stored away. We know that for most suicide attempts, they're impulsive. We know most adolescents and young adults, back to what Senator Campbell was saying, that their prefrontal cortex is not fully formed and developed. They're more impulsive. And so if we can remove means of access by which individuals can die from suicide, we will be more successful in reducing the rate of suicide.
And what about accidents? You have, you read stories on a regular basis in the newspapers about one child playing with a gun and shooting another child or a young adult who they didn't know was loaded or for whatever reason didn't have the safety on. And it's a real serious problem. When you have this many children being lost to guns, not only suicide, but unintentional gun injuries. It's just an amazing statistics that it really shows the range of challenges and problems that we face in trying to make not only our public schools, but homes safer for our children and the public in general. But thank you for your testimony.
Thank you.
I had one, since we have you two experts here, and I want to thank you, Senator Hinojosa, about suicide and the thoughts there. Post-pandemic, I've been told teenage girls are at greatest risk right now. Are y'all seeing that in the ideation or attempts?
I'm seeing that for self-injurious behavior, eating disorders, and suicidal ideation. For adolescent males, I'm seeing a lot more concern around substance use, aggressive behaviors, and depression as well. So I think girls present and note symptoms and will talk about symptoms more, so get treatment faster than young males do. So I think in that way, our young males are often underserved.
And go ahead, if you...
I agree with that completely. I would also add that we are seeing an increased number of children that did not have pre-existing mental health concerns that are coming in for suicide attempts for the first time, as well as seeing children who had pre-existing mental health concerns that have been exacerbated over the last 2 years.
It's a real issue. On the substance abuse with males, and again, looking at, we do not have the toxicology report, as I ask, from the perpetrator. And I look forward to getting that. But I've recently read an article about the use of certain drugs, as you talked about, as the brain is still forming, and the long-term effects. As you say, post-pandemic, with males, you see that up. Suicide attempts or ideation, manifesting it in females. What are the long-term effects of recreational drugs and other, you could throw alcohol in there, on developing brains?
Would you like to take this one?
Sure, happy to take this one. We are seeing an increased rate of substance abuse across the board. And for children, adolescents, their brains, because they're not fully developed, are much more vulnerable. And so we can see effects.
Most often, what are you seeing when you say substance abuse? What kind of substance?
We're seeing marijuana, we're seeing increased vaping and nicotine. We're seeing certainly drugs like cocaine, alcohol. I would say the most common things, we're also seeing methamphetamines and LSD. I think it is across the entire spectrum of substance use that we are seeing.
What's the most common you're seeing in substance?
I say marijuana is probably the most common. And one of the particular worries, with marijuana in particular, is that for adolescents whose brains are still forming, it can actually dull their cognitive abilities. It can affect their memory, their concentration, their ability, their overall intellect. And so all of these substances have a significant effect on the growing brain. And it also is oftentimes, we see comorbid mental health conditions, so things like depression and anxiety. And we're seeing children and adolescents that are sometimes using substances to self-medicate the underlying symptoms of mental health distress that they are in.
Recently, the Wall Street Journal published an article similar to that, and the effects of marijuana and those which we have asked multiple times, what are some commonalities with mass shooters? And it was an interesting article. If y'all don't have it, I'd be happy to provide it to y'all. And I hope there's more research in this regard. Again, as we look to the toxicology reports and other traits, mental health, and looking to work through these issues and complexities of our society today. Thank you.
Just a statement. We also want to include the opioids, fentanyl, because coming across the border, that's a major thing right now. So we can't forget what that is. Thank you. Thank you, Mr. Chairman.
All right. First of all, thank you all both very much for your comments and for taking the time to be here and for the work that you do for the citizens of Texas. Your comments have been very helpful to this committee. So thank you all very much.
Thank you.
Have a great day.
Thank you for
Drive
the opportunity.
Careful. Next up is the Meadows Mental Health Policy Institute, Dr. Andy Keller. Come up, please state your name and make your presentation. Lois?
Well, good afternoon. My name is Andy Keller, and I'm the President and Chief Executive Officer of the Meadows Mental Health Policy Institute. And I want to thank you, Chairman Nichols, members, for letting me be here today and for calling this great group of people together to try to find some solutions on how we can prevent tragedies like we had in Uvalde. I also want to start out by thanking the Lieutenant Governor and the Senate for their investment and commitment to mental health over the last 4 legislative sessions. We are in a much better place today to be able to put additional resources, prevention deployed throughout our state, not just because of the resources, but because of the way you have organized those resources and brought together multiple providers across public and private sectors to try to care for all Texas children. One thing I want to specifically take on before I get into my testimony, though, is this sort of widely bandied thing in the media that Texas ranks 49th in mental health funding. We do not. The most recent study that was based on was from 2015. That study did not include the nearly $3 billion we spent on Medicaid that year. It did not include the nearly $500 million we spent on mental health through our district program. And it was 7 years ago. It predates all of the investments. Even the other rankings where people talk about access were done in 2018, 2019, and they merged together policy questions such as lack of insurance with actual access to services. So I would really caution you to actually use those reports as they were intended, and I wish the media would as well, which is to look at specific policy questions, but not to put an overall grade on one state's mental health. So I just wanted to say that because I think those media accounts are wrong and they need to be pushed back on. I think that's the main thing I would say, other than just to remind you all that since the 84th legislative session in 2015, y'all have increased your investment in mental health by 34%. So I think we could be pretty proud about that. And I also think, too, that you can only increase over time as your workforce will allow. And we're going to talk about that because these sort of things require multi-year efforts. And these are things, frankly, that no other state is taking on at the scale that Texas is. I want to talk a little bit about what is mental illness. Sadly, I got to have a similar conversation with many of you at a select committee in late 2019 after the terrorist attack in El Paso and the Midland and Odessa shootings where we talked about mass violence. There's actually been some things, unfortunately, we've learned since then through additional studies that I'll talk about. But I want to begin by saying that mental illnesses are discrete and treatable health conditions. They are not brain abnormalities. They are health conditions that can be treated, such as anxiety that disrupts functioning, depression, PTSD, bipolar disorder, schizophrenia. And it's very important that we all keep in mind that mental illnesses on their own do not cause violence. Violence itself is not a mental illness. And it's very important, this, because it's very complicated. There are specific mental illnesses that I'm going to talk about that increase the risks for violence. But the reason why it's so important that we make this distinction and point out that negative, antisocial thoughts, feelings, actions that are associated with violence are typical human behaviors that can come about from all sorts of motivations, everything from self-sacrifice to hate. And those are not mental illnesses. And the reason it's so important is there have been centuries of prejudice against people with mental illnesses that have equated mental illness with violence and perpetuated a belief that among members of the public, that's still widely prevalent, that mentally ill folks, such as me, I have an anxiety disorder, are violent. They are not. The statistics on the entire group of people with mental illness are not differentiatable from the population as a whole once you factor out substance use and other factors that are common across both populations. So I think it's really important that we say that at the beginning. That being said, there are links between violence and specific mental illnesses. So severe mental illness drives slightly more risk, 3 in 100 composed to between 1 and 2 in 100 for violence of any type against self or others, not just mass murder. By the way, the reason I'm talking about violence is mass murder is so rare that we cannot look at studies just of that in large scale. We have to look at the overall scheme of violence and say, what are the common factors and what are the things we can learn from that to try to prevent mass murder? Mood disorders, such as major depression, are primary drivers of violence against the self. People with anxiety disorders like me are actually no more likely to harm anyone. If you have my particular one, I mentioned this last time I testified, you're also not more likely to use the wrong lane at the checkout store at the store because you're very careful and anxious, so you don't hurt people. But an untreated psychosis makes a person 15 times more likely to commit murder. And the wonderful thing about that statistic is treatment alleviates that risk. So these are treatable illnesses. They're not the same as evil. The thing that's been new, though, since 2019 are 2 reports that came out in 2021 focused specifically on mass violence across large groups, and one specifically by the U.S. Secret Service in 2021 on mass violence in schools. The one in 2021 didn't just look at shooters, they looked at averted plots, which is very important because we can avert plots, and that's part of what the evidence shows. And there's tremendous similarities I'm going to talk about between all of these young people that are different from mass violence in general. But when we look at mass violence in general, there was a very important project that came out last year that was based on over 170 instances of mass shooting that basically concluded that these are best thought of as violent suicides, where somebody has given up hope, but part of their equation on giving up hope is they have turned that hope and that anger against a group that they hold responsible. So there's very much a mental health component of that and something that we can, in many cases, treat if we find it early enough, which of course is hard, and we're going to talk about that. I want to talk specifically, though, about mass murders in schools because they're a distinct subset. They are exclusively boys. They are exclusively under the age of 20 or 21. Their brains are not fully developed. They're still basically developing adolescents. They are almost all exposed to early childhood trauma. They have instances of school discipline. They express hopelessness and despair and isolation. That's that violent suicide sort of thing. They generally experience bullying and severe abuse. There's an identifiable crisis point, usually with suicidal ideation, and self-hate turns against others. And the issue is that while that is the profile of these school shooters, it is also the profile of other young adults who are never going to do that, but the other bad things are going to happen to them. They're going to drop out of school and be, most of them, not really great members of society. They're going to get involved in juvenile crime and have a prison to pipeline kind of from schools pipeline thing going on. They're going to hurt themselves and they're going to hurt other people. And we've included a chart that really looks at deaths among Texas children from violence more generally, because while our hearts break for the 19 children that were lost in Uvalde, there were over 400 children last year lost to violence in our state. And if you look at the chart, it was the first year where losses to homicide went above losses to suicide. on a per capita basis. And those losses disproportionately affect Black children and Latino children and other marginalized populations. So it's really important when we think about this that we're not just talking about interventions to help that shooter. I think the analogy I would want to use is we have about 10,000 of these people out there that meet these profiles. Once every few years, you may have one that's going to have the conflagration of events that would allow them to potentially be on a school shooting. But those 10,000 youth every year are in our juvenile justice systems and are in our child welfare systems and are having tremendous expenses right now. And the interventions that I'm going to talk about today are ways that we can have much better outcomes if we scale them up, and also much better cost effectiveness if we scale them up. So I want to begin with the work of the Texas Child Mental Health Care Consortium. And I won't repeat the testimony that was done earlier today. I thought it was an excellent overview of the program and talked about many ideas about how to scale that up and how important it is for being able to find and engage these youth and their families. And that's a very important part of this, because the only proven treatments that work for people of this age involve caregivers. And if I could talk about one thing that predicts involve parents and caregivers. And if I could note one thing that most predicts treatment failure, it is the lack of engagement of the parents and caregivers. In fact, one of the services I'm going to talk about, multisystemic therapy, its main quality indicator that they use for the oversight of whether a program works or not is how much the caregiver, the adult that's taken responsibility, believes they have been helped. It is absolutely essential. It's not just about parental consent, it's about engaging parents, which can be hard, and I'm going to talk about how that works. I do want to say, though, that there are some real barriers as we scale up the TCHAP program in schools, and the biggest of which is not money. Y'all have allocated money. It's really workforce. And one thing we have observed and recommended is that the consortium be given authority to expand the range of partnerships that can be involved and to more actively engage local mental health authorities, community-based organizations, to be able to surge that workforce under the guidance and under the supervision of our medical schools, but to have additional workforce. And that's going to be hard because all of those providers are strapped as well. And fortunately, there's some legislation being looked at in Washington, D.C. that could increase some resources there, though I'm not holding my breath for anything coming out of Washington, D.C. I put more faith in y'all. And I think the other piece that is coming, that's important there, is recognizing, and I think Dr. Lakey talked about this, that the local mental health authorities themselves are struggling to compete for workers, not so much with other healthcare providers, but with other businesses in their communities that are now paying tremendously higher rates. So you can go be a manager at Walmart or in a retail setting or a restaurant and make as much or more as you were making with the much harder work of a local mental health authority. So it's really important. The other piece I want to emphasize too is that the cost of the TCHAT component of the consortium are $25 million a year. And for the 18,000 people that have been served in the last year by that program, and for which we are still scaling up, right? So we're going to have additional people scaled because it's actually not operating at full efficiency yet. The costs are less than one emergency room visit cost. It's under $1,500. So when we think about these are for urgently needy children, these are not for your routine cases. They're to find the kids that are scaring people, that are worrying people, that are upsetting people, and to engage their families in care. It's actually a very cost-effective intervention. I want to talk specifically, though, about what you do when TCHAT needs more, because often these children, these 10,000 children at the highest risk, need more than just telehealth. So the function of TCHAT is to find them, assess them, figure out, kind of winnow who's going to need these more significant services, but then they have to have something to step to. And Mr. Young from the Harris Center talked earlier today about the multisystemic therapy program that y'all funded last session that they have stepped up and implemented along with a similar organization in El Paso, Emergence Health Network. And the thing that's so cool about those programs is they're doing it before juvenile justice involvement. We cannot wait until these young people are arrested to do that. And look at this instance of the Uvalde shooter. He was never arrested, but we had lots of warning signs, and he is the kind of person who exactly fits the profile of what we would see for multisystemic therapy. These are youth who don't have a psychosis. They don't have a more severe mental illness. What they really have is a combination of depression and some level of trauma that leads to anger, and most importantly, a lack of structure at home to be able to have effective caregiving for them as children. And so MST works well more than half the time. It's one of the most effective. It works better than residential care. And we have 7 teams, but we need to ramp that up dramatically. And there are providers out there who could provide more capacity immediately were we to fund that. The other treatment that's for a smaller group are for the young people that have psychosis. Now, when we look at school shooters, actually very few of them have psychosis. Psychosis is something that can affect other violence, but in the school shooters, just a handful do, because psychosis doesn't really emerge till your later adolescence, early adulthood. However, for that subset that does, it's very important that we continue to expand access to the gold standard for psychosis, which we have implemented as much as anybody here in Texas, called coordinated specialty care. And we need to continue to invest in that and make it available, and try to get some of these insurance companies to pay for it so that my kids could get access to it, because my kids are just as likely to need this type of care, and I would have to go pay out of pocket for this from a mental health authority or from a university to get it, and we need to try to make that available more broadly. We also need to respond to children when they're in crisis. And we have some wonderful mobile crisis outreach teams in this state, but the proven intervention for children and families looks different. It's not just a person coming out to assess a risk. It's a person coming out able to come before the crisis and be able to stay with that family for 60 to 90 days to support them as they engage in care. Because that bridge, particularly for a family suffering from a chaotic situation without adequate community supports, adequate housing supports, is going to need hand-holding and help and support to be able to make that engagement into care. So these pediatric crisis stabilization and response teams are something that, frankly, we recommended last session to help respond to some of the crisis in our foster care system and some of the crisis in our hospital emergency rooms, because these are proven to be able to maintain foster placements, to divert children from emergency rooms, and help people successfully transition to the community. Finally, there's some other things to think about, because it's not enough to just do mental health. We think the iWatch Texas program needs to be leveraged to assess and act effectively on school-related threats. We don't want to make mental health providers the threat assessors. They are clinical assessors. We want the threat assessors to be carried out by people in the justice system who are able to work to protect people's constitutional rights, as well as carry out investigation of weapons. And that's not something we're very good at in the mental health industry. The Texas Education Agency needs to have resources, because schools need technical assistance in how do they make use of these resources. It's not enough to just provide TCHAT. Schools have to have effective referral and parent engagement strategies around that, and to make sure that all of this happens with parental consent, because it's the only way statutorily and also, frankly, clinically it can be provided. Psychiatric bed capacity is also needed, and we need to be able to deal with the backups we have in our justice system that are impeding our access to psychiatric beds more generally. And finally, the workforce. And I talked already about how with the workforce, we need to broaden the array of workforce that we engage in these different providers. We need to broaden to some private sector folks who are able to provide things like MST beyond our public system through appropriate procurements that kind of do apples to apples. And finally, we think we should ask our licensing boards to say, can you do more? Can we do more to have expedited licensing? Can we get more supervisors so people don't get backed up in the various supervisory pipelines where we have too few supervisors? And can we do what you all did with physicians last session, which is to create compacts and other agreements so we have reciprocity with other states, so people who move to Texas, who are happy to move here, can quickly get their licenses in place, and people in telehealth networks can serve people here in Texas. So thank you for this time, and I'm happy to answer any questions.
All right, thank you for the presentation, Senator Perry.
Thank you, Mr. Chair. Specifically, I'm going to go back to the Uvalde shooter. If I'm understanding you correctly, you believe had intervention occurred that guy was redeemable or salvageable, or I don't know what the right term is politically, but basically you think we could have intervened and fixed that individual?
I would say that the symptoms that were documented in the media, which is all I really can go on,
sure,
that were evident in the fall of 2020, almost year and a half ago, were profiles that we treat every day. And we have success in well over half to 2/3 of the children. And the primary thing that differentiates whether we have success is whether we're able to engage that family and back them up and give them the
support. So obviously he had no family dynamic. He was living with the grandmother. He had, from 4th to 5th grade, something happened. There'll be research, I assume, that'll go back and figure that. But the family dynamic's non-existent. But you make an interesting point. I think you just said effectively 2/3 respond favorably and move on in life with minimum issues with, I guess, monitoring and pharmaceuticals and everything else. But what do you do with the other third?
Yeah. The other third, we're going to maximize things if we do things like multisystemic therapy, because that's going to push the percentage up. Because what multisystemic therapy does is it really tries to build that caregiver cadre. So like, take this young man's grandmother. Clearly not able to provide the care he needed. I'm sure she was doing what she could, but they build other adults around her. And in the first month, they're going to spend 100 hours with that family saying, where's a cousin? Where's an uncle? Where's a pastor? Who's someone else there? So we're going to increase that, but we're still going to have, a good chunk of folks. And this is the unfortunate thing. We have youth who do not have parents. And that's really where the residential system, our justice system, others are going to need to come into play.
I like Meadows a lot. I think they're quality. I think they shoot straight. You're kind of giving me the answer that no one is willing to give me. There is a segment that, going back to old school, we used to institutionalize. And there is still that existence, correct or not correct?
Well, unfortunately, there are children that have been institutionalized because of a lack of adults in their life.
I think that's a point I want to keep hammering on, that at some point there is a group that is not, quote, fixable or will not adjust to norms that would fit into a societal model without fear or threat of harm. They've crossed over. There's some kind of connection or of antisocial, whatever, but we seem to always overlook that and don't want to talk about that. And the reality is, based on, and I'm not holding you to the numbers, but you just said that there is a segment, be it a third or whatever, what we come in contact with. And from a school shooting perspective, it is that third that gives me the most heartburn, because it may not be 17 years old while he's in the classroom. It'll be the 21-year-old when he's out of school, or the 18-year-old. And those are the ones that we have a challenge to find out. Because if intervention works, great. If intervention doesn't work, great. It's the challenge of catching those people so that we know from 18 forward, this is an individual we need to be concerned about.
Yeah. Can I comment on that?
Yes, sir.
I think the operative term is "and." We have to look at that group. And the neat thing about TCHAT is that it helps us identify these children when they're in school. So even if we're not able to do something successful, they're on our radar. We're watching. There's going to be legal involvement for most of these youth, even if it's something as simple as truancy. Those can be cues for being able to get that youth under the supervision. And I really think, unfortunately, incarceration doesn't really rehabilitate. All it does is let us monitor them.
Sure.
Try to keep them
So the
hurting
second
people.
point you're making, and I've tried
Can
to
I add
make-
one more thing, Senator?
Yes, I'm sorry.
Because I think the other piece I just want to make sure is clear is we have 7 MST teams in Texas right now. Actually 9, thanks to y'all funding 2 more. We need 140. So we're not catching the 70% and helping them. We're letting them all go through the dam right now, except for those few we're able to get to the few services.
So the second point I'm hearing clearly you make, and it's one that we've talked about, we acknowledge, but then we just blow past it as it's not relevant. There are legitimate indicators inside our school system that would indicate this person's in trauma, or we need to have a conversation. But truancy keeps coming up, and truthfully, truancy is one of those indicators that we have chose to effectively kind of gut to where we don't really have a lot of conversation about it. It's not worth the time, expense, or efforts to do something with the truancy issue, but that is an indicator that something's going on.
I see truancy and other school discipline as indicators of need. And
Right.
so if we respond with a expulsion or law enforcement, we're not going to actually meet the need. We have to say, these are red flags and we need to act on them.
I agree, and I think that yesterday the sheriff said it best. I don't want to write another 6,000 citations. I've been there before. That doesn't fix it. But he followed up with, we have to find the proper intervention, and I think that's where your solutions come in. And so I'm not looking for punishment or punitive or unrealistic citations that can't be paid and parents get in trouble for not paying them, et cetera. That's not where I'm going. I think that we have to be bold enough to acknowledge that's the problem and go after it and intervene at an appropriate level. What do you do with the kid that doesn't want intervention and the family doesn't care?
So there's a couple things we need to do with them. One is there are things we can do in school. We actually are working with school districts in the Permian Basin, and we're working with school districts in North Texas that are looking at alternative disciplinary approaches within schools to be able to really educate these children and being able to provide some structure around them. And the school can provide some structure. It can't substitute for a parent. But there are a handful of these young people who, if they don't have effective supervision at home, are going to be able to latch on to something at school.
I asked it a while ago, though, that we have made a critical decision error in my point that we take a kid that's in stress, having these indicators, and we pull them back into an alternative education program thinking the results are going to be different. I make the argument, I've said it and I'll continue to say it, if a kid's at that level of stress, we've got to deal with the medical/behavioral/health issues before that kid can sit in a classroom and learn.
I would argue that you do it at the same time.
You can do it.
You can do it at the same time. So I would say that when they're in the acute stage, you want them, probably in a hospital or a partial care program, give you a few weeks to stabilize that, which Medicaid pays for, the state pays for, and then being able to transition them back with the supports. It's a dual thing.
That's not the system we have, though. To be clear, the system we have takes the kid out of the classroom, moves them to DAEP on campus. If that doesn't get their attention, then they move them to JJAEP, which is akin to the criminal justice system, the juvenile criminal justice system, in a classroom setting without really, because they don't have those. It is not their expertise, and any legitimate probation/juvenile detention center will tell you that is not a child that we can help.
And Senator, I would totally agree, and that's because we have this huge gap around intensive community-based services like MST. We don't have that in the vast majority of cases, and you put that into that pipeline, it's going to divert.
I'm going to ask you the same question I asked the other two. Do we have a mid-level fix available today before the kid's put back in an academic area? We may get him fixed and go back to traditional classroom. We may get him fixed and he still needs some structured environment, but we don't have that bed space today in Texas of substance.
It's going to take 3 to 6 months with intensive services to make that change, and you don't want a student out of school for 3 to 6 months.
That's the answer.
So I think you're going to need them back in school at some point before the 6 months, but not in those first few weeks.
I hear you. Final question, it's not off the topic, but it's what role does, and it was kind of talked in the previous panel, I meant to ask it, for someone that's decided to commit suicide by action such as a shooting, is there an element that I'm going to gain notoriety? Does that play out in the social media platforms? And if not for social platforms, would they still go commit that probably? Or is there not an element of narcissism / I want to be recognized today? Is that a real component and almost consistently could be said?
Yeah, absolutely. What you just said is almost a direct quote from the U.S. Secret Service report.
Really?
Yeah.
Well, I get lucky once in a while. I think we cannot stress enough that the interaction with our media companies that have thousands of employees monitoring this stuff, understanding the privacy issues and understanding all those nuances, but we have to have a little more clearer path to catching those, because someone that is in that mindset, I think, does want the notoriety, does want the significance in perpetuity for bad or good, that wants their name in the book, so to speak, because they feel that way. And I think we're ignoring the opportunity to do better catch of those folks. Thank you.
Senator Perry, if I could just comment on that. Senator Campbell raised this question with the earlier panel about social media and these types of things. The American Psychological Association is in the process of putting together a report on ways to combat that. We can talk to them and see if there's some preliminary components of that they may be willing to share, and we'll get back to you about that if you would like.
All right, the next question actually was with Senator Zaffarini.
Thank you, Mr. Chairman.
And then Senator Kokhorst, did you also? Okay, followed by Senator Betancourt.
Thank you, Mr. Chairman. Thank you, sir, for your excellent testimony. I certainly appreciate it, and I agree with your perspective. Did I hear you say that a coordinated specialty care plan is the gold standard for young persons?
Suffering from psychosis. Yeah, if they have sort of hallucinations and delusions, a very severe mental illness that kind of takes them out of reality a bit.
But how do we explain that? Last session, for example, I had a bill that required group health benefits plans to cover coordinated specialty care for a person younger than 26 who suffers an episode of psychosis, specifically the group you're talking about, but couldn't get a hearing. How do we educate people about the importance of this program for the specific group we're talking about?
Well, it's a wonderful question, Senator, and that's the key. I mean, we released guidance 2 years ago on how to bill for that. We said there's actually codes you can use, and we put that out, and it's helped move the conversation forward. Right now, we're trying to partner with the private sector. We're working with the Dallas-Fort Worth Business Group on Health, the Texas Business Group on Health, and the Houston Business Coalition on Health, all of whom represent self-insured funders, not just businesses, but also unions, municipalities. And those groups have identified as their biggest concern as employers is unmet mental health needs. And many of them are aware because while these are relatively rare cases, they really affect people and they really affect families. And so that group is working very actively. I've had an opportunity to testify before the U.S. Senate looking at parity enforcement. I do think the Department of Labor's efforts to have better enforcement on parity are going to help, but I do think there is an opportunity for Texas to, create the kind of dialogue with. I think we have to have it be a private-public partnership where we're going to have to show the benefits of that and then look at how a regulatory approach could help support that.
Well, I would appreciate it if you would go back and look at that Senate Bill 1144 and perhaps advise me about how we can improve it or how we can tie in its relevance.
We'd be honored to do that.
Issue. Thank you.
Yeah, we would be.
On pages 3 and 4 of your written testimony, you talk about mental illnesses as related to thinking, emotion, or behavior. Now, sometimes it's all three, correct? Thinking, emotion, and behavior.
Correct.
And then on page 4, you talk about what mental illness is not. But yet, looking specifically at your last bullet point on page 4, where you talk about the centuries of prejudice against persons with mental illnesses and how many members of the public assume that any act of violence is related to mentally ill. We hear it all the time. Somebody is a child abuser, he's mentally ill. A wife abuser, mentally ill. A shooter, mentally ill. How do we educate the public and all members of the legislature specifically who don't understand the issue about the difference in the different kinds of mental illnesses, and that, of course, we must not stigmatize mental illness?
It's a wonderful question, Senator. I would say that having sat in many of these hearings over the last several sessions, I believe that education is happening. I mean, the questions I'm asked today, the discussions I hear, the public statements I hear made are much more trying to walk that line, and it's super complicated. Personally, I think the best thing we could do is mental health professionals could start being more specific, because too often we come in and we say, oh, well, you just need more mental health care. Well, no, don't fund general mental health care. These are specific disorders. And if you just put money out there, it's not going to go to these specific disorders. A great example of that is the federal block grants that go to community mental health. No one was putting in place coordinated specialty care teams until they put a 10% set aside on that, and they said you can only spend the money on this. And we were fortunately really able to use that and leverage it here in Texas. So I think we on our end need to do a better job of being specific and not just talking about mental health in general. I don't even like to talk to people about mental health. I'm like, what are you talking about? Are you talking about depression, PTSD? It's sort of like talking about physical health. I'm gonna go treat your physical health. Well, okay, you're gonna like resuscitate my heart? You're gonna like give me insulin? I mean, those are pretty different disorders. So I think a lot of it's on us, Senator, and I think we're trying to do a better job, but we need to do better.
My question is, how do we get that done? That's what I don't know.
I guess I'm saying if we in the mental health profession don't make those distinctions. I've seen a lot of my colleagues in the media, over the last few weeks saying mental illness does not create violence. That's not helpful. You need to say that there are specific ones that do. And I think that a lot of times we're so caught up with wanting to, I think understandably, push back against stigma, protect the well-being of the people in our care. We don't want them falsely done. That sometimes we do a disservice to ourselves by not also saying these specific illnesses in these specific settings without treatment are going to lead to these outcomes. And so I really do think a lot of the responsibility, Senator, is on us.
Would you please explain the premise that most mental health conditions are associated with a comparable or lower risk of violence?
Yes. So remember, most mental health, the biggest mental health condition is the one I have, an anxiety disorder. That's what most are. We're like, we don't park in the wrong place. We're very anxious. And so you put all of those together and you look across the entire group of people with mental health concerns, people with depression, the vast majority of people with psychosis. Then what you do is you factor out substance use, because there's a higher use of substances among people with mental illness. But if we weren't using substances, and also if we take out family violence, because people with mental illness have families, and we get in conflict with our families, and we have girlfriends and boyfriends that we get in conflicts with. If you take out those common factors that are exactly the same in someone without a mental illness, then overall, the risk goes to normal, and then among people with severe mental illness, it goes down to 3% versus 2%.
Thank you. We've talked about many of the characteristics of shooters and what they have in common. Would you say that self-harm is more a predictor of suicide attempts than it is of mass homicide?
I would say it's a predictor of violence.
Of
I mean, if
violence.
someone is going to engage in self-harm, that is a form of violence. And I think it's somewhat artificial to differentiate between violence towards oneself and others from a clinical perspective. The antecedents, the treatments are very similar. There may be additional things we need to do when it's violence directed towards others, but the commonalities are more common than the differences in my experience.
Thank you. On page 6 of your written testimony, you refer to a report published by the United States Secret Service.
Yes.
Averting targeted school violence, and it indicates that there were 67 averted plots to identify common characteristics of mass murders in schools, and concluded pre-violence intervention is almost always possible. Almost always possible. So how do we accomplish that? How do we avert more of these tragedies?
Well, we have to find them before. So, like, I mean, Senator, I just have to say, the day after the shooting, when I read the Wall Street Journal account of him coming into school in the fall of 2020, apparently his school was in session, with cuts on his face, posting pictures of a video of a dead cat in a bag, like, I got nauseous. And I looked at the T-Chat map, and I didn't know what I wanted to see. Did I want to see that we did have T-Chat there and we failed? Or did I want to see that we didn't have T-Chat there and we failed? And we didn't have T-Chat there, but like, I mean, I wish we did. And I'm not saying it's 100%, but I'm saying I don't know a better intervention for under $1,500 per person who can detect people at risk and help get them into the right care. And so, you know, I think that's what we need. And then the other piece, too, that we're seeing in West Texas, Lubbock is doing some of this, the folks at Dell are doing it. They're actually, in their partnerships with the schools, doing education on what the risk profiles are, because you heard I think it was Dr. Coley said earlier in the last panel, oh no, it was actually her colleague, whose name I'm forgetting, but who said that, you know, young girls will present with talking about their symptoms. Boys will not. And so a lot of times when we see the symptoms of boys with mental illness present in schools, we tend to say that's a discipline problem, that's a violence problem, particularly if they're a person of color. We are going to have a 4 times higher likelihood of treating that as a discipline problem as opposed to a mental health need. So we really need to educate school personnel to say that these, you know, a 16-year-old is not irreparably bad. A 16-year-old almost always, not always, but almost always can be helped, and we need to get them into the help, and we need to have the help there.
Related to that, on page 7 of your written testimony, you have some very important information. You say that mass murderers in schools are a distinct subset, and list these bullet points about everything that they have in common, and indicate that fewer than 10,000 Texas youth fit this profile?
Yes, and they fit a profile, though, of students who are at risk of self-harm, dropping out of school, violence in general. So only a few of these folks, because it's almost like a perfect storm. And that's, again, why, you know, these are hard cases. But if we could just have changed one step in that pathway, it could have led to a different outcome. So it's not just the mental illness, it's the lack of the parents, it's the access to means, it's a combination of things, which often the main reason why young people have access to means is a lack of effective adult supervision. I'm not saying they're not doing their best, but I'm saying they don't have the resources to be able to protect that child from themselves.
Okay. Boggles the mind, frankly. On page 13 of your written testimony, you talk about the pediatric crisis stabilization and response teams. Could you tell me how that differs from the mobile crisis outreach team?
Absolutely. First of all, they're specialized. They're only for children and families. Second of all, they're a 2-person team that includes a clinician and someone like a family member who's been through the system before, who can be a coach and a support, because it's not enough to just stabilize the crisis. You have to be able to help that family engage in, sometimes it's housing that they need, sometimes it's basic supports like food, sometimes it's treatment that they don't want to do. But what they can do is they can kind of hang out, and the family may not want to get involved in treatment, but they are willing to call 911 when there's an issue. So these people keep coming out. It's kind of like community paramedicine. You know, community paramedics often have to go out multiple times times to get somebody who has diabetes or some other chronic health condition to make the connections and get the supports, transportation, other types of things they need to engage in care. These are wonderful linkages, and it comes back, Senator Perry, to the question you were asking too about how do we link parents? Because I mean, the reality is most parents, all parents, want to help their children. They're going to have concerns about whether people actually can be helpful, but these are wonderful ways to help bridge that gap and get the resources like transportation that people need.
Thank you. On page 14 of your written testimony, you touch upon workforce and say that these issues must be addressed. How do we address them?
Well, I think that we need to, I think we've been doing some things to fix them. I mean, you all put in loan repayment programs, you've put in other types. I think there are internship opportunities. I know the consortium members are looking at how they can build the workforce flow into their schools and being able to also partner with our local mental health authorities so that many of these young people have placements in the community or with our state psychiatric hospitals, so we make sure that there's also some public service there as well. But frankly, Senator, I think we need to do what we've done with every other industry and steal them from other states. I mean, I think we need to be able to draw people here, to either move here, or to be able to, if our workforce cannot muster what it needs to in terms of a pipeline of people here, to allow us to work across states with the licensures there under proper supervision, and we defer to the boards on that. But I think we have to come to terms with the fact that we have a public health emergency here, and there's a state interest in speeding access. And so maybe, you know, like we did with COVID, where we, you know, suspended laws and we said for the next 2 years we're going to allow anybody licensed, just like we did under COVID, to function here. I mean, I think we need to look at things like that. I think we should do it in collaboration with our boards. Our licensing boards are important supporters for the long-term health of our workforce, but I think we have to admit that we got something to do here. And I think it was Senator Colkhorst earlier talking about how many years it's going to take us to recover from, you know, what happened to our children during COVID. We're going to need to redouble our efforts for a while. And I think these type of emergency procedures that we used during the pandemic, I mean, I think what the pandemic showed us is if we actually want to combat a disease, we can. We just have to take the means that are sometimes unusual to do so. And I would hope that perhaps we would have the will to do that now.
Would it be helpful for us to have more fellowships and residencies in related fields?
Absolutely. You have, under actually the consortium, one of the things you did was you have almost doubled the number of child psychiatry fellowships. One issue that we run into is that across the country, we're not seeing all of those positions filled. It's good for us to have as many as possible because you're going to get 75% of whatever number you have. So to have a bigger number is good. But we're going to have to build the pipeline of physicians, we're going to have to build the pipeline of residents, but we're also going to have to look beyond that. We're going to have to look at community health workers, other professionals, faith partners. There's a wonderful program in Houston where we take the cases that are relatively less difficult and we try to have them served by people who can extend the reach of therapists and don't need to have the actual psychiatrist see that person. The previous panel also talked about primary care integration. You all created a benefit in our Medicaid system for collaborative care last session. Collaborative care is a wonderful way for every psychiatrist that practices in collaborative care. They can see 3.5 times as many children as they would in private practice. So I think there are some steps you've taken, but I think we're going to need to look at some more dramatic means and some that are perhaps time limited.
Thank you very much. My final question is my favorite question, which I've been asking as long as I've been senator, and my colleagues have heard me ask it many, many times. If you were writing 3 recommendations for this committee to include in our interim report, what would they be?
Did you say 3, Senator? Mm-hmm. Statewide TCHAT expansion with that education component, statewide multisystemic therapy, and I gotta pick one. I would do the psychiatric stabilization teams. If you do them this way, you have to do them with a child specialization, even in rural areas. You can't just have the adult person go in there. Maybe they do it through telehealth. I mean, there's ways to do that, but that would be the 3rd one.
Thank you very much. Thank you, Mr. Chairman.
Thank you. Senator Betancourt.
Thank you, Mr. Chairman. Dr. Teller, appreciate your testimony. With the last 4 recommendations that you made to Senator Zaffarini, have we done an ABC costing of any of those to understand what type of cost level we would be at?
We have.
Okay. I didn't see it in the presentation, so.
Yeah, we did not put the cost numbers in here. We do have those costs. I'm happy. I could talk about some of them, Senator, or I can also send some.
Yes, I mean, no, I mean, if you have like an example to ballpark, but otherwise we would certainly like to have the that information.
Absolutely. Let me use an example. Would that be helpful?
Sure.
So like on T-Chat expansion, we believe if you were to fully ramp that up, and I know that actually the consortium has put some numbers in place that are a little bit more precise than ours, but we believe it would be about $62 million a year to run that at full boat. Now, you're not going to get there next year. You know, it's going to be a bit of a skeleton's crew initially.
And how many either patient, visits do they make, or, telemedicine versus in person? Do you have, for that 62 million, what?
This has never been done. I mean, one thing I wish they would print in the media is like, we're the only state that has done this, trying to have all 12 of our medical schools serve every school. But extrapolating from the numbers that were shared today, it would cost under $1,500 per child served.
$150.
$1,500. Think of it more like an emergency room kind of thing.
No, well, I mean, the base rates that we calculated without having, if all $300 million were put into just a patient, the number of patients is about 30,000 a patient, but that's not counting the 48,000 effective telemedicine visits they've got. So that's why I was trying to get an ABC.
Well, that's counting the workforce component, which is distinct, counting the CPAN component, which is distinct. I mean, there's a lot of different components.
No, I know with CPAN, I remember that now. And I do agree with one comment. The state of Texas has done many things. There are people, the state of Texas has done many things. This whole program is novel and unique. And in fact, the reason why there is that program in Lubbock is because he carried a bill, Senator Perry, that I voted for, along with everybody on this table, I believe. So the state of Texas has been making these mental health decisions from the legislature and actually trying to implement them. And that may come as a shock to the people that are simulcasting right now, but it happens to be the truth. Now, when you go to were you here for the first part of the consortium discussion? Did you see my question?
I've read it and I followed it, but I may not have seen every piece.
Okay. Now, we're here because we've had another horrific, tragic school shooting. There is an idea, the reason why we're talking about this is that somehow that could be preventable. So I went over 2 examples with Drs. Lauren and David last time, which is obviously the Santa Fe shooter, who has been declared mentally incompetent, whose last major acting out was walking in with a trench coat for 4 weeks before the shooting, which was clearly against Santa Fe ISD's policy, but they didn't do anything about it. Now, when we look at this shooter in Uvalde, 4th grade apparently was the grade that he actually attended the elementary school in the classroom that he horrifically killed 20 people. And then the question is, his truancy started going up. Then we see significant problems with him failing grades, nearly almost all of his high school classes, except one that he barely actually passed. But more importantly, it got to the point where he's dragging a sack of dead cats in a small town of 16,000 people. Now, we know this because Director McCraw went through 500 to 700 interviews of people, which is a big sample of 16,000. And at least 6 of those people, about half a dozen of them, said that they would have already identified him as somebody they were worried about as a school shooter. Now, with that all being said, very dysfunctional family, nobody there to go through the normal, go to a general practitioner, go to a specialist, sign off on this and that. So with all of this, then how do we actually affect these grains of sand that we're talking about? Because we've got millions of children, and we've got these grains of sand that are clearly, by the time we got to this person in Santa Fe, I wouldn't even use the term anymore, it's an evil shooter. So what can in your program or TJAT, what can we reasonably expect that's an outcome that could affect this environment?
Yeah, so it's a couple things. It's an and of multiple things, and I think the way you lay that out was very nice. If we do the model of the TCHAP program that they do in Lubbock at Texas Tech University, that Dr. Wakefield was able to stand up with the additional ARPA funds that you all added last fall, what we would do is we would do education in the schools about what these young people look like. because they don't look like people who are suicidal. They don't make us sad, they make us scared. They make us want to recoil, they make us want to run away. And so we would be able to have those programs, and we would find, let's ramp up from where we're at, just take the numbers we're at right now, 18,000 a year in TCHAT, let's say we find 50,000. So we're gonna find 50,000 children in the TCHAT program. They talked about 14% of those folks having suicidal type of issues and self-harm issues. So you're going to find a good number of these 10,000 with that 50,000 screen. Not all of them, but you're going to find a good number of them. You're going to then need to get those 10,000 into either coordinated specialty care if they have a psychosis, which we have some capacity, but we don't have enough. But we could prioritize. We could prioritize every student who has gone through TCHAP for a slot in one of our existing programs with just, I would think, a modest increase in resources, assuming we had the workforce. And then but the bigger thing are going to be these MST teams. Senator, I would say that actually, again, I don't know this family. I just know what I read in the paper. I know also what has begun to come out through these investigations. I would actually say there was some caregiving. I mean, the young people that we have no hope for have no adults. They've been shuttled from house to house. There's no one. We have a grandma who was trying to do some stuff. We have an intermittently involved mom. We have an intermittently involved grandfather. There were adults. And I would be actually optimistic with that level of adult in the home of being able to build the infrastructure around those adults, which is what MST does. Remember, they're going to spend 100 hours in that first month talking to them, saying, what is it you need? What can we do? Is there someone at church? Is there somebody, at school? Who can watch him between 3 and 6 when you're not able to be there? And if they could do those 3 things, then 2/3 of the time, we're going to be able to help that person be on a different track, even the most severely impaired person. And then, as Senator Perry was saying, we're going to have a third that we're just going to have to monitor and try to use other means until maybe someday we do find an adult. I mean,
well, part of this is that with all the data that we've learned, and even, quite frankly, dragging a sack of dead cats around, none of that got reported. Again, and this is a staggering concept. We're in a small town with 16,000 to 17,000 people. We think the shooter was working at a fast food restaurant. You've got multiple issues. You've got truancy. You've got literally a sack of dead cats, and people thinking that there's a problem, but not one report.
Senator, what I would say is we have to make it a change as a society. When I was growing up, I had 49 kids in my graduating class. I remember these 2 kids when I was in 6th grade who we didn't want to hang out with. They were scary kids. And they burnt down one of my friend's houses, destroyed his whole house. Everybody knew that these kids were not doing okay. But we were scared of them. We didn't want to be around them. And so the idea was, what is wrong with these kids? The thing we have to shift to say is, what happened to these kids? What is happening to them? And that's a trauma-informed lens. It's a rehabilitative lens. And as a culture, we need to make that shift. And frankly, that is what the enhanced TCHAP programs are doing in schools. They're saying, look, when you see a kid with his face cut like that, dragging around dead cats, you're going to recoil. Like, a regular person with no education is not going to want to hang out with that kid. But if a teacher can understand that, whoa, this is a sign of help, and by the way, I have an easy button for help. I have a TCHAP program, which we didn't have in 2020 there. We didn't have in 4th grade. We didn't have in Santa Fe. So I'm not telling you it's a panacea. There is no medical procedure that's a panacea. The best medical procedures work, 80-90% of the time. Right. But we can do a lot better.
Well, I think that it's important, again, for people that are listening, they need to understand that the state, specifically the legislature, has taken some very unique steps, from Senator Perry's bill about Lubbock to the passage of Senate Bill 11 in the last session. Bills passed, after Santa Fe. But the problem is we're dealing with an extremely intractable, complex problem that's got granularity in the millions, because that's at minimum of the kids that are coming through the process. Now, one last thing. I read your whole presentation. Even though we're dealing with young people and children, I didn't see any reference to what are now very common issues of autism, being on the spectrum, ADD, Asperger's, et cetera. I didn't see any mention of that. What role do some of these fundamental diagnoses play in this overall mental health process.
Yes, Senator, I would need to go back and look at the studies, because what we were trying to do was to say, what are the most common profiles? What are the things that most stand out? And so those are the ones we listed, but I'll go back and look at that. I don't recall. I know it was not a lot. And it was autism and ADHD. Those were,
Sure,
and
right.
then Asperger's, which is a form of
Yeah, which
autism.
is another subcategory.
So those are the ones. We'll look at that, Senator.
No, I just make a comment because, you look at the fact that the shooter couldn't turn the car, and so your question is, you have obviously some type of motor impairment. That doesn't take anything away that the person had become evil, and there was no stopping at that point in time whether he crashed the car or not. But I didn't see any of that type of information, because you've got and not that that would be a marker for shooters, but you've got a situation where you've got a very complex mental health issue that's out there in society in general.
Yeah. I'd say that there are a lot of mental health issues, and I think we try to focus on the ones that were most highly correlated. We will double check on those and see.
And you owe me the ABC costing on the 4 solutions
we will
you
do
gave,
that.
right?
We will do that. We will
Thank
send
you
that
so
to you.
much.
Prepared. Can I just
Okay, I've got some other members who'd like to ask some questions.
Please.
Senator Kokorsk.
Thank you, Mr. Chairman. Dr. Keller, thank you. Thank you for the work. I've enjoyed working with you. I think you opened some of your remarks, but since 2015, mental health money increase in the state of Texas, these are state funds mostly, there's a little bit of matching, is 34%. Is that correct?
That is correct. The other thing, Senator, that we did was we weren't counting the Medicaid dollars. So we were, we didn't get credit for everything y'all were sending to HHSC through the Medicaid program.
Yeah, so is that 34% exclusive of or inclusive?
The 34% is new, almost entirely state.
Yeah, good.
I mean, well, there's some additional Medicaid plan, but the most of it's state.
Yeah, I appreciate that so much. I want to ask you, you made a statement too, and I want to clarify. Is TCHAT the only of its kind in the United States?
I'm not aware of anything like it. I mean, when people, it was interesting, like I'd have reporters say, well, what about, we have counselors here, we have school professionals here, we have, other types of partnerships. I'm like, well, are they designed to respond to children with urgent needs and get them immediate help? Like, I mean, the thing about TCHAT is it is same day. I mean, assuming the parents are going to go along. It may take a little longer to engage, but it is as soon as that child's available. And it's an organized system. That's what's so cool about this is, you've put in place this entity where all 12 of our schools come together and share resources. Some of them don't have expertise in one condition, and others do. So it's the organized system in partnership with schools that is unique. So everywhere else has like a hodgepodge. I'm sure there's things that maybe are even cooler in an individual school somewhere. I would also add that there are schools in Texas that are doing other things. There are schools who have made their own investments, and that's fine. But the thing I think we need to do is standardize the urgent access. To say, if you're not going to do TCHAT, tell us what your protocol is for same-day urgent access for somebody who meets these profiles.
And I know I've said this, but in visiting with all of my superintendents, I do have a sampling of the different things that are going. Many of them are using TCHAT, but some have contracted with others to do exactly as you say. I want to go to page 8 of your presentation, and it's titled Death Among Texas Children and Youth, Rate of Suicide, Homicide, and Mass Shooting Deaths Among Children and Youth in Texas, 2001 to 2020. I went and got the colored version because I couldn't tell in my non-color version here about these. So it looks like homicide is on rate per 100,000 children and youth in Texas, less than 18, as the number 1. Is that right, if you look at your chart?
Yes.
Okay.
Homicide is the one that 3.1.
3.1. Yeah. Second is suicide at 2.7.
Yes.
And this line goes up and down. It was interesting to me that the 3.1 per 100,000 children and youth, which is homicide deaths, is identical to the year 2000. It actually went up slightly, then it came down. It descended in 2012 to a low of 1.4. Do y'all have any data of why that is?
And
why is it matching 2000 and 2020, our high watermarks
it's a great
on homicides?
I will double check. If you were to take that line back into the 90s, because you remember in the early 90s, we had even higher homicide rates in our nation. And, the whole, all the rhetoric around, youth being out of control, whatnot. And beginning in the mid-90s, those rates went down dramatically. And so you're seeing the tail end here that bottomed out in 2012. And I would say we don't know. I mean, I think people make correlations between societal changes. To me, what was said earlier, I think the biggest driver of any youth difficulty is isolation and lack of resources to parents.
So that's right. The steep climb right now does not surprise me, given the testimony in the panel prior to you, where they talk about, again, the rate of admission for mental health crisis. The example was Texas Children's, I believe, is number one, far and away, more than tonsillectomy, ear tubes, broken bones. So let's go to the bottom line, which is mass shooting fatalities is absolutely flatlined. It's the lowest at less than 0.01.
Yeah. Part of that's because of the scale. Like if we were to zero in on that, we would see variation because there's some years when, there may be some years when we didn't have any.
But I think it's really important here. We were assembled to keep all Texans safe. That's the name of the committee. And certainly the Uvalde tragedy, the horrific act that occurred there, brought us here today. And it's an opportunity. But if you look at how children, the deaths among children, it is suicide and homicide that are the major drivers. And literally it's flatlined on, it's less than 0.01 per 100,000 children. And so while we are focusing today on the traits of the perpetrator in Uvalde, and as you said, there are 10,000 in Texas that would have this tendency, but not all of them would commit that. But as we zero in, we have to look at some of the self-harm, the ideation of suicide, or as you say, it may manifest itself not in a mass shooting, which is defined as 4 or more per your presentation. That's pretty consistent what I see it. A mass shooting is more than 4 versus homicide, and that children are more likely to commit suicide. And going back to all the effects, as you've talked about, and I think Dr. Lakey is echoing what you were saying. If T-Chat were maybe available when this person was in, as we yesterday learned, 4th grade, everything was going okay. 5th grade started truancy, in and out, very, very inconsistent. We don't know, but we might gather that he didn't go to school post-pandemic. And I just think there's a lot of nuggets in here that we have to focus on. And that includes, as you say, all the indicators of these adverse events in children's lives. We learned just a while ago the substance abuse issue with our youth, with their developing brains and things like that. So if we pinpoint, girls, they just said, have suicide tendencies and suicide ideation. Boys are acting out in a more violent manner. Is that correct?
Yeah, so I love how you just explicated this table, because that's exactly why we put this data out here. And when you think of the 10,000, I would just quibble with one thing. I wouldn't say they have tendencies to commit violence. They have risk factors. Most of them are never going to commit violence. Most of them will never even occur to them to do that. They'll get involved in gangs. They'll get involved in, they may in the gang, but they're not going to actually.
Which leads to homicide.
Exactly, it can. So if you treat, actually, I don't like the grain of sand, because I think it's actually needles in haystacks. I think it's a little bit more manageable. And so if you take those 10,000, you're going to get a lot of these children. That's why we put this table in here, because the 10,000 is all of the children at the highest risk of homicide, suicide, and terrible outcomes, because we can't keep them in school and we can't help them become productive members of our society. So if we were to fully scale and fully make available and fully find all of these children and their families, because it's really helping their families as much as it is them, often more in some cases, these lines would come down.
And I would ask you over the months ahead let's take this chart back a little bit more, the flat line of literally there's no increase or decrease. on mass shooting fatalities, but this line is all over the place on homicides and suicides, and it's reaching an all-time high right now. And then we went to a low watermark of both of those in 2012. And as you say, maybe we could go back to the 90s and figure that out. And what was going on and what's caused that? And then post 2012, you know, I can pinpoint the pandemic, but there were things going on in looks like 14-ish that the line started to go up again.
So I think the biggest one was one you touched on earlier, which is our just being drowned in social media. And it's not the social media per se, it's what the panelist on the last panel said, it's parents kind of using that as a substitute parent. It's using the social media, letting that be the supervisory structure for children. It's also, we have additional fragmentation. We've seen fragmentation in our families and communities and I think that's gone up. But I think if you look at one thing that correlates, it's the dramatic increase in people being isolated and also not having as great of interaction with their families. And the way to do that, unfortunately, is we have to really empower parents and help them figure out how to kind of retake control. And we're working on some interventions on that. There are some cool things we didn't include in here. There's some neat things that we're seeing, interventions in primary care that really empower parents. How do you take that phone away from your kid? How do you remember, how do you exert more control over this very addictive social media that you have in your home? And so we're looking at some of those things. Those are broader prevention things. That APA paper I mentioned earlier to Senator Perry is one we'll see if we can get some information on for you.
We look forward to you pulling together that data. Been very consistent, Mr. Chairman. You said it in some of your remarks. We've had law enforcement, we've had psychiatrists and psychologists, mental health experts as yourself, superintendents, and they each echo the importance of parental involvement in children's lives. But as you say, the effectiveness of treatment in children being in dire need, that the parental involvement is super important.
Okay, we'll go to Senator West's question.
I'm just going to ask a few questions here. Dr. Keller, how are you doing? As it relates to TCHAT, is that program at middle school, at elementary, middle school, high school, or how is that program?
So it's meant to be, I'm sorry, Senator.
Go ahead.
Senator, it's meant to be available to every child in the district. Given the risks that it's focused on, they're going to be more prevalent in junior high and high school, in sort of those later middle school, early high school years. I would go back to the data. I'd have to look back at the data presented this morning. I think they did break that out by age. If they didn't break it out by age, I know they have it by age, and they could give you the exact information. But I know the intention was to serve children who are at more risk. It's not really...
And that would be on every campus in the district.
Every campus in the district should have access. Now, for example, Dallas ISD. Dallas ISD has a very robust internal mental health component that they've actually invested more in, as I know you know.
Right.
They were using TCHAT for some of the campuses that they couldn't get to because it's such a big district. So some districts will have a hybrid model where they're going to have in-person therapists at some of their larger schools and use TCHAT as a supplementary. And I think that's important to keep in mind.
Okay. We know that Sandy Hook occurred in 2012 and Parkland, I think it was in 2018. Have you done any analysis of the individuals that were involved in those shootings to make a determination as to whether, have you done any analysis of those individuals to make a determination as to whether or not we can use any best practices implemented by those states? Because I see that since those tragic incidents, there hadn't been any further mass shootings, but in Texas, there have been. So have you learned anything at all from those?
Yeah, I mean, we've looked at some of the things that were done and recommended in Connecticut. We've looked at some of the things that were recommended in other places. And I think what you would see, Senator, I guess I'd have to look again at the data. My read of the data is, we have 1/10 of the school students in the country, so we're going to have more of these because of our number of population. I'm not aware of us having more incidents on a per capita basis, but I'm not 100% sure. I'd have to go look. But my belief is these are pretty randomly done, and there's nothing going on in Texas that I believe is more likely to cause these than what's happening in other states. But I'll double check that to make sure I didn't miss something.
Are there any best practices in those states that we could look at?
Yeah, so the best practices that we've assembled here are the ones that we believe are helping. So the states, our kind of companion states, Louisiana and New Mexico, have both ramped up MST availability actually quite a bit. There's 40 functioning teams in Louisiana, and they have some excellent results. We have linked both the consortium and folks at HHSC with, some of them were already linked, with the MST Services, who compiles the data on that to be able to talk about what happened in those states. Another cool thing about having our neighboring states have infrastructure is there are providers functioning in those states who could come over and be able to be part of our workforce and help us out as we ramp these up, because MST doesn't require licensed people. MST is more of a rehabilitative service, and so you need master's level people, but the licensure is less of an impediment to ramping MST up.
Okay, thank you. Thank you, Mr. Chairman.
Thank you, Senator.
Okay, thank you very much. We appreciate the work that you do in the Meadows Foundation.
Thank you, Senator.
All right, next up is the Texas Gun Sense, Nicole Golden, Executive Director.
Dr. Kelly.
Hi.
How are you?
Hi, good afternoon.
And so please state your name for the record and begin your testimony. And the members have a presentation, I think, in everybody's packet.
Yeah, absolutely. I'm sorry. Say the last thing you said. I don't think I caught that real well. Just sorry.
I'm sorry, I could not hear what you said.
I couldn't hear the last thing you said.
Oh, the last.
Did you repeat?
I said the members have your packet,
Oh, great.
I believe, in their folders.
Oh, great. Thank you.
Thank you.
Yeah, thanks so much. Thanks for including me today. I am Nicole Golden. I'm the Executive Director of Texas Gun Sense. We are the only nonpartisan gun violence prevention organization founded here in the state. I represent thousands of Texans from a broad range of backgrounds, gun owners and non-gun owners alike, and our mission is to prevent gun violence through common sense policies, education, and partnerships with key stakeholders. Thank you, Chair, and I just want to mention I had a great meeting with your staff and just really appreciate you including us and circulating the copies that I had shared with you. I've been doing this work for nearly 10 years, and honestly, I've never seen anything like this past month, both in terms of the outrage, the despair, the heartbreak, and the outpouring of public demand for immediate action on preventative gun safety measures. It's greatly impacted me personally. I'm sure it impacted you. Texas is facing a crisis, one we know we have faced a long time. And now, in the wake of the unspeakable shooting of 19 young children and 2 educators at Robb Elementary School in Uvalde, the world knows it too. The gun violence crisis, however, is not new here. The Center for Disease Control's data shows us that the firearm death rate among Texas children ages 0 to 17 has more than doubled since 2015. Solutions that only address mental illness and school security are not adequate alone. Even with more funds and better enforcement of policies, experts have said there's no indication that intensifying school security has prevented violence. Yesterday, we heard for many hours, as you know, DPS Director McCraw speak about gaps in the system that led to the failure to save the lives of the students of Robb Elementary School. He spoke about warning signs. The gunman threatened to shoot his grandmother, which he later did before entering the school. He asked his sister to purchase a gun for him, demonstrating a clear intent to back up his threats with violence. And then, on his 18th birthday, he purchased a semi-automatic weapon used to inflict generations of trauma on Texas families. Session after session, we've come here to this legislature to advance policies such as an extreme risk protection order that would fill many of the gaps Director McCraw spoke of. This is an evidence-based legal tool to empower law enforcement and families who are in crisis to avert suicides and homicides. These tools, enacted through a civil process, work. For example, in the year after Florida's extreme risk protection order went into effect in response to the shooting in Parkland, law enforcement filed almost 255 unique petitions in Broward County in which individuals with firearms had made serious threats of violence. We've also come here to advocate session after session for a stronger vetting process for the purchase of firearms. You may or may not know that around 80% of all guns acquired for criminal purposes are obtained through transfers from unlicensed sellers. We've also come here to advocate for safe gun storage and reporting requirements for Texas's alarming rate of more than 1,200 lost and stolen guns, and those are the only ones that are reported. I think it's probably much higher. And for protections for domestic violence victims to address the 150 Texans a year shot and killed by a partner, and the clear connection between domestic violence and mass shootings, which is known to be around 60%. Those bills, frankly, have languished in committees, and instead, resources have been spent weakening our public safety. The time to end that dangerous trend is now. A new poll that just came out, conducted by Third Way and Republican polling from GS Strategy Group, found that 75% of Texas voters support red flag laws. 90% of voters, including more than 8 in 10 Republicans, conservatives, and gun owners, supported requiring background checks on private transfers. And 80% said they support increasing the minimum age to purchase a semi-automatic weapon from 18 to 21 years old. These aren't just polls, these are Texans. You know, when tragedies hit, people understandably look for answers. And the answer comes in the form of prevention, not reaction. Background checks on private transfers may have prevented Midland, Odessa. Extreme risk protection orders may have averted El Paso. Child access prevention laws may have prevented Santa Fe. Domestic violence protections may have prevented Sutherland Springs. And age restrictions for semi-automatic firearm purchases may have stopped Uvalde. These major events are compounded by the daily gun violence crisis that claims the lives of more than 4,000 Texans every year and costs the state $16.5 billion. I know you all know that yesterday the U.S. Senate unveiled a historic bipartisan gun safety bill with a Texas senator at the helm. You here have the power to reach across the aisle, to enact measures that most Texans support and that will help prevent more shootings in our communities. You know, we've been here before. We've visited your offices. We've sat at round tables and offered database solutions, which we'll continue to do. We are a resource to you all. But this all happened as the gun violence crisis raged on, though we tried to curb it through the work that we do. And here we find ourselves again. I know I'm here to present to you, but as I sit here, I want to ask you and I ask myself, you know, what solutions can we get done together right now? How can I help or be a resource in any way to bring us together to implement substantive change immediately? I want to urge you not to let another moment go by without advancing preventative gun safety legislation in honor of Uvalde, in honor of your children's and grandchildren's schools, and in honor of mine. Thank you, and I'm happy to talk more with you.
Thank you. Senator Zaffarini.
Thank you, Mr. Chairman. Thank you for your excellent testimony and for your leadership in addressing these issues for so long.
Mm-hmm.
You stated at the beginning that you are not partisan.
Mm-hmm.
Given your experience working with the Texas legislature and having studied the polls, many of whose results you included in our notebook or you gave us in a handout, what is your best estimate of the kind of legislation that the Texas legislature, not only the Senate or the House, but the Texas legislature could pass with bipartisan support and have it signed by the governor?
That's a great question. Yes, we are a bipartisan organization. We don't work on elections. There's about 19 states that have passed, for example, an extreme risk protection order, or otherwise known as a red flag law that I talked about. Many of those had bipartisan support behind them. So I think that's very clear right there. Many of them moved forward because they had bipartisan support, and in some cases, like in Florida, it was after a horrific mass shooting in which the legislature acted quickly as a team.
Thank you. Is there a bill, or are there several bills that you can point to that have been passed by legislatures with bipartisan support that you believe the Texas legislature should and could consider?
So ones that we have come forward with that have not passed here? Is that what you're asking?
Well, whichever, whether they've come up or not.
Yeah. Extreme risk protection order, I would say there's an urgency behind it. Background checks on private transfers is absolutely something that I think we need to move forward on immediately, and the polls show high support for among a broad range of Texans. We can also pass domestic violence protections. Last session, I believe that there was a bill that we helped support simply to just ensure that there was proper relinquishment, in which somebody who's a convicted abuser and is a prohibited possessor, legally they're already supposed to relinquish those weapons, but kind of is there oversight for that? I think things like that can be considered fairly low-hanging fruit that we could all get behind.
Thank you. I don't know anybody who doesn't support the Second Amendment in general. Perhaps there are disagreements about specifics and how the Second Amendment impacts specific issues, but everyone I know supports the Second Amendment. How do you respond to people who say that we should not pass any new gun reform laws because of the rights under the Second Amendment?
I would say that I speak with full confidence that none of the laws that we have brought forward here take away Second Amendment rights for responsible citizens.
And when we deal specifically with red flag laws, how do you answer criticisms related to due process, lack of due process?
Yep, it's a reasonable question. There is a clear due process through a civil proceeding to allow for potential, to allow for someone to receive their gun again should they no longer present a threat.
Thank you. And do you have to have a lawyer?
Yes, it's absolutely a legal process. And it's really a partnership, I would say, between our public safety officers and families in crisis to go through that court system together. You have to present a clear threat. There's a long list that has to be checked off.
When you address specifically the issue of raising the age required to buy an assault weapon, how do you answer critics who say that somebody can be recruited into the military or could join the military at age 18 and have access to all sorts of weapons?
I would kind of say this, is that there's plenty of science behind the human brain. And I'm not a scientist, but you can read this, and people have been talking about it a lot this month for good reason, is that the prefrontal cortex is not really fully developed until, 25 really. So I think that makes an argument for raising the age. I think that I've never seen polling in favor for something like this ever. I think it speaks to the moment. I think people want to see this. I think it makes sense to people. And, we saw Buffalo followed by Uvalde. I think it's one way that Texas voters want to get behind to do something.
How could this committee make a difference that you believe would result in our protecting all Texans, especially students and teachers and staff in schools?
Raising the age specifically?
Whatever.
The way I've been doing this a long time, and so the way I view gun violence prevention is there's not one solution, and there's not just one form of gun violence. We have to throw all solutions on the table. And I think some of what I presented to you are those solutions. Are they going to eliminate gun violence completely? No, I certainly will fight until we have a future free from gun violence. But if to push to advance other solutions that have been spoken about, these past few days, and not to include these, I think, would be a grave error. And I think that there's data behind these. They're proven. Other states have done them. Our U.S. Senate is moving forward, and we need to do it too.
Thank you. On page 6 of your written testimony, you included Governor Abbott's policy recommendation. Do you support, or does your organization support all of those recommendations, or only some?
We were part of the roundtables that took place in 2019. We were a resource at that time. We were glad to be there. And in the school safety plan after the Santa Fe shooting, Governor Abbott did demonstrate interest in mandatory reporting of lost and stolen firearms and something kind of resembling an extreme risk protection order. We were, yes, very much in favor of those things. They didn't, pass muster in the final school safety plan, which I think, was a mistake. And then again, a couple of years later, we participated in, there were some other talks at the top state leadership level to kind of revisit some gun safety legislation after some other major mass shootings. And again, those didn't pass. And the gun violence crisis did escalate. And, and then we've now faced Uvalde, which is, as you know, unspeakable.
Thank you. On page 7 of your written testimony, you list Texas Gun Sense policy recommendations. Could you describe for us the members of your group in general? Is this a partisan or a bipartisan or a nonpartisan group?
People join us from all parts of the state. We do not have a partisan message. People don't join us to work on elections because we don't do that. Gun owners and Republicans will email me and have very much recently and said, "What can I do?" We represent thousands of people from a broad range of backgrounds.
You talked about the outrage after Uvalde. The situation seems different from before. How hopeful are you that this legislature will make a difference?
I wouldn't do this kind of work if I didn't hold on to some kind of hope and have strong conviction in the work that I do. I feel as though what's happening at the federal level gives me hope because that's unprecedented. It's historic. I've been working for almost 10 years, but people have been working for far longer than I have been waiting for something like this. And I'm a believer in incremental change, so I'm here to work on that. I am not sure what the legislature will do, and that's frankly why I said to you, I'm asking what you will do and how I can help make that happen.
Well, thank you so much for your leadership and for your testimony. Thank you, Mr. Chairman.
Thank you, Senator Zaffarati. Other questions? If not, thank you very much for being here and bringing these proposals. This is what we're asking for, and you brought them. So thank you very much.
Thank you very much.
Okay, our next panel, which will be the last panel, Sandy Hook Promise, Aurora Vasquez, and then we'll open it up. So please come forward. Then we're going to open it up for public testimony. I've only got 17 witness cards. So if all of y'all would like to, we have enough chairs out here. Y'all can work your way down if you're in the gallery to the seats out here. Yeah, right up here in front.
Mr. Chairman?
Yes, ma'am.
What is the time limit for public witnesses?
I usually do 2 minutes.
2 minutes, thank you.
Okay. Please state your name for the record and make your presentation.
My name is Aurora Vasquez. I'm the Vice President of State Policy and Engagement at Sandy Hook Promise. Chairman Nichols and Co-Chair, Co-Vice Chair Colkhurst, and our regards to Vice Chair Creighton and members of the committee. On behalf of Sandy Hook Promise, I'd like to thank you for this opportunity to have this conversation with you all during this very critical time. I hope to spend my time with you focusing mostly on the legislative vision, the legislative hope we have for Texas, but I would be remiss if I didn't first pause to acknowledge the unmistakable similarities between the shooting at Sandy Hook Elementary, which is the genesis of our founding, and what recently happened at Robb Elementary School. Please know that at Sandy Hook Promise, we are very struck by what happened. We continue to be very struck by what happened. The loss of 20 children and 6 adults in Sandy Hook and 19 children and 2 adults at Robb Elementary School was a stark reminder for the team at Sandy Hook Promise of what sometimes happens in this country. And our founders in particular each lost a loved one in Sandy Hook Elementary. So they are particularly moved by what's happening in Texas right now. Our founder, one of our founders, Bill Sherlock, lost his wife, Mary. She was the school psychologist who ran towards the sound of gunfire when she heard it. Our other founder, Nicole Hockley, lost her 6-year-old son, Dylan. He was found in the aftermath in the arms of a teacher. And our other founder, Mark Barden, lost his 7-year-old son, his little Daniel, as he refers to him. He waited in the Family Reunification Center for his son until he heard the phrase, "No more survivors." And so it's from that connection that Sandy Hook Promise comes to have this conversation with you all today. And we also like to acknowledge that we understand that in moments like this, in the shadow of a mass shooting that targets children, that the people will ask a lot of their leaders, and rightly so. We also want to acknowledge that we know all too well that sometimes people who want to speak to the issue don't necessarily do so very diplomatically, and we know that can also be hard, and it's also understandable that sometimes it's hard to choose your words in these moments. So to all of you, please know that Sandy Hook Promise is thinking about all of you, and that we, as you embark on this journey, we are wishing you gentle passage. We are wishing you much healing and clarity as you go forward. And indeed, we wish that for all the people of Texas during this very important time. So in terms of our vision and dream, our legislative vision and dream for Texas, I'll back up a little bit and say that at Sandy Hook Promise, our area of expertise falls into two general areas. One is the bucket in which we focus primarily on students in their schools, and the other is the bucket where we focus on the general public and access to firearms. And as this relates to the charge of this committee to try to prevent mass shootings from happening, in particular those that target students, from our perspective, I think it will become evident how that flows from the work we do. Overall, our commitment is to increasing student safety in their schools, homes, and communities. And we have an unwavering commitment to doing so. However, we also have what we describe as an unshakable responsibility to come up with nonpartisan solutions, because the solutions belong to all of us, just as the Second Amendment belongs to all of us. And so that's our direction to all the work we do in Texas, but in any state that we work in. So as it relates to the 4 areas, I'm going to turn to the written testimony that I'm sure you all have a copy of. The 4 general areas are going to be very familiar to all of you. In fact, our friend just went over some of them. The 4 areas are not at all unique to Sandy Hook Promise, but what is unique is our approach within each of those 4 areas. And I think you'll find as this conversation unfolds that we do things a little different at Sandy Hook Promise, and we bring a little bit of a different lens, in particular because we focus on students in schools and on the general population outside of schools. So the 4 areas are, generally speaking, violence prevention, education for students, raising the age, temporary transfer of firearms, and closing the private sale loophole. As to the first, which is violence prevention education, we have a piece of model legislation that we refer to as the SAVE Students Act. SAVE is an acronym, and I'm going to read it out. It's a very long name, so bear with me. SAVE stands for Safety, Suicide Prevention, and Violence Education for Students. Hence, we prefer to call it the SAVE Students Act. And in a nutshell, what this is a piece of model legislation that seeks to institutionalize in K through 12 schools evidence-based violence prevention training in some clear categories. One is suicide prevention. Another is promoting social inclusion. Another is general violence prevention, in which students are taught to recognize the signs and signals of somebody who may be at risk of harming themselves or others. And the last aspect of that for us is anonymous reporting. We believe in teaching students to use anonymous reporting as a helping tool, meaning a tool that they can use when they see signs and signals, when they hear something in the hallways, perhaps when they see something disconcerting on social media. And we encourage them to speak up and talk to a trusted adult about what they know, so that adults can do what adults are supposed to do and get the ball rolling in the next steps. And we have found that when there's an anonymous reporting system available to students that is student-centric, they will use it. They're not so much inclined to use anonymous reporting systems or tip lines that are also available to the public in general. And part of the reason for that, and students have made this clear to Sandy Hook Promise, is that they're not so much interested in using a tip line that is marketed or sold as a tool to get somebody in trouble. They're interested in prevention, and they want to be able to bridge other students or individuals they know to help. And so for them, anonymous reporting becomes a helping tool. As to the second legislative idea we have for you all, it falls into the bucket of raising the age to 21 for the purchase of or possession of certain types of semi-automatic weapons. And I emphasize certain types because Sandy Hook Promise is not interested in suggesting that it should be all semi-automatic weapons. We are not, for example, interested in something that would be so sweeping that it might pick up your ordinary hunting rifle. We are interested in encouraging you all to draft language that does focus on the type of semi-automatic weapons that are most often misused in mass shootings targeting children. We'll take note of a similarity in Sandy Hook and in Robb Elementary, that it was a similar type of firearm that was used. That seems to be what these shooters are choosing. So we acknowledge we're not experts in firearms, however, so we don't have a piece of model legislation, but we would be happy to come to the table and help figure out what that kind of language would be. In fact, we would go so far as to say that if it doesn't seem conceivable to draft a piece of legislation that identifies, not just now, but for all time to come, the types of firearms that would be subject to the 21 age requirement, we encourage you to draft something that identifies the firearms that will be excluded from the 21 age requirement, if that's the more practical approach to ensuring that there is kind of this bubble around the firearms that tend to be most misused. And an interesting thing comes up in the when we talk about raising the age, and it's why is 21 the magical age, right? In fact, in the conversations I've been having with some of your colleagues, that has come up, why 21? So on the one hand, I don't know why 21, but it's been 21 for handguns and through a licensed firearm dealer, it makes sense. On the other hand, I kind of know why 21, because there is evidence out there that suggests anything younger than often 25 is maybe people aren't in the best decision-making modes, and this happens in other industries, right? So that's why if you have a teenager on your car insurance, your premiums are really high, because the insurance industry doesn't think it's such a great idea to let people under 21 or young people, teens, drive. Car rental companies don't want to rent to people who are under the age of 25, or if you are, they'll charge a significant premium because, again, has a little something to do with decision making at that age. And then there was also a report from the U.S. Secret Service that looked at the age, not necessarily of shooters, but of the would-be shooters, of the plotters, as they said. You know, and that age range is all the way down to 16 and up to 19. So this is the age range of the young people who are thinking about targeting their schools. So that's also something to take into consideration when we think about why is 21 the magical age. The third area of legislative vision we offer to you all is temporary transfer of firearms. Sandy Hook Promise believes that creating a system that makes the temporary transfer of firearms away from people who are on the brink of crisis is a helping tool. We are, by our very nature, while we were born of a horrific act of violence, have decided to be a helping organization. And that is the way we structure our approach, including our legislative solutions. We think temporary transfer is a helping tool because if you can prevent somebody from misusing a firearm, well, you've helped countless people, including the gun owner themselves. At Sandy Hook Promise, we refer to this type of legislation as crisis aversion and rights retention. It is something we have created in partnership with our allies in Kentucky, including members of the Kentucky State Legislature. We have drafted the version we have of crisis aversion and rights retention with direct input from Democrats and Republicans, and we have introduced it. We introduced it in this past session and the session before with Democrats and Republicans, one of each as the primary sponsor. And I point that out because Sandy Hook Promise chose to begin the journey of crafting a piece of legislation around temporary transfer in a state with a strong gun culture like Kentucky, because we wanted to produce something that would be helpful in a state with a strong gun culture. And we wanted the direct input of Democrats and Republicans, and it's what we've been able to achieve. And so what is in our model is something that reflects the input we've received from gun owners and others who have said, what about this? And I'm happy to give some examples if at any point you all want to hear them. And so we offer that as well. We call it crisis aversion and rights retention because we believe in calling our legislation what it is. So for us, this is what temporary transfer is. It's an opportunity to avert a crisis because it's a prevention tool. If you act early enough, you avert a crisis. And if you can prevent the firearm from being misused, then you are able to help the gun owner retain their Second Amendment rights because, in fact, they have not misused their gun in an act of violence that could disqualify them from continuing to own firearms. So that's our third area of legislative vision for all of you and the state of Texas. The fourth is in the realm of the private sale of firearms, and in particular, in the subset of expanding background checks, but we're even a subset below that. Our recommendation to you all is to close what we refer to as the stranger-to-stranger loophole, and that is the part of private transfers where a firearm can be sold or transferred to an absolute stranger without first completing a background check on the would-be buyer. We think it's important to close this loophole because it would be yet one way, one step of ensuring that people who know good and well that they shouldn't have a firearm can get a firearm. And here's what I mean by that, that the public tends to think that the bad guys who get guns do so by risking their own lives by interacting with gun traffickers or gun dealers and who themselves are scary and dangerous. And maybe that does happen. Maybe that is how some people who shouldn't have guns get guns. But there's also a much simpler and safer way, and it's this loophole, meaning a person who knows good and well that they are not eligible to have a gun can stroll over to your neighbor's house. That neighbor that you might sometimes have coffee with or have dinner with, who might have babysat your children. They can just stroll right over to your neighbor, and so long as your neighbor doesn't know them and doesn't know anything about their history, buy a firearm in the safety of your neighbor's home. And so it's a very easy and unfortunately easy loophole to exploit. And that's the point, that it is being exploited. And so that's our fourth legislative hope and vision for Texas.
Okay, I appreciate your testimony. Senator Zaffarini.
Thank you, Mr. Chairman. Thank you, ma'am, for being with us today and for your excellent testimony. On page 4 of your written testimony, you have a statement that you also referred in your oral testimony, and that is that studies have shown that in states that increase the age to buy a handgun to 21, the rate of adolescent suicide drops. Yes. What states are you referencing?
So this, a couple of things. This comes from, I don't have the list of state here from this report, but I do want to say that it should say raising the age, in private sales, because sales that are done through an FFL.
Okay, and the issue we're discussing in Texas, of course, refers to increasing the age for buying an assault weapon. Do you have any access to any similar studies?
I'm sorry, I didn't hear that.
I said in Texas, the issue we're considering is raising the age for buying an assault weapon.
Yes, ma'am.
Not the issue that we've already dealt with of buying a handgun at the age of 21. Do you have any similar studies that show the results of increasing the age for buying an assault weapon to 21?
Not for an assault weapon in particular. I think the point we were trying to make here is why 21 is the magical age, and what goes on within that 18 to 21 age group that might suggest they're not the best decision makers all of the time.
Thank you. On page 5 of your written testimony, you refer to the Sandy Hook Promise approach regarding what you call crisis aversion and right to retention, or CARR, C-A-R-R, and that you passed that legislation with Republican and Democratic support.
We've introduced it in Kentucky, yes.
Did you pass it?
Not yet.
Oh, you have not passed it. And what are the major elements of that legislation?
Well, it's very similar to an extreme risk protection order. It doesn't have all of the elements of an extreme risk protection order because, of course, Kentucky wanted to tailor it to a state with a strong gun culture. And through that lens, we think it would be a good fit for Texas as well. So it allows for an immediate order issued by a court when there's an immediate sense of urgency to separate a person temporarily from their firearms if there's a crisis afoot, for example. It has a process to return the firearms to the gun owner as soon as they are well enough to have the firearms back and be safe. It has language that protects other gun owners who might live in the same household with the respondent, the focus of the order, so that it's clear that their firearms aren't also subject to the temporary transfer clause. It has language that provides for basically expungement of the respondent's records if a judge decides not to issue the order. We feel there should be no reflection of the fact that somebody triggered the order, attempted to trigger an order. There's information in there about notice to the respondent, notice of their rights. They have to be told very clearly that the process includes the opportunity for them to have their firearms returned at a certain point. Notice includes giving them the choice as to who will store the firearms that are removed. There's different options based on what type of order is in place, whether it's an emergency order or a long-term order. We put that in, by the way, because gun owners in Kentucky made it very clear to us that if they were going to be subject to a long-term order, so an order that would separate them from their firearms for months, that they wanted some say in who was going to store their firearms for them. In fact, they said they even wanted the opportunity to be able to sell their firearms. So we've written that into the legislation as well. So there are a number of elements.
Now, you say that it's a tool, it's not a tool that will protect individuals who, despite being ineligible to own or to possess guns, get their hands on them, and that it's focused on the good guy with a gun. Can you explain that statement?
Yes. precisely because we see it as a helping tool for gun owners who are in lawful ownership or possession of firearms. A helping tool that indicates that if we, so the royal we, if we intervene before that gun owner misuses their firearm in an act of violence, be that against themselves or others or possibly both, by doing that and taking that helping step, we help that gun owner retain their right to bear arms, because a person who misuses their firearm in an act of violence will likely lose their right to bear arms, could lose their right to bear arms permanently. And so it isn't meant to protect, nor would it apply to a person who is in unlawful possession of guns to begin with, so the bad guy.
Thank you. What are the major provisions of your model legislation titled the Save Students Act?
The Save Students Act is the one that focuses on schools, that seeks to bring the evidence-based violence prevention training to students. The actual model is in the appendix, and it has multiple clear sections. All of it requires evidence-based training, and I emphasize that because there's probably a lot of approaches to doing what I'm about to explain, and we believe students deserve the best, the most high-quality resources. So the Save Students Act seeks to institutionalize suicide prevention training for students, general violence prevention training for students, training that would help students combat social isolation, and then anonymous reporting is the fourth aspect of that. And all of that is entirely school-centric, K through 12, because we believe, again, if you give students tools to position them to be able to prevent violence on a spectrum, they will in fact do that. They want to be in a position to prevent violence, and that makes them feel like school is in fact the safe place. We all want them to feel that school is a safe place. And then if they speak up using an anonymous reporting system or by telling a trusted adult, it is entirely possible to avert school shootings. There are several schools and districts around the country who use our anonymous reporting system. In fact, in Texas alone, there are 11 districts who are using Sandy Hook Promise's anonymous reporting system. We have one. We make our system available to schools at no cost. In fact, we make all of our violence prevention programs available to schools at no cost. And students use it. You train them on how to use it, and they use it as a helping tool. It's
what are the
incredible.
minimum actions that you believe this committee must take to prove that we're serious about ensuring the safety of our students, teachers, and staff?
Sure. So I think something like the Save Students Act, so putting mechanisms in place, evergreen mechanisms that will help students today, but also students tomorrow and teachers today and teachers tomorrow, but give them the upstream violence prevention tools they need. Because when you couple upstream violence prevention tools with the other things that adults tend to ask for in the shadow of something like a mass shooting, which is what in this space is often referred to as school hardening. If you couple those two, students tell us they feel much safer, because if you leave out the upstream violence prevention, they have told Sandy Hook Promise that while training them on what to do in the moment that something bad happens is really useful, it also makes them feel like adults are just kind of training them to be sitting ducks. And so they want those upstream. So that's one, as it relates to just focusing on students and doing right by students. And then the other aspect is the legislature taking these, what really are nonpartisan steps to balancing Second Amendment interests. Texas has an incredible Second Amendment infrastructure. Some of it you all have created intentionally. Some comes from federal loopholes, like the loophole that has led to strangers being able to sell guns to each other without conducting the background check. So I think the combination is the right approach.
Thank you, ma'am. Thank you, Mr. Chairman.
Thank you. Any other questions? Senator Betancourt.
Ms. Vazquez, thank you for your testimony. And essentially, obviously, you're with the Sandy Hook organization. And just looking at your recommendations and proposals, I looked up, we've had obviously a lot of information come our way. Adam Lanza, who was the very evil shooter of the Sandy Hook tragedy, was about 4 months and a week away from 21.
Yeah.
And looking through this, apparently his mom bought the guns.
Yes, sir.
And there's actually another entry that the doctors felt like that, he was in control of that relationship. So if his mother purchased the guns in this situation, how could the age limit proposal made any difference in Sandy Hook?
Well, I would suppose that if there was an age limit proposal in place at that time, that his mother perhaps would not have been purchasing firearms for a child who was under that age limit, right? We acknowledge that there are other types of firearms that perhaps she could have purchased for him, but perhaps not those, right? The ones the type of firearm he chose to use.
No, I mean, this is just there's a whole list of shooters
Oh, absolutely,
here that
yes.
you go through, but since you're with the Sandy Hook organization, I wanted to ask that question because obviously this is an intractable problem. And when, if you make a legislative proposal, then, and clearly in this case, that proposal probably wouldn't have made any difference. But I want to thank you for your testimony.
Thank you.
Members? If not, thank you, Ms. Vasquez. Thank you very much for coming and spending the day with us and for your presentation. Okay, we will now go into public testimony. There is a timing element of 2 minutes. There will be a light. So when your testimony starts, you will start the timer. And when you get to within 30 seconds of your 2 minute, then the yellow light will come on. And at the end of the 2 minutes, the red light will come on. And I'll call 2 up at a time. So the first up is Dr. Sandra McKay, Texas Pediatric Society, as well as Andrea Breyer, Committee to Protect All Texans. And so Dr. McKay, so whenever you get ready to start, go ahead and state your name for the record and then begin your testimony.
Sandra McKay. Okay. Hi, I'm Sandy McKay, a general pediatrician from Houston, representing the Texas Pediatric Society with our written testimony. Thank you for the opportunity to speak today on the importance of strong firearm safety policies to keep children safe. I also serve as an associate professor of pediatrics with the University of Texas Health Science Center at Houston and a non-resident fellow with the Baker Institute for Public Policy, where I have expertise in firearm injury prevention research, and I'm also a firearm owner. I completely agree with my colleagues that we must address the mental health crisis in children. We also must address other mechanisms of firearm injury, including unintentional injury. We must address the importance of safe storage, which can impact not only unintentional injury and suicide, but also reduce firearm theft. In fact, we know that if half of the homes with an unlocked firearm switched to locking up their firearms, just half, we would see a reduction in youth suicide and unintentional injury by 1/3. In Texas, we need to fund research to advance the interventions that can impact firearm injury prevention in children. This is something we can do in Texas. In fact, my team is currently developing a database with our firearm retailers and law enforcement agencies on temporary storage to allow families to have a safe option to store firearms out of their homes in times of crisis. We are also collaborating with retailers to develop a comprehensive education on safe storage at point of sale and using geospatial analysis to identify neighborhoods primed for intervention. We need ongoing research to identify Texas-based data to help drive Texas-based solutions. Through leveraging databases, we can develop a more comprehensive approach to identifying firearm injury prevention and continue to expand on community-based collaborations. The single most modifiable risk factor in firearm injury is access. In the past decade, nearly 1/3 of all firearm injuries, both fatal and non-fatal, in children for unintentional or suicide shootings. Thank you for your time.
Didn't have my mic on. Appreciate very much your testimony. Senator Zaffarini. Excuse me, Cocorst.
Yeah, you mentioned geospatial, what was that?
Geospatial analysis.
How do you do that?
So what we're doing is we're creating these maps of where firearm retailers are doing temporary storage. And so what that means is that our retailers, our FFLs, are currently offering, and there are several throughout the state of Texas, and we're actually calling every one of them. There's a lot of them. And what we're doing with them is we're asking them about what their practices are with providing safe storage counseling at point of sale, and if they offer temporary storage for any reason, whether it be if someone's in a time of crisis or if they, offer storage if, if a family is needing temporary storage, like if they're selling their home or if they're going on vacation and they don't want their firearms stolen out of their homes, which, theft is also a reason that a firearm would be stolen and could potentially be used in crime as well, right? And then what we're trying to do is identify on a map and see where are these at, and then overlaying that with where the firearm injuries are happening or firearm deaths are happening. And so then we can see on a map and see where are the disparities, right? And so then utilizing research, we can say, wow, more firearms here, injuries here, but then there are no services here for either, in areas of high suicide, but then we don't see areas of where maybe temporary storage could potentially be an option for those families. And so that would be on our team to reach out to those FFLs in that area, or even the law enforcement agencies in those areas. But, unfortunately, my research team is doing this completely unfunded because we believe that this is a high priority for the greater Houston area. And so we're really just doing this with volunteers and a research assistant of mine that really cares about this project. So this is a great example of how Texas can invest in research that would really, save lives and improve what we can do in the greater Texas area that would also reduce suicide, injury, and death.
Do you, I meant to ask the panel, but it came after the Meadows Foundation chart where it was, I think it's it's at a high right now, 2.7 per 100,000 youth, the chart of what I referred to, and homicides at 3.1 and suicides at 2.7. Do you know what is most often used in suicides among youth 18 and below?
As far as mechanism in suicide
Yes.
for youth?
Yes.
So in youth I've got that right here actually.
And I don't know if somebody has that data.
50% of them use firearm.
Pardon me?
50% of youths use firearms.
50%?
Yeah.
And then the other 50% would be?
So, that would be kind of a mix between either it be, pill ingestion or other types of kind of asphyxiation, stuff like that.
Yeah. If you could get that to my office, I'd appreciate it.
Yeah, we can go ahead and look that up for you.
Thank you for your answers.
Absolutely.
All right, thank you. Andrea, please state your name for the record. Senator Zaffarini, you're trying to hand you something. Our staff really ought to be up there passing those out. Up there.
Oh, sorry. Oh, got it.
You one on each side.
Okay. My name is Andrea Brower, and I'm a gun violence prevention advocate. I'm happy to be here today, but I also understand why some folks are skeptical and sat it out. The name of the committee being the Committee to Protect All Texans. That has traditionally meant protecting gun rights and the gun lobby on this issue. It has not been public safety. And when the charge and the name of the committee can't even say gun violence or gun laws, I think we're missing the biggest problem here. We need to be able to say what it is. Of course, mental health is a big issue, but we cannot solve and cure and identify every child with a mental health issue and just take care of this problem. The Uvalde shooter, we're focusing a lot on schools today. The Uvalde shooter was 18 and he wasn't even in school. Most of the homicides and suicides and gun deaths in Texas are by folks 25 and up. So what are we going to do to stop those folks from getting access to firearms? I think at the end of the day, our biggest problem is access to firearms, easy access by people who shouldn't have them. I gave you a handout with 8 bills that I think I'm hoping that the legislature will consider. Senator Zaffirini, you asked earlier, what can we do to show that we're serious? Have a Republican member of this committee file a bill. These bills will not hurt gun owners. There's one, I have a draft right here. It's a state law prohibiting those who are adjudicated as mentally ill. 34 states have this law, including Arizona and Florida. We don't have it. A straw purchase law, a suicide prevention bill. I have a draft of it right here. Mainly education, coordination, like she mentioned. We talked about 18 and up. We know their brains aren't fully formed. If you don't want to go that far, have those folks that are 18 to 21 get an LTC or take a hunter's education safety course. My request is also to ask the NRA, bring them to the table, bring the Texas State Rifle Association to the table. Have courage. We need you right now. Thank you.
Thank you very much for your presentation. Were there any questions, members? If not, thank you all both very much for being here with us today. I'll now call up Police Chief Mario Pena, as well as Allison Boulware, Hog Foundation. Is Allison here? Okay. Chief?
Yes, sir.
Please state your name for the record.
Yes, sir. My name is Marco Pena. I'm the Chief of Police for the City of Elmendorf Police Department. Well, thank you.
Go ahead.
Thank you, sir. Well, Senators and Chairman, thank you for having me today. Essentially, I'm going to give a couple of things. I'm going to talk from experience, right? From my heart. I don't have no documentation, whatever. However, I've been in this profession for 23 plus years. I've been the Chief of Police for Elmendorf Police Department for almost 8. Since then, I've seen an epidemic of a lot of mental health issues within our community members, right? And leading up from 3 years old to adults. And so we see this epidemic rising, not just in Bexar County, but at different areas, because we serve a little part of Wilson County as well. So I see this happening to the trend, and a revolving door with the same individuals who have mental health issues, right? I think one of the issues that I think that we need to address, and I have facts on this, right? I think that the mental health institutions, they're doing their best they can. I understand they're probably undermanned, understaffed, underpaid. I get all that. But one of the things that really affects us as law enforcement officers is that we ED an individual, for example, they're threatening to kill their family or what have you, but they have mental health issues, reliable, factual mental health issues, and also induced by narcotics as well. So all that plays a part with guns and whatever else. All that plays a factor. So we ED these individuals, and so they're out within 24 hours. I don't quite understand that, because we put them in there for a specific reason, to get mental health. I think, in my opinion, that they should be more than 72 hours evaluation. I think they need to be there longer to be evaluated. I spoke to a nurse who is also involved in mental health, who works at a big facility, and I asked this individual, I said, look, I said, what is the biggest problem? She says, it's a revolving door. Oh, sorry.
Go ahead. We've got Senator Zaffirini. Go ahead.
Yes.
Senator Zaffirini.
Yes, thank you. Chief, what would be your suggestions for this committee? What legislation would you like to see us recommend to our colleagues?
That's more sensible, right? As far as mental health issues. Again, I think that the legislation and the senators could get together, and both parties work together on this to get this thing under control, because it's not only affecting law enforcement, it's affecting families. And the legislation would move to where it would be better evaluation for those who really need to be seen mentally.
And of course, you are in southeast Bexar County.
That's correct. I'm 13 miles southeast of Bexar County from San Antonio.
So you're outside the city of San Antonio?
That is correct, ma'am.
So how do you work with city and county, state and federal law enforcement officials to be ready and to ensure school safety?
Well, I tell you, because East Central School District is in the immediate area, although we don't have a school as of yet in Elmendorf, but we work together in collaboration with the federal agents, local, state, and school district police officers or district.
But you collaborate with schools in Wilson County as well as in Bexar County?
We have a portion of Wilson County, yes.
Yeah. And how would you respond? What would be the responsibility of the police in the Elmendorf area if there were an active shooter in a nearby school?
To be honest, as the chief of police there, my response is to go ahead and get there as soon as possible and take out the threat.
Thank you. Thank you, Mr. Chairman. And thank you for being here today. We appreciate it.
Been a pleasure. Thank you all.
Senator West, did you have a question as well?
Yes, sir.
Okay. Any other questions? Thank you, Chief, very much for being here. Let me ask you one question.
Yes, sir.
We heard testimony yesterday. Each school district is supposed to have their emergency operating plan.
Yes, sir.
And as we went through all the various testimony, we got to the Sheriff's Association, and they suggested, which I thought was an excellent suggestion, was that the school, whoever that lead person is for the school, actually go over with the local law enforcement, which would be city and county, the plan so everybody knows operationally how it's supposed to work and who's in charge. Do y'all do that?
That is correct, sir. I think that's very imperative. If an active shooter, it's not if, it's when. And God forbid that should ever happen again, but we are planning for that. In fact, I'm in the planning stages myself as well to make contact with individuals to try to work out a plan, yes.
Do y'all actually go over the plan with the school?
Yes, sir. Well, there's an MOU, right, in the process, and so right now we're in the process of doing that. Yes, sir.
All right, thank you very much for your service.
You're welcome, sir. Thank you.
Allison Boulware Hogg Foundation for Mental Health.
Yes, sir. Good afternoon, Chair and Committee. I appreciate the opportunity to present to y'all. My name is Allison Moore-Bulwer, and I'm the Director of Policy at the Hogg Foundation for Mental Health. The foundation has been around for over 80 years through an endowment from the Hogg family, and our goal is to have every person in Texas thrive in communities that support mental health and well-being. There's been so much said today on mental health that I really want to focus on two things for y'all's consideration. The first is overall school climate and student mental health and well-being. Our goal should be to prevent any student from getting to the place where something like this happens, right? And in order for that to happen, we must be cautious about how we discuss the need for mental health services in reaction to a shooting like this. We do not want to incorrectly infer that violence is directly correlated with mental illness, because as has been shared, it creates a negative stigma for mental health. So while a focus on mental health is important, of course, to prevent, but also to support the community after something like this happens. Children are grieving, they've experienced trauma. It's important for us to think about mental health in a holistic way. Our first goal should be to create schools that are providing safe and supportive learning environments that support mental health and well-being of both students and staff. And part of this is creating positive school climates inclusive of mental health supports and services. Wow, 2 minutes goes by very fast. The second item that I want to focus on is the workforce shortage. Especially so many of y'all in rural areas. I'm from a rural area. This isn't new, right? So many counties don't have any mental health professionals. There are lots of solutions, but what we really need to look at is y'all have invested so much in programs. We need people to run the programs. We need people to provide these services. And
yeah, good to see you again. I know you've testified before Health and Human Services many times. That last sentence, why don't you repeat that again?
Thank you. So we know that y'all have invested so much in programs for mental health, and we need people to actually run the programs.
Yeah. I think, Mr. Chairman, members, that is a great sentence to encapsulate the efforts that we've done through, and I always refer to it as SB 10. It became SB 11. It was folded into SB 11. But other programs, and you've heard the local mental health authorities, the 39 different bills that members on this committee have carried, myself included. And so we have created the programs, but we need the personnel to run the programs.
Exactly. And if I could give a couple of ideas.
Sure.
Okay, thank you. Again, 2 minutes, y'all, it's not enough time. But I know y'all have a long day.
I'll get in trouble from the chairman. You can't go 5 minutes, but keep.
No.
Just
Thank you.
Give me 2 recommendations.
I do want to share that Dr. Lakey shared many items for the consortium that we support, because this would be the full spectrum of the mental health workforce in addition to psychiatry. Because as has been shared, not every child needs to see a psychiatrist, of course. There are so many other options for them to get counseling. So we need to make sure that the consortium has the workforce development for social workers, counselors, peer support specialists, other folks to provide services. Also, increase funding to the existing mental health loan repayment program that is specifically focused on underserved areas. We know that over 270 professionals have participated in that program, and again, it's the full spectrum of mental health professionals, which we love to see. And last, and this is an idea that I hope y'all really take into consideration, is a dedicated line item just for mental health professionals to either be in schools or contract with schools, especially for those rural areas that we know there might not be enough for them to be embedded, in a school, but they could contract with it. Because we know that students, when they see someone who looks like them, that they know from the community, there's that shared trust, there's that relationship there, and that can really be a strong foundation for a relationship and support.
Yeah, so Mr.
Senator
Chairman?
Kokhorst.
Yeah, thank you. I'll be quick. But you're really talking about more than TCHAT.
Correct.
Okay. Get your testimony to our office, and let's talk about that. And, one of the ideas, Mr. Chairman, I don't know what's going to be born out of this group, but, we talked about the hardening dollars, $9.72 originally was thought to be a lot more. Some of the superintendents I've visited with in Senate District 18 and new Senate District 18 are the ongoing costs, not just the hardening, but personnel like you talk about. That could be, we want to harden the schools and have certain things that would slow down or prevent the perpetrator that we saw from Uvalde enter, but also the mental health services that would be recurring dollars that I think we can make great strides in, especially post-COVID, as was the testimony by a psychiatrist and a psychologist today, and the emotional disturbances that we're seeing from isolation and social isolation. Thank you.
Okay, I would just like to say, how long have you worked for the Hogg Foundation?
About 10 weeks, but I was a previous policy fellow there from 2015 to 2018.
Okay, it's a great organization. I think it was a wonderful thing that the family set up, and something you may not know about the Hogg Foundation is Governor Hogg was born in my home district county, Cherokee County, and his father, Joseph Hogg, was the first state senator from my home county who served in the first Texas legislature. Anyway, just so you'll know. All right, thank you very much for being here. And we'll call up our next witness, the Most Honorable Judge Wayne Mack. Please come up. And also Lee Spiller, Citizens Commission on Human Rights. Lee, are you here? All right. Judge Mack, please state your name for the record. And
Judge Wayne Mack, Montgomery County, and Senator, thank you for your time and your leadership. I want to thank the governor and lieutenant governor. I think there's power in words, and the fact that this committee is Protect All Texans. The American Foundation for Suicide Prevention has a talk that they give that's called Talk Saves Lives. And I think the fact that we're having this conversation as Texans is going to save lives. And I appreciate the fact that you are doing this. I came up here today to say thank you. And as a judge, I've been in office 2,976 days, but who's counting? And in those 2,976 days, I've done 2,280 inquests, death inquests, as many justice courts across Texas. Not only do we have our judicial responsibilities, which include truancy, but we also have the unfortunate job of having to do what Judge Diaz did just a few weeks ago with that tragedy. And so I started one of the founders of a Montgomery County Behavioral Health and Suicide Task Force in our county, and we've brought together over 200 volunteers, over 60 different agencies to look at behavioral health and suicide task force and what our response is. And we know that if we can't, as a state, we cannot keep doing what we've always done, or we're going to have what we've always had. We've heard the ABCs of budgeting and so forth, but Texas, we, depending on what study you look at or what group you talk to, we're 50th in the nation in what we spend per capita for mental health, and we've got to look at what we're doing. My faith teaches me that where your treasure is, there is your heart also. And so we have the opportunity here today. History will show this committee was complacent, complicit, or had courage. And my hope and prayer is that you will have courage to do what we need to do as Texans.
And Judge, thank you very much for your work on this. I know you work closely with Tri-County because y'all came in together.
Yes, sir.
Your relations and connection with the Children's Consortium we talked about earlier.
Yes, sir.
Today, do you also, or are they interacting with your group, your new group?
So we're that consortium, not directly, but indirectly through the Texas Council of Suicide Prevention and all the other isms that we're a part of. We're looking at this and trying to increase the safety net. We know that the safety net is fractured in some areas, and as a county, we're looking at that, and we're trying to find workable solutions. Come alongside. We're not an ism. We're all volunteers, and we're coming alongside to build collaboration to look at what we can do to improve this in our area.
Okay, and you've got two new Montgomery County senators here with Cocorse and Betancourt, and I want y'all to know Judge Mack is a rock star down there. Senator West, you had a question?
Sure. Judge, nice seeing you again also. As it relates to what we've done in the past and what we should do in the future, are there any Second Amendment, well, let me be straight. Are there any gun laws that we need to look at? The age, background checks, red flag laws, in your opinion, that would help reduce, let me finish, please.
Yes,
that
sir.
would help reduce the probability of incidents like this occurring again?
Well, I know that the suicides that have involved guns, Senator, there were in all those, every suicide I've worked, there has been, and murder suicides as well, that there has been missed areas where people have missed the warning signs, and access and means is one of the ways that you can reduce that. And I think, in Texas, you have to be 21 to smoke a cigarette. You should be 21 to have to buy an AR-15, a rifle, or anything else. If we don't think they have enough confidence in drinking alcohol or smoking cigarettes, I think we should look at this realistically at that age. That's my personal opinion, Senator.
Senator Corning has done an exceptional job in terms of pulling together with Murphy, pulling together a bipartisan group in order to pass legislation. Hooray. What about red flag laws? What are your thoughts on red flag laws?
I think we have to be careful in everything. And don't take offense to this. I'm a 33-year county employee, but it's been my experience that government does two things well: overreact and nothing. And I think we have to be careful with that, but we have to do something different. We cannot allow people that have a mental illness to have access to weapons, and we need to figure out how to fix that in a bipartisan way. This is not a Republican and Democrat issue.
It's not.
This is a public health epidemic. People are dying every day. Suicide is the second leading cause of death for ages 10 to 35.
Right.
And we can't keep doing what we've always done, Senator, and expect a different result.
That's exactly right.
We have to have courage.
We have to have courage. But I just want to let you know something. I'm with the government, and I'm here to help. Thank you. Thank you, Judge.
Thank you very much for being here. I know you came a long way to be here, and you were patient all day long for an opportunity to speak. Lee, please state your name for the record.
Thank you. My name is Lee Spiller, and I'm with the Citizens Commission on Human Rights, Texas, and I'm not going to read you a 4-page testimony. First, I want to thank Senator Cocorse for mentioning not wanting to load kids up on a raft of psychotropic drugs. I would remind all of y'all, in fact, I was reading, I think it was last night or the night before, about mental health or mental illness may not correlate to violence, substance abuse does. And I would remind you that whether we call them mind-altering, psychoactive, or psychotropic, legal, illegal, prescribed, non-prescribed, these drugs affect mood, cognition, and behavior. Right? We need a mandatory toxicology report for all mass violence and suicide, and it needs to be public-facing so that the public can make good decisions. I think you, Senator Perry, yesterday mentioned the need for outcomes data. We need that. And I'll give you an example. We funded suicide prevention again and again and again, and yet the suicide rates have gone up. And it's particularly concerning in view of the fact that very few of these programs, if any, are well studied for adverse effects. We need to know. We need to know whether these programs and whether this perception that it's the mentally ill that are doing these crimes is causing more kids to be hauled off to psych hospitals. We need ramped up parental rights in school mental health programs. In Senate Bill 11, we were promised that nothing would be done without parental consent. Unfortunately, that's what we're seeing right now. Multiple school districts, screenings. And thank you all very much. I'm out of time.
Mr. Chairman.
Right, Senator Kokorsk and then Senator Perry.
Lee, in Senate Bill 11, which I refer to as Senate Bill 10, it clearly, and Dr. Lakey stated it today, and so did the lady presenting with him, her name escapes me right now, but it was clear that parental consent was necessary. So, you know, if that's not happening, that would be Dr. Williams was with Dr. Lakey. If that's not happening, then, you know, we need to know about that. But
yes, that was in regard to TCHAT, and one thing I will say about TCHAT, their policies are very clear on that. Parental consent's required.
So then what do you refer to?
Screening programs, surveys, and assessments. In 2020, the fall of 2020, Austin Independent School District announced their intention to interview every one of the district's 80,000 students to check on their mental health. When we asked about informed consent, they said they didn't need it. Louisville ISD incorporated an emoji-based emotional assessment. We asked for the informed consent on that. They sent us the parents' consent for the child to access the district's IT systems. So when we reiterated and said, hey, this doesn't seem to be specific to a screening, can you please give us the consent for the screening? They said that because the tech team had approved the app and because leadership was okay with it, they felt like this general thing was enough. TEA's mental health, school mental health, our school mental health TX website has a toolkit for universal mental health screening, and in that, and this one is from out of state, it didn't come from here, but the authors of this toolkit actually state that if the teacher is the respondent, parental consent is not needed.
If the what?
If the teacher is the respondent to the screening. In other words, if you have teachers answering questions about kids' behavior, parental consent is not needed. I'll be glad, you know, we've gotten other allegations from other parents. The other thing that we're doing is opt-out consent. And what that means is if the parent misses the notice, didn't get the email, then their kids, you know, the onus is on the parent. It shouldn't be that way. It should be opt-in.
Okay, Senator Perry.
Thank you, Mr. Chairman. Lee, it's always good to hear from you, whether we agree or disagree, but we're more aligned on most things. Last session in education, I remember clearly, as well-intended as it was meant to be, an age-inappropriate conversation regarding suicide, what that looks like at, I think it was as early as first grade kind of deal.
Yes, elementary school, yes, sir.
Yes. So you and I both saw that that was not appropriate conversation because it interjects thoughts that from a maturity level, those kids shouldn't have been dealing with it. So we killed that. So here's what I want from you is those districts that you know specifically are in violation of parental consent. Those are our violations of intent and statute that we put in place or did not put in place. If they're doing that, we will find out what remedy from a financial perspective we have. If not, there will be remedies put into it because it's unacceptable. Now I'm going to switch hats.
Yes, sir.
There's nothing more sacred than individual liberty. I do agree with your assessment that we drug kids before we ask kids what's going on. But here's the challenge, and you've heard this committee for 2 days now. We are scrambling to respond to kids that have risk factors that have been scientifically proven that they are great indicators to project out that without intervention, there's going to be a catastrophic event, possibly. Possibly. So, and it may be this answer. I'm going to give you the answer I think it is, and you tell me that's correct.
Okay.
When faced with giving up personal liberty or trying to forecast and protect public based on that, is it one of those situations we just have to live with the fact that we may not be able to tag? And I say tag in a very non-professional way. We have to monitor and intervene, but give me some confidence that there is a way to do it that doesn't violate yours and mine and my constituents' concerns, or is there not a way?
That's really the problem, and I think it's a Solomon-like decision here. What do we do, right?
Right.
We're splitting the baby.
Split the baby.
The thing is this, if we're doing it based on a profile, we can't take that chance. You know, and in the fall of 2019, there were several experts quoted in the Houston Chronicle stating that, guess what? We can't predict violence any more reliable or slightly more reliable than chance, right? We can't lock people up on slightly more reliable than chance. What has bothered me, you look at the case of Nicholas Cruz, Seth Ator, the Odessa shooter, the White Settlement Church shooter, and Devin Patrick Kelly, the Sutherland Springs shooter. These are all people that ping-ponged back and forth between law enforcement, criminal justice, and mental health. And my concern is that we divert people who are known to be violent, and we expect that the mental health system can fix it. That's not what the mental health system does.
Agreed.
So we burden that system, and we have this false sense of security. I mean, law enforcement had been to Nicholas Cruz's house like 21 times related to him or him and his brother. He had had, I want to say, over 50 disciplinary referrals in school. He had had hundreds of hours of therapy. He had had medication. In interrogation, he admitted that he was using Xanax recreationally, although he wasn't high the day of the event. That is a lot, and Xanax is one of those drugs that's associated with homicidal thoughts, right? Ironically, the week before the shooting, what was he searching? Homicidal thoughts and treatment for homicidal thoughts, right? We can't do things just in case, but we can certainly keep people from ping-ponging between those systems. If you're a criminal, you belong in the criminal justice system. It's made for that.
And the last guy, the Meadows guy, finally, in clear and uncertain terms, and he used a number, and I'm not holding him, but basically a third are individuals that do not fit our mental health models. They are not fixable in the sense that they either go to an institutional setting where there is no harm to anybody else, or they may end up in that criminal justice system. But to put that in with an expectation, we're going to fix this person and put them back into a classroom, or if they're adult age, out of that classroom setting, is not a realistic expectation. But going back to the challenge, those thirds probably had clear indicators along the way that maybe, just maybe, with the right intervention, according to the experts, could have been diverted to a productive person.
Right. I have to wonder if we're looking to mental health to do something that human services could do. Well, when we went to Uvalde to get records, we drove by the grandmother's house and looked at that neighborhood, and then we went to the trailer park that he had lived with with his mother, kind of like on the back of the property. And it was really poor and it was really rough. And I kept thinking, man, how hopeless would I feel? I mean, I've been poor. You know, when I was 12, my dad was sick for like 9 months, and we went broke. I know what that feels like.
Right.
I didn't go out and commit murder.
I hear you.
But if we're going to do prevention, you know, what's interesting is one of the most prevalent factors among shooters is stressors.
Right.
And we're talking financial, family, work, things like that. What can we do generally in the community to improve communities and lift people up?
True.
And maybe that's not a legislative solution, but that's where we need to go.
I knew you were out there. I knew you'd be one of the last ones, and I'm always reminded that it's usually the last group or last few that remind me that there is two sides to every coin.
Thank you.
And I
All
thank
right,
you for
Lee, thank you very much for spending the day with us.
Thank you, sir.
For coming and testifying. Our next witness is Greg Hance, National Alliance for Mental Illness, Texas. Is he here? All right, then I'll hold that. Yeah, you come on down. Daniel Graber, representing himself from Paradise, Texas. Come up. Have a seat. When you're ready, please state your name for the record and then begin your testimony.
I'm sorry, sir.
Please state your name for the record and begin your testimony.
My name is Daniel Graber. I'm representing myself and just want to thank the committee for your time today and for convening on this matter. I've been involved in shooting sports since I was 13 years of age on a rifle team in high school. I have multiple credentials for teaching youth at multiple ages and have been running events at large ranges and small ranges alike. I have served as a master instructor, a general manager, training and facilities director, and events coordinator. The thousands of shooting activities I've supervised are primarily recreational. Safe firearm handling is always the first item briefed on at any of these events and is the key to success and enjoyment in the sport, whether involving adult clients or youth experiencing their initial exposure to the sport. Safety is job one. Perceived danger in shooting sports can come from sources unfamiliar with proper instruction in firearm safety. Safety should be job one outside the shooting sports as well. NRA's Eddie Eagle Gun Safe program teaches young children to stop, don't touch, run away, and tell a grown-up if they encounter an unsecured firearm. The age-appropriate instruction is on an accident prevention and available for use in the Texas schools. There's also an excellent non-shooting course available for older youth called Home Firearm Safety that is designed to help anyone understand how to make sure a firearm they encounter is unloaded and safe to handle. Education is key to safety involving firearms or not. This includes school safety. In 2,000 colleges and universities, including the UT system and the Texas state system, a product is in use that has now been adopted for use in the K-12 schools. It is a three-tiered approach, educates faculty, students, and parents in awareness, educates faculty and staffs on ways to encourage sharing of key information and proper actionable steps on their part, and the use of threat assessment teams. Thank you, sir and ma'am.
Okay, sir, we very much appreciate. Do what? Well, that's another witness. But go ahead. Greg?
Yes, thank you.
Please state your name for the record.
Good afternoon. My name is Greg Hanch. I'm the executive director of NAMI Texas. I would echo many of the comments that have been made by mental health experts today, including it's important not to stigmatize mental health. Mental illness is not a panacea to addressing these mass shootings. It is part of the conversation. We should address firearm safety and access. We should address safe storage. And the mental health workforce shortages really undergird a lot of the other initiatives that can be put in place to make a difference. So we should be focusing on addressing the mental health workforce shortages in our state. I do want to add in the time that I have a few concepts that haven't gotten as much play today. It was mentioned in earlier testimony, the opportunity to expand access to coordinated specialty care. Senator Zaffirini had a bill that would have required commercial insurance companies to provide coverage for coordinated specialty care. We hope that idea will come up again in the next session. We should also be ensuring that commercial insurance companies are providing coverage for serious emotional disturbance. we do require an existing insurance code for commercial companies to provide coverage for serious mental illness for adults, but we don't have a comparable requirement that they provide coverage for serious emotional disturbance among children. We support the concept of certified family partners. We talk a lot about empowering families and engaging family members in the care of their loved ones. We talk a lot about parental consent. Certified family partners are an opportunity to give parents and caregivers a supporter, an advocate who can walk them through the mental health system. There have been bills filed to provide Medicaid reimbursement for certified family partners, and we hope that those bills will be considered again next session. We should also reform our state's inpatient mental health commitment criteria for civil commitments. We have a standard that is lagging behind. Louisiana just reformed its inpatient mental health commitment criteria, passed their Senate unanimously, and we hope a bill will be filed on that in the next session. Please reach out with any questions on my written comments. Thank you.
Okay, thank you very much. Thank you both very much for taking the time to come here. We appreciate your comments. So next up will be Krista Del Gallo, Texas Council of Family Violence. Are you here? Please come up. Paulina Vidal Herrera, All Children of Texas. Is she here? Paulina Vidal Herrera, All Children of Texas. I don't see her, but go ahead and state your name for the record.
All right.
And begin your testimony.
Thank you. Krista Del Gallo, good afternoon. I'm the Legislative Director at the Texas Council on Family Violence, and TCFV is heartened by the creation of this committee, and we look forward to supporting the chair and members and the entire Texas legislature in taking the necessary steps to prove to be a safer, stronger, and more prosperous state. TCFV is a coalition comprised of members, among whom are victim service providers in your districts, and we are dedicated solely to creating safer communities and freedom from family violence in Texas. We appreciate this opportunity to offer comments related to firearm safety and to share what we know about the deadly combination of firearms and family violence, and to offer some initial solutions. We know most Texas victims and their children live in homes where both domestic violence and firearms are present. We know the severity of violence in Texas homes has grown over the course of the recent public health emergency. We know the presence of a gun in a domestic violence situation dramatically increases the risk of homicide. We know the majority of family violence homicides are perpetrated by means of a firearm. We know the lethality risks extend beyond the primary victim to their children, family, friends, law enforcement, and bystanders. We also know the tragic and terrifying frequency of mass shootings across Texas and the nation have revealed connections between mass violence and domestic violence. So this brings us here today to spotlight the Texas laws that have already been codified that, if they were actually operationalized, could help save lives and prevent future violence. Operationalizing the existing statutes that prohibit possession of firearms for certain domestic violence perpetrators means that we would have protocols in place to prompt the effective transfer of these firearms precisely at the disposition of a criminal case or the issuance of an order that effectuates these prohibitions. Thank you for letting me finish that statement. Any questions?
Mr. Chair.
Thank you very much. Appreciate your input, Senator Perry.
Are you keeping Gloria straight?
I'm trying real hard, but she's a wily one.
She is a bundle of energy and has been for the 30 years I've known her. Thank you for your work.
Thank you, Senator Perry.
All right. Thank you very much for coming here.
Thank you.
Our next two up, Victoria Imhoff Woodruff from Austin, as well as Evan Robinson, Tri-County Behavior, Conroe. So Victoria, please state your name for your record and begin your testimony.
Victoria Woodruff. Esteemed senators and citizens, When I was a girl, my dad taught me the most important treasure I would ever own, more than gold or silver, would be the reputation and integrity of my own good name. My name is Victoria Woodruff, and my dad's words are my compass. I'm a wife, a mom, grandmother, retired middle school teacher, and proud Texan. But I have another identity, too, gun violence survivor. My only son died by suicide 3 years ago. I find I must overcome my intense desire for privacy to speak out on this issue. In 2019, my son was one of 39,707 people to die in the U.S. from firearms. Spouses, parents, teenagers, children, people with names, people like my sons, James Ryland Woodruff, and 110 more names every day. A savage roll call. Eliana, Jacqueline, McKenna, Jose, Xavier. Should I keep going? I'd be reading all day. So why am I here? What do I want? Senators, I want you to support evidence-based, robust gun safety measures. For instance, a waiting period might have helped my son. For others, red flag laws, age increases for assault weapons, and more actions. For the love of Texas, claim your own good reputations and names. Please use your bipartisan authority to effect courageous change for the citizens you have sworn to serve. And I thank you for your service.
Thank you very much for your testimony. Senator Kolkhorst.
Yeah, thank you so much for your courage of coming here today. I'm sorry for your loss.
Thank you so much.
Just a quick, you mentioned a waiting period, and
yes.
I don't want to dig too deeply, but was your son over 21, and did he purchase his own firearm?
Yes.
So when you talk about a waiting period of just a cooling off period of
yes, slow
48
in the roll.
Right. Okay, thank you so much.
Thank you.
Appreciate it.
Thank you very much. Evan, please state your name.
Good afternoon. My name is Evan Robertson. I'm the Executive Director of Tri-County Behavioral Health Care. We're the local mental health authority that serves Montgomery, Walker, and Liberty counties. In some conversations with Senator Nichols' office this morning, I wanted to just highlight a bit about our connection with the TMHCC, and specifically their child psychiatry program. UT Health Houston has contacted us, and we're one of those 13 organizations that will be transitioning to having third and fourth year child psychiatry students at our facility. Actually, I think they'll be doing most of it via telehealth under supervision from the university. And that process started just a couple months ago, and we expect to have those students on site in the fall. We are also partnering with several other organizations, including Sam Houston State University's new Director of Osteopathic Medicine School, and some rotation site for the FQHC internist students, several nursing programs, and others. What excites us about that opportunity is that we know a certain percentage of these folks will, whether they like it or not, be hooked by community mental health. And there's desperate need for more folks who find what we do every day interesting and enjoyable. This need is really amplified in our child and youth area. We have had more kids in crisis seen this year in the 9 months of our FY than we did all of last year or the year before that. And at the same time, our outpatient services have grown substantially. The kids are more complex. They're coming in younger. They're suicidal. They have self-interest behaviors, anxiety, and depression. Our challenge is workforce, as you've heard over and over again today, so I won't belabor the point. For us, I thought we were doing terrible. We're at 27.5% vacancy. I assure you it feels awful. The key, though, is that, thank you for your time.
Go ahead and finish up, wrap it up.
Yeah, so the key is just that the employees that we're missing are in the same core group of bachelor's and master's level staff that provide really the engine, our day-to-day work with these kids and our adults as well. And we're missing a large number of those folks.
When you say you have 27% vacant, did you say vacancy?
Vacancy.
Is that in workforce or is that in beds?
No, that's 27.5% of our positions are vacant currently.
Positions vacant? Got it. Hard to fill the positions.
Yes, sir.
Yeah, that's on our list.
It's on your list.
All right, thank you. Thank both of you for coming and testifying today. Very meaningful. Okay, next up is Bradley Hodges. And Jason Sabot, Children at Risk, Texas. Are you Jason?
Yes, sir.
Okay. Is Bradley Hodges here? Then next up will be, looks like Jennifer Fleck, F-L-E-C-K. Anyway, please state your name for the record. And
Mr. Chairman, members, thank you for the opportunity to speak. It's nice to see many of you. I also would like to thank the Lieutenant Governor and the Chairman specifically for allowing public comment at today's hearing. It is appreciated. I'm today representing an organization called Children at Risk and a project that it has called the Texas Family Leadership Council. I often come to this building and speak on behalf of child advocacy organizations. Today I'm speaking specifically on behalf of direct service nonprofit providers, the folks in your district who run the food banks, the folks in your district who run the child care centers, the folks in your district who run the after-school programs. They are very concerned about what's happening. They're very concerned that school violence will spill over from public schools into child care centers. They're very concerned that domestic terrorists won't just go to our Walmarts and will begin to go to our food banks. And from my perspective, these do seem like reasonable concerns for many of these organizations who are dealing with some of the most intense issues and communities and families in our state to be confronted with on a daily basis. They offer three to Senators Birdwell and Zaffarini's concerns, three specific recommendations for what Texas can do to improve and respond to this tragedy. Number one, invest in school-based mental health. Y'all have done a lot in the last couple of years, in the last more than a couple of years, to invest in mental health. It's a down payment. We can and do more. If you look at how school districts are asking to spend that federal ESSER dollars right now in this third round, they want to spend it on mental health. There is a need out there. Let's provide the resources necessary to meet that need. Secondly, let's expand the social safety net. I spent a lot of time in rural Texas. Gun violence in this state is not an urban issue. I was in Borger, I was in El Paso, I'm everywhere in this state. Gun violence is as much a rural issue as it is an urban issue. And finally, we can do things to implement gun safety. We can do things bipartisan. This legislature, just last session, chose to regulate whether or not 18, 19, and 20-year-olds are allowed to openly carry firearms. There is precedent for regulating the possession of firearms based upon age, based upon the votes that many of the members of this committee themselves have made. Thank you. I'm happy to answer any questions you might have.
all right, thank you, sir. I did not see any questions. Thank you for your testimony and taking the time to be here. Next up is Sheila Hemphill, Texas Right to Know. Sheila, are you here? Up high in the corner?
No, right there.
Oh, come on over, Sheila. All right, and then also we have a Margie Barilla, B-A-R-I-L-L-A, Elevate Healthcare. Are you here as well? Ah, great.
You want to go ahead?
So whichever one of you is ready to go.
Go ahead. Okay.
Good afternoon. Thanks for having me. I had to zoom up here, about 3 hours. However, I'm so excited because
Please state your name for the record.
Margie Barilla with Elevate Healthcare. We are an outpatient mental health hospital that was established January 2019 in North Texas. We opened up our first location in Mesquite, Texas, and to date we have established 15 outpatient mental health hospitals. We serve ages 5 to 17. Our current clientele we actually serve is dealing with anxiety, depression, suicide ideation, and homicide ideation as well. We have served well over 25,000 clients since January 2019, and we continue to work with the communities as well as all the hospital systems in regards to providing free mental health screenings. The 2 points that I wanted to make today was the assistance for us to push optional mental health screenings prior to starting school. Of course, with the consent of the parents, we're able to initiate that. And second, to be able to get additional support in regards to how the insurances are handling denials, timely reimbursements, as well as refusing to provide authorization, especially if they had a discharging diagnosis and then having similar or the exact same diagnosis upon admission. Today, I ask that if we can collaborate more as we are traveling. Oh, thank you. Do you have any questions? Keep going. So I wanted to come here to share with y'all, I have a solution. It's been working since January 2019. That is duplicable, not just within our state, but throughout the U.S. It's worked, it's robust, we are 100% EMR system, and we have numbers to show that our documentation is most effective upon early intervention and prevention.
All right, thank you very much. Sheila?
Yes, sir.
Please state your name for the record.
Yes, sir. My name is Sheila Hemphill with Texas Right to Know. I would draw your attention to the paper handout, which therefore let it be resolved in support of laws requiring toxicology reports to evaluate for physical root causes that result in psychosis, and the data should be available to the public. With that, I would like to direct your attention to the poster. I made this after listening to a few hours this morning, and I know this committee is looking for solutions. I personally have had 5 manic attacks in my life, 3 hospitalizations. I have been the victim of what I would consider medical abuse. If you go into a facility and you're in there the exact amount of time that you have insurance to cover it, even though you were fine weeks ahead, I call that somewhat medical abuse. The only time I ever experienced homicidal or suicidal ideation was when I was on the prescribed medication. That was in August of 1990. My second relapse was within a few months, so I was diagnosed a certain kind of manic, could never get off medication, and I relapsed. And on that one, the medication they sent me home for Easter, I had to be escorted around, and my head hung and I drooled. Now, it's tough to tell those stories because it creates PTSD. And I'm having a hard time today, so I thank you for your patience. When you're sitting here contemplating what kind of mental health you're going to offer, especially children, until you have been through this system, you have no idea what it's like to be checked into a psych ward. I could take anyone in this situation, but rather than belaboring that with the few minutes I have, there are some suggestions here of viable therapies that if they're known about, they can be pursued.
Mr. Chair.
Go ahead and close up.
Thank you, sir. Mental health is physical. In my manic states, I have done the pendulum of losing all sense of feeling. Smell, taste, hunger, sleep, gone. I have also swung the pendulum where everything is so intense like I am today that the lighting, the words, the crackle, the paper is just very stimulating. I'm overstimulated right now. I came back from the Republican convention. Does that tell you anything? Okay. So on this, you will see swelling before and after a pulse electromagnetic device that you just lay on. Down here, you will see a 23-year-old diagnosed scoliosis, in pain, would need surgery. Within 45 minutes of using this technology, is able to reassess the brain to the muscles, and she has 2 shoulder blades.
Okay, I appreciate. I was asking you to go ahead and give you an opportunity to close out.
Oh,
but
okay,
not
sorry.
Just continue on. Senator Perry.
Mr. Chairman, I appreciate it. And Sheila, it's always good to see you. And I appreciate your honesty and courage of willing to have a conversation. Can I ask, you're not currently on any more medication?
No, sir. I have not been for 30 years.
30
but
years.
I have techniques and I have tools, and this one's a huge one.
Right. And so I asked that, and I think we're spot on that we don't do a very good job of a more holistic look when we're talking about symptoms and issues. I've seen this paperwork of this individual kiddo where you show the differences with with really just nutrition and some other things, that he was heavily dosed.
Not only that, but it's lead, it's fungus, it's these things in our environment that we're not looking for. And I had this at the 2018 convention, and I had teachers coming up to the chaos handwriting saying that's what's in my classroom.
Right. So can you give us your credentials? What's your educational background?
My formal degree is in computer science. I taught computer science at Angelo State for 4 years, and I taught public school for 4 months.
Okay.
And that's when I had my first episode.
Bioscience, though, do you have
Sir?
medical or bioscience? Do you have that background? Medical or bioscience? Do you have some of that?
I've had the privilege of falling apart physically and rebuilding it with brilliant practitioners, and so I do their web development.
Well, you're a stalwart person of conviction, that you always show up and you keep talking about things that are relevant to our conversations, although maybe not traditional. I think that we need to further expand our opportunities about talking some of these other remedies rather than just going to pharmaceuticals. And I think
there's a place for pharmaceuticals.
There's a network of providers out there in my area, actually.
But 1 in 6 children are on mood-altering drugs. Adderall and Ritalin, the diagnosis is based upon observations. There's 9 different factors. If a kid gets 6, twiddle their fingers, moves around in their chairs, answers too quickly, get 6 of them, congratulations, you're ADD, here's your Adderall, which is amphetamines.
I appreciate you being here. Thank you.
All right, thank you all both very much for coming, and
Thank you.
appreciate spending the day with us.
Thank you.
I've got 3 names I'm going to call one last time. Bradley Hodges, Paulina Vidal Herrera, all children, Texas, and Jennifer Fleck. I'm not, last chance, so they were called. Members, there's a little bit of housekeeping here. I've got a stack of witnesses who wanted to be shown on the record as being here but not wishing to testify. Are there any objections to us just entering those in the record? Hearing none, so ordered. That wasn't very loud. Now, I'm going to recess in a second, which we may not be meeting again, but just in case we might need to, I'm just going to recess. But what I'm going to be asking my staff to do is, we began working on some of these ideas as we read and talked to witnesses before the hearings. And then during the hearings, as conversations came up, we've been adding things to our office list. I would ask that y'all put your office list together as well and break it down by categories, the mental health, the school, and so on. Anyway, the 5 categories. And then and mark those as work in progress, working documents. And then at some point, ask you all to share those with my office so we can try to collate a bigger list and incorporate the other things that are not on the list we put together. And then what I will try to do, maybe on a member-by-member basis or possibly a chief-by-chief basis, is go around and work with each of you and see which ones do you all strongly support, which ones do you kind of support, which ones can you not support, and so on. As a working document, will not be privy to open, and we'll see where we go from there. I think that'll tell us a lot of stuff. Okay, so I just want to make sure that y'all had an idea of what we want to do, as well as any public watching. Bob Hall, Senator Hall, appreciate you being here today. Yeah, and if you've got some ideas you would like to incorporate them, share them with my office. Same thing, there were some other members here the last couple of days. With that, we're going to recess, call of the chair. And drive safely. It's dangerous out there.